Good morning and
To
welcome
take you through the scientific feast, I welcome and hand over to Dr. Krishna Kumar.
Good morning, greetings and welcome to all the delegates joining in for the 5th Annual National Conference of FeFCon Foundation FeFCon 2022. We are starting our day 2 session after the breakfast session on antibiotics. Welcome all the delegates to the pediatrics hall here, and also you can view the other sessions in physicians hall A as well. And also we have the poster all session running through on the platform. You can also view through the posters. PG posters, we had been more than 150 posters coming in from internal medicine and pediatrics poster that's being displayed in the poster hall. Without wasting much time, we have the faculty for today with our organizing chairperson, Dr. Jagdish Sinappa sir, as a key person here joining in today. And also we have Dr. Ravishankar Marpalli. Can I have the slides of Dr. Ravishankar Marpalli, please? He is the head of pediatrics at Spurs Hospital, Bangalore. He'll be the chairperson for today's session. And also I welcome Dr. Jagdish Sinappa sir to do the opening remarks and start the sessions, please.
Welcome everybody to the second day of this fantastic FeFCon 2022. And this is the pediatric segment which we are starting now. And we are starting with a very exciting session, which is going to be chaired by Dr. Ravishankar Marpalli. So Dr. Ravishankar will do the introduction of the faculty and we will straight away start off the sessions. So Dr. Ravi, over to you.
Yeah, thank you. Thank you, Jagdish.
Yeah, can I have the slides, please? Dr. Vikram Kumar's slides, please.
You want to share the screen?
Yes,
this one?
Backend team?
CV? Yeah.
Ria?
Dr. Vikram Sakleshwar Kumar. So he's a very good friend of mine. Almost it's something like my younger brother to me. Always highly academic. Anytime, any paper, any research paper you ask him, within 5 minutes, it will be on our WhatsApp or in our email. Always a highly academic person and very much interested in teaching. And he's the professor at Subbaya Institute of Medical Sciences and also a DNB teacher at Sarji Maternal Child Hospital. Last year, I came to know that all his DNB students had got passed in the first attempt itself. Such a fantastic way he teaches the things. Now he's going to speak on fever, the global, that is the global warming and fever, how the global warming is going to affect the infections and our biosphere. So he'll be speaking on that one. Over to you, Vikram.
Thank you so much, sir. So I'll share my screen. Okay, so is it visible now?
Yeah. Make it a presentation mode.
Yeah. Do it, yeah. So thank you so much, Ravi sir. Thanks so much for the FeFCon organizers, especially
before starting, yeah. Vikram, I'm just interrupting. Yeah. Dr. Basaraj is here, yes, so we'll just invite him, please.
Okay. Sir, please go ahead, sir. I am in flight.
Thank you, Basav.
Yes, sir.
Vikram, you can continue. Sorry for the interruption.
Okay. No problem. Thank you so much. Thank you so much, sir. Thank you so much, FeFCon organizers, especially Dr. Manjula and Dr. Jagdish. It's a privilege. Dr. Krishna Kumar, thank you so much for this opportunity and chance. So, this was a very interesting topic given to me for 10 minutes. Only in the last 1 week or so, I realized the magnitude of problem that we are dealing with. Thank you so much. So I would begin my introduction. So the topic was global warming and fever. I have nothing to disclose because I have, I'm not an ecologist or an epidemiologist. I'm just a person who's interested in reviewing the latest article. So I thought I'll just go through with this article. So what is the link between climate challenge or climate change, global warming and fever? A failure to slow global warming is providing many deadly diseases with its ever expanding reach, especially the vector-borne diseases. So to the extent that climate change is brewing as a bona fide public health emergency is what the World Economic Forum has come out with. So let's do a very quick short review of this amazing article, which came out just about a month ago. It's a brand new paper from the team of University of Hawaii. Fortunately, I had one of my very good Twitter friends who was their health consultant, and he shared this paper, and I had a very good discussion with him about this paper. And many of us know, or we have known for a long time, the many pathways through which climate affects our health. But this group conducted a systematic review, and to really dive in and to look at the literature, they looked at these 10 different aspects related to climate change, the most important being global warming, which is the base of the pyramid for all the problems now, most of the problems that we are encountering. Apart from that, they also looked into global warming leading to problems in oceans, change in the sea surface temperature, so on and so forth. So these were the physical attributes that they looked into in the systematic review. And this is a very, very busy slide that this team essentially found over an amazing 1,000 unique pathways through which climate affects, especially global warming affects our health, causes altered dynamics in human pathogens. As you all can see, the most common is the vector-borne disease, which is directly affected by the global warming, followed by waterborne. And they also found it's not just infectious disease, rather mostly infectious disease, but also some non-infectious communicable diseases like raised incidence or raised probably at higher risk of developing rheumatological and immunological diseases across the world in the coming decades. So they found the connections across 1,006 pathways after searching around 77,000 papers. So they found out that almost 58 to 60% of all the infectious diseases and other human pathogens were directly related to global warming, climate change associated. And because it is vector-borne disease that they found out to be the most commonly affected increase in the coming decades, it boils down to mosquitoes and ticks. And I'm sure there are differences between us and ticks or flies, mosquitoes, that we don't fly, and I'm sure none of us in the audience suck blood. But mosquitoes are cold-blooded, and so its body temperature is that of its surroundings. Shift in the temperature can make a world of difference in the transmission dynamics for vector-borne diseases. And here in India, we're already seeing, or we've seen more than average rainfall that we did in the last 50 to 100 years. So we are getting much more flashier as far as heavy rainfall and water contamination, vector-borne diseases, and airborne diseases. I would like to introduce you to this screenshot. I mean, you can all take the screenshot of this amazing website. You know, you get to see an interactive display of these 1,006 different pathways. If you just click on this URL, you will be directly, or rather you'll be redirected to this interactive display wherein you have 1,006 different pathways. And so if you go on that link, you can click on any of these little spaghetti noodle kind of pathway, and you can see a full display of different diseases, probably their vectors, and also the papers that are published, everything related to that. I spent around 1 hour on this and really was mind boggled to see the connection between the underlying global warming, climate change, and its manifestations in the form of increased diseases. So what have I observed locally? I'm sure many of you can endorse this opinion. I mean, for me, because I stay in a region called Malnad, we have seen, for instance, monkey fever, which is Casanova forest disease, was rare and was affecting only those who interacted with animals, especially the forest dwellers. But monkeys are now forced to move into the human settlements, exposing an entire community to infection, and we've seen that happening. And because, given the fact that we don't really have good data coming up from the government sources, so we don't really know the magnitude, but I'm sure KFD has increased in the last 5-6 years. And scrub typhus, tick bite fever, I'm sure all of us have seen this happening. Most of our general wards, infectious disease wards, and also ICUs are filled with children who have scrub typhus. I don't even want to speak about dengue, because all of us have seen a lot of dengue because of various global climate challenges. And I tried to search for quite a bit for Indian articles on the effect of climate change or global warming on the prevalence or epidemiology of infectious diseases. But believe me, I couldn't find even a single, I mean, not many good substantiated articles, good peer-reviewed articles. So anyways, I just came across this article by a team from BHU, Banaras Hindu University, where they found out, especially in kids, that 18% of infectious diseases, I mean, they had certain limitations, but around 18 to 25% of limitation, I mean, 18 to 25% of infectious diseases, especially respiratory infections, were directly attributable to global warming and underlying climate factors. I will just finish my talk by citing few anecdotes in the next 3 or 4 slides. The common, I mean, in the last 2-3 years that have come up big time, cholera is making a grand comeback. WHO states that it used to be limited to just 20 countries in the last 5 years, according to reports on an average. But this year it's already creating havoc, or rather created havoc, in more than 29 countries. The countries at the forefront have been that have been bearing the brunt are Syria, Malawi, Haiti, and also not to mention Yemen. And this is an interesting thing that I found out, that skin is directly affected by global warming, because it's the largest organ, and there can be a significant problem to the dermatological health, especially in a tropical country like India. There can be more abnormal colonization of bacteria that can lead to all sorts of problems in the form of impetigo, scabies, that can predispose to various invasive bacteriological infections. Another interesting thing wherein global warming directly affects the sleep. So research suggests that rising temperatures can disrupt sleep and blunt immune responses and make someone more predisposed to developing infectious diseases. Malaria and Vibrio. Vibrio, I mean non-cholera Vibrio. Studies have shown that there has been a significant increase, more than almost 40% increase in number of months suitable for malaria across the highland areas of world since 1950. And non-cholera Vibrio bacteria, again, the conducive environment has been there and has been ever increasing since 2011. Last is something that I came across called as Alaska pox. Now that we are used to listening to monkey pox, we are all used to chicken pox and kind of stuff. But Alaska pox again probably is going to pose a threat in the coming decades. It was confined to permafrost that was in Alaska. Because of rapid change in Arctic temperatures, there has been an increase in the population of vole. Vole is a kind of small rodent. So, and there has been a shift of the epidemiology of Alaska pox, and it has affected around 5 to 10 people in the last 2 years. Fortunately, none of them have been serious or dead. We'll have to wait and watch how it unfolds. There have been, of course, other looming threats. Typhoid, which was probably more commonly seen in Africa and Asia, has started spreading, and Europe, USA, and UK will have to be on their heels. Not to mention an already ongoing epidemic of Ebola and monkeypox, Ebola especially in the African countries, northern African countries, and also monkeypox across the world. The other real danger, real world danger would be rabies because of change in the forest and also change in the habitat. Wildlife carrying the rabies virus are now have more access to urban and human population. I'm sure Sukumaran sir would agree that there was a deadly Nipah virus epidemic, which was quite well controlled about 4 years ago. Listening to the way Indian government handled gave me goosebumps, because the secondary attack rate of Nipah virus was so high that amongst the 26 people or so who were infected, 22 died. And so these are certain looming threats. So I would just end with this take-home message that as healthcare providers, healthcare workers, I think we can start cleaning from our own homes. So we'll try to prioritize decarbonization in the health sector and global health practice. This is an amazing way adapted by FeFCon to go green, because the amount of carbon footprint that we leave by having physical conferences is mind-boggling if you do certain math and statistics. So this is an amazing initiative that you'll have taken, and thanks so much for this opportunity. I consider it as a privilege. Thank you so much.
Thank you, Vikram. Thank you for the nicely telling about the global warming, how it is going to affect us, the life of us, and the life of the microbes, how we are exposed to that one. The only thing is, any questions are there? No.
Ravi, you can take the questions at the end of the session.
At the end of the session. Thank you, Vikram.
Thank you so much.
You can stop sharing, Vikram.
Yeah, I'll stop. Yeah.
Then we welcome Dr. Yagnesh Popat for his next talk on the fever following vaccination. Can we put up his slide? Previous slide? Yeah. Yagnesh Popat was the chairperson of the IAP ID chapter last year. And he was very much interested in the IAP, and always involved in the infectious disease chapter of the IAP. And this is his CV, the president of IAP Gujarat 2006, president of IAP Rajkot 2004 and 5. Yes, very, very soft-spoken, both husband and wife. Whenever they meet, always holding their hands and welcoming us, very sober, soft, feel like very friendly with them. Such a nice person, Yagnesh Popat, he is. I welcome him to this conference and to speak on fever following vaccination. Over to you, Yagnesh.
Yeah, thank you, Ravi, for a nice words. I don't know whether I deserve it or not, but thank you very much. I enjoyed it very well. Is my screen visible now to everyone?
Yeah, correct, visible.
Good morning, all. Today we will be talking about the fever following vaccination, a somewhat new topic for anybody. In fact, if you search on the literature, you will not find any major article or the presentation on this topic. So this is the new topic, and I thank Dr. Jagdish Chinnappa and his team for allowing me to share my views on this new topic. How do we define the post-vaccination fever? There is no agreed definition of post-vaccination fever, but the gold standard definition of fever is the rectal temperature of more than 38 degrees centigrade or above following vaccination. Adverse events following immunizations are categorized into two different categories, major or the minor. The major could be serious or the severe one. The passive surveillance system of AEFI in United States have found a fever to be the most frequently reported non-serious AEFI for all age groups, with the exception of persons aged between 18 to 64 years, in whom the wide variety of local reactions are more frequently reported. So, fever being the one of the most common manifestation of minor AEFI. It is quite common to develop a fever after vaccination. This normally happens within 48 hours of vaccination and usually goes away within next 48 hours. This is an expected reaction. It is usually self-limiting without any specific complication. Then why we should worry about it, or why we should talk about it? Often fever are associated with illnesses, and therefore it is understandable that the parents have concerned that whether their child is suffering from fever is because of the post-vaccination or it is because of any other disease. So they would like to clarify. Second most important point is the febrile seizure. There are some children who are prone to have a febrile seizures, and the parents of such children are definitely worried and they do not want their child to have any episode of convulsion in lifetime. So whenever there is a fever, whether it is because of vaccination or because of an illness, they do not want it. So because of these two major reasons, they are worried about the post-vaccination fever. You will find less Indian studies on this topic, but there are a couple of studies from European countries who had looked at the various aspects of the post-vaccination fever, particularly the fever patterns, probability of fever after a particular vaccine, management of such fever, as well as the cost of having such post-vaccination fever. Majority of these studies have reported a fever frequency, but there are very few studies which has reported post-vaccination fever pattern. This is a busy slide with regards to the timing and frequency of fever after some of the common vaccines. Just look at the this red marks. Fever can happen from 1 to 17 days after hepatitis B vaccine, 0 to 7 days after pneumococcal vaccine, and as long as 42 days after chickenpox vaccination. In cases of multiple vaccines where the multiple antigens are used, like MMR, DPT, and others, the fever can be as after 14 days. And in case of DPT vaccination, fever occurs more frequently after the second dose. Why fever occurs in a post-vaccination phase? The vaccine prepares the immune system to protect against viruses or bacteria that could have made the child sick. The way this happens is that they introduce components of germs that are known to activate the immune response. However, vaccine will not cause any significant enough immune response that a person suffers to any untoward events such as that occurs following the natural infections. And with this said, in some cases, the immune response is strong enough to cause a detectable symptoms like mild fever. So does it mean that the vaccine is not working if there is no fever? Definitely not. Not everyone who responds to a vaccine will develop a fever. Post-vaccination fever is common after any vaccine. It can occur due to any vaccine, but the frequency of fever occurring within first 24 hours following vaccination is highest following DPT containing vaccines, and other vaccines that also cause fever in majority of the cases are pneumococcal vaccines and the measles containing vaccines. There are few important characteristics of post-vaccination fever. Fever usually starts within 24 hours, but it can occur as late as 42 days, usually mild, but can be high grade, especially after DPT containing vaccines. In interfebrile period, the child is comfortable. No other associated symptoms like cough, cold, diarrhea, headache, etc. And febrile period is usually short and self-limiting. Fever phobia. A post-vaccination fever phobia could lead to an unnecessary testing as well as treatment and emergency department visits. This increases both medical cost as well as the possibility of side effects. The post-vaccination fever has its own fever pattern, which is dependent on which is the vaccine which is used and use of antibiotic drugs. Hence, post-vaccination temperature monitoring may ease the fever phobia. Let us understand post-vaccination fever by a couple of cases. Case 1, 2.5-month-old girl from an urban slum presented in a monsoon season with a fever of 101 degree Fahrenheit since 1 day. There was history of vaccination with hexavalent vaccine before 1 day. What is your thought? Probably this is an post-vaccination period. Just observe the child. Next case. A 9-month-old child presented with fever of 2 days duration has undergone a vaccination with MMR before 3 days. Now, what is your thought? This is again fever starting after 24 hours of vaccination, could be because of measles vaccine, and so probably this is a post-vaccination fever. Case 3, a 5-year-old girl having a high-grade fever since 3 days, headache since 1 day, vomiting 3 to 4 days per day last night, feels weak, hasn't undergone a vaccination for 5-year booster before the start of the fever. Now, what is your thought? यहाँ कुछ तो गड़बड़ है. क्या गड़बड़ है? There are high-grade fever. There is high-grade fever associated with headache, vomiting, and feeling of weakness. So this couple of points towards some issues that the child might be sick. So such a child should be investigated and not just labeled as post-vaccination fever. How do we manage post-vaccination fever? As usual in case of any other fever, make the child comfortable, avoid hot environment, avoid excessive clothing, give plenty of liquids, and if required, do a tepid sponging. If the fever is high grade and the child is uncomfortable, use paracetamol for the fever, but do not give medication prior to vaccine or as a prophylactic immediately after vaccination. What are the economic implications? Whether caused by an intercurrent infection or immunization, fever after childhood immunization has an important economic implications with 2-fold increase in utilization of medical services and 3-fold increase in work loss for at least one parent. And as per one of the US studies, the parents reported willingness to pay a median of about $50 to avoid a fever after immunization. So there are economic issues related with the post-vaccination fever. So to conclude, although there are many aspects of societal, medical, economic, and epidemiological meaning of fever as an AEFI are still elusive, but it is still a common, generally benign clinical sign. The cost of potentially unnecessary clinical and diagnostic evaluation of a child with fever after immunization to be clearly offset by a risk of complication from disease that would have resulted had we no vaccination programs. So friends, always keep on reminding the patients that short period of discomfort is a whole lot better than a visit to an ICU. Thank you.
Thank you, Ignesh, sir. I love the last but one slide that parents are willing to pay $50. Maybe that is one of the reasons why many parents prefer the feverless, painless injection.
Yeah, that's so absolutely
maybe one of the reasons that we don't know, because
that is why pharma is always in search of such devices or the vaccines which are less painful.
So where immediately within a minute they fire in America, probably maybe paying $50 is safer than getting fired. Okay, thank you, Ignesh. So now we'll go to the next talk by Dr. Sukumaran TU. So when we were students, anything we wanted to know about respiratory, it is always we used to listen to Dr. Sukumaran and Dr. Parmesh. So the way they used to teach us with respect to the respiratory system and everything probably helped us in passing our exams and also doing a fine job in our practice. So respiratory means from Kerala, it is Sukumaran, he's coming. Okay, we know it about. That is the way it was equal with the respiratory system, Sukumaran means. So welcome you, sir.
Okay.
And your talk is on allergy and fever. So can we put up his slide, TV slide?
Okay.
Yeah. He was the past president of the IAP in the year 2011. And I think during that time, his workshop on allergic rhinitis, everything came up.
Oh,
It was a fantastic one, sir. Nicely, we enjoyed that one. Welcome you, sir, Sukumaran, sir.
okay.
He's the former professor and head of the Department of Pediatrics and IAP president 2011. Welcome you, sir. Over to you, sir.
Okay. Hey, Krishna, can you just show the slides now?
No, there is Anand. Yeah,
Okay.
previous one.
Okay.
No, drop the
You
slides.
close that?
Please. Close the slides, please. Stop sharing the slides.
Stop sharing the slide.
Shall you take the slides? Okay.
Yeah.
Yes, sir. It is coming.
Okay. Beloved Chairperson, Dr. Ravi, beloved Jagadish, Shinappa, and my beloved friends. It gives me great pleasure and privilege to be here with you to talk on allergy and fever. And as you all know, there are 4 or 5 common allergic disorders in children. The commonest being asthma. Then we have the allergic rhinitis, then atopic dermatitis, urticaria, angioedema, and food allergy. These are the common allergic disorders that we see. But our topic is on allergy and fever. And according to the American College of Allergy and Applied Immunology, they say that allergies don't cause fever. Allergies don't cause fever. And associated complications of allergic disorders, like other infections, can produce fever. For example, in a child with an allergic rhinitis, they can have associated sinusitis, and this can present with fever. So allergies per se, fever is not a usual manifestation of allergic disease. I think, Krishna, can you just change the slides? The slides are not moving. Krishna?
Team
I
there.
think he's doing
Yeah.
it.
Yeah.
Vinay. RX Steven. Move the slides, please.
Sir, tap the enter bar.
This
Sir,
one.
enter
Maybe-
the bar, Sukumaran, sir. Enter the
Yeah.
bar.
The center
just
big bar.
Just enter the
Space-
enter.
Yeah,
That is
space
also
bar
possible.
or space bar, you can, or enter button.
It is not moving.
Sir, I'll share it for you, sir.
Yeah, please do that. Okay.
No, you stop sharing, sir.
Okay, then coming to the asthma and fever, I know asthma is a common clinical diagnosis. A child presenting with more than 3 episodes of wheezing per year, and if the wheezing is reversed with a bronchodilator, you can make
Backend
a
team,
clinical
stop
diagnosis
sharing,
of
please.
asthma
Take it
in
out.
children
Sir,
about
sharing.
5 years. But in those children less than 5 years, it is called an under 5 years. Under 5 years comes under 2 groups, depending on the symptoms. It can be an episodic viral wheeze, or it can be a multi-trigger wheeze. Episodic viral wheeze, as name suggests, is associated with fever. Any child less than 5 years presenting with recurrent episodes of fever without a family history of asthma or atopy, it is called under 5 years, and these children are asymptomatic in between the episodes. And the child is asymptomatic in between the episodes. And the commonest viruses that produce episodic viral wheeze are, one is rhinovirus, Broca virus, human metapneumovirus, influenza virus, and parainfluenza virus can produce fever. But it is associated infection that can produce fever, and not asthma itself can produce fever. So how will you manage these children? You can manage these children. The main thing is that you give a nebulized salbutamol for acute management, and long-term management,
depending on the severity of the disease. If a child is having a very severe disease, then very frequent attacks of wheezing, more than 3 episodes per year, these children can be given a long-term prophylactic drug, either montelukast or inhaled corticosteroids. You can have a trial with inhaled corticosteroid, budesonide up to 400 micrograms per day, and it can be given for a period of 6 weeks, and you can see the response. The second condition is allergic rhinitis. Coming to allergic rhinitis is a very common disease that we see in children. And our own study from Kottayam district shows that more than 40% of children has got allergic rhinitis. And allergic rhinitis as such will not produce fever, but the complication of allergic rhinitis, like allergic sinusitis, can present with fever. Even though it is called hay fever, fever is not seen in these children. Can I share now?
Yes, sir, you can share, sir.
Okay.
Go to the presentation mode, or whatever the slide, which slide, and there you click there, and from there you can start the presentation mode.
Okay, right. Thank you.
Okay.
Now, coming to allergic rhinitis, these children will have mainly 4 symptoms. A child presented with a sneezing, nasal block, nasal itching, and nasal discharge. Among these four symptoms, if more than 2 symptoms are present for more than 2 hours per day for a period of 2 weeks, you can make a diagnosis of allergic rhinitis. Now, this is the classification of allergic rhinitis. ARIA classification depends on the duration of illness. Duration of illness can be intermittent allergic rhinitis or persistent. And depending on severity, it can be mild, moderate to severe. So a child can have mild intermittent allergic rhinitis, mild persistent allergic rhinitis, or a child can have intermittent mild allergic rhinitis, persistent moderate severe allergic rhinitis. But fever is not common. But these children can develop sinusitis. It can also present with fever. These are the common symptoms of allergic rhinitis: running nose, sneezing, lacrimation, headache, rash, cough, and periorbital edema can be there. And what is the management? Just like DINA guidelines for asthma, there's ARIA guidelines is there. There's a step-up management of allergic rhinitis is there. You can start with the second generation antihistamines, or you can try intranasal steroids, and lastly, immunotherapy. Coming to the third problem, atopic eczema. Again, I want to highlight that fever is not a common presentation of atopic eczema. These children will present with the rash mainly on the face by second month of life. And as the child grows, they will develop flexural dermatitis. But this atopic dermatitis can get infected with organisms like staphylococci. Then these children will present with fever. So the treatment is you can have an moisturizing skin moisturizers. Then you can have steroid ointment. And if you suspect a staphylococcal infection, you can have anti-staphylococcal dust can be given. Coming to the fourth problem, food allergy and fever. Food allergy usually will not produce fever. The main symptoms of food allergy include wheezing, skin infections like hives, swelling and itching, watery and itching eyes, running nose, burning sensations in the lips and mouth, and they can rarely present with anaphylaxis. The common trigger factors include milk, nuts, eggs, wheat, fish, and shrimp, crabs, etc. But even though this child can present with allergic manifestation, fever is not commonly seen in these children. Coming to other skin manifestation of allergy, these children have urticaria or angioedema. In children with urticaria, when they are presented with an acute episode, they can have fever, and as the rash disappears, the fever also subsides. And the treatment is mainly a second generation antihistamines and a short course of steroid can be given. So to conclude this talk, what I want to highlight is that allergies usually will not produce fever. Only complications of allergy, like allergic rhinitis presented with sinusitis, or a skin infection associated with atopic dermatitis can produce fever. I once again thank the organizers, especially Dr. Jagadish, Dr. Manjula, Mr. Jairaj, for giving this opportunity. Thank you very much. Thank you.
Thank you, Sukurman, sir. So it is a nice statement. Allergy will not cause fever, but the secondary complication that can raise to fever is the one point we have to note about it. So that is a very good point. So that is the way the teacher teaches to his students from my practical point. Thank you a lot, sir. So questions can be asked later. So now I welcome Dr. Anand Vasdev. So he was with me in the IAP EB. He was the OB when I was the EB during that time. I used to call him as Vasu. So he used to tell, you are the only person you are calling me as Vasu, whereas everybody calls me Anand. Why you like Vasu? Then I told my elder brother name is Vasu. That's the reason he immediately remember. So he's very nice gentleman, always cooperative, friendly. And at present, he is the senior consultant and pediatric nephrologist at Apollo Hospital and Max Hospital, New Delhi. And you're the national vice president of the CAP in 2020. Welcome you, sir. He'll be talking on fever and UTI.
Thank you. Thank you very much, Dr. Ravi. And also thanks to all the organizing team, especially Dr. Jagdish, Dr. Manjula, for inviting me for this talk. Can I share my screen?
Yeah, sure.
Please.
Please do. Go ahead.
You see the full screen?
Yeah.
Fine. Thank you. So, as already highlighted by Dr. Ravi, the topic given to me is fever and UTI. And I was putting a question, how dangerous is it? Why are we talking about fever and UTI? So let us see what are the implications and why do we need to get concerned about it. Urinary tract infection, I'll call it as UTI in short form, is a very common bacterial infection, we all know. And it was surprising to me also when I came to know that it is second only to the respiratory tract infections. And we see day in and day out respiratory tract infections in our practice, whether OPD or IPD. And if we are not seeing so many UTIs, probably we are missing a lot of urinary tract infections. And the diagnosis is often missed because the symptoms are very non-specific. And what is the risk? The risk is of the scarring. 15% of the urinary tract infection may end up with scarring of the kidneys, and that is the main danger why we are concerned about it. Now, a few learning points that the urinary tract infection can be present apart from other than the fever. So many other, there can be other presentations like failure to thrive, common presentations like dysuria, frequency, unexplained vomiting, diarrhea. In newborns, it can be presenting as hypothermia or jaundice. And fever without focus is one thing where we should always keep urinary tract infection as the underlying cause. If the fever is not settling, if it's not a common cause like viral for 3 days or so, we should think about urinary tract infection when fever is present. I'll start with a case which is a very learning case for all of us. This is a 10-year-old child. Just give me a second. This is a 10-year-old girl who was evaluated for short stature because she was shorter than her 8-year-old brother. And the family realized that the girl is not growing while the boy is already outgrown the girl. So the child was taken to an endocrinologist, pediatrician first, who referred to an endocrinologist for short stature. Her height was less than 3rd centile, but what was noticed was her blood pressure was on the higher side, 160 by 100. So that alarmed the endocrinologist, and he got some other investigations done to see what is going on. And to his utter surprise, the blood urea was taken to be high, the serum creatinine was 2.5, and he was really disturbed. He referred the patient to our unit in nephrology, and the simple test, when we did an ultrasound, the ultrasound showed bilateral contracted kidneys. There was loss of corticomedullary differentiation, and we were more or less very clear that what we are dealing with, there was an MCO was done. There was a bilateral reflux in this child, and a DMSA scan was showing both the kidneys had scarred. So now what had happened? Retrospectively now, once we realized she had multiple episodes of fever, which were possibly urinary tract infections, which were haphazardly treated and not evaluated properly. So what this led to was resulted in the chronic kidney disease because of the scarred kidneys, deranged kidney functions due to irreversible kidney damage and hypertension. So my dear friends, the learning point here is that this child had recurrent fevers, which were treated with multiple courses of antibiotics, but not properly evaluated, and ultimately led to the renal damage and irreversible damage. And it was very difficult, hard for us to convince the parents that the child already has damaged kidneys, and what has been missed. But they were like very, very aggressive and very unhappy why the pediatricians could not pick up these things earlier. So I think this is the learning point. So once we think of urinary tract infection, the initial evaluation, as for any other child, a general physical examination. But here I want to highlight that the blood pressure, and that too with a proper size cuff, should always be taken in any child where you are suspecting renal problem. Then other investigations, like we would send a urine examination routine and a culture, a CBC and kidney function test, and blood culture in infants and very sick children would be required. Some of the things which often get missed apart from the general physical examination, we are not in the habit of derobing or removing the undergarments and seeing, and we should not be missing on things like phimosis and vulval synecdoche or labial adhesions, which can lead to recurrent urinary tract infections and fevers, and ultimately they can damage the child's health also. Now, once we are suspecting urinary tract infection, we, as I said, have to send urine examination. And the routine urine examination is never a substitute for a culture. We would always send the culture along. But in the routine examination, we can look for leukocyturia, that is the WBCs, which are often mislabeled as pus cells. And mostly the centrifuge specimen is taken. And if there are more than 5 WBCs per high power field, along with the other two very good enzymes, which are mostly done in most of the labs now, are the leukocyte esterase and nitrite. So these investigations have to be done in the initial go. And mind you, if the child has some symptoms pertaining to UTI with more than 5 WBCs, with both these enzymes present, we are more or less dealing with UTI. And as a presumptive diagnosis, you can start the antibiotics if required, awaiting the culture report. Now, for the culture, it's very important that we must always educate the mothers how culture can be taken. One is the urine bag, which has got a very high false positive result, so not recommended. The commonest is the clean catch midstream, which is most widely used, but there's a risk of contamination, and we must always tell them how to collect the urine. And this is a day in and day out problem which I face in my practice, that they come with a report. Yesterday only a child came with a urine culture report of pseudomonas, and the child was looking so well. I hardly believed that this could be pseudomonas. So I told them that how have you collected the urine? And they said, we just asked the child, 10-year-old child, to go in the bathroom and bring some urine, that we gave it for culture. But that is not acceptable. The private parts have to be cleaned with plain water. I always emphasize no soap or no antiseptics, only with plain water. Clean the genitalia, then ask the child to start passing the urine and collect a midstream urine. It's not a difficult thing to do that in a toilet trained child. So be cautious about the precautions. Then sometimes we need catheter samples, and sometimes suprapubic punctures are required if it's difficult case and admitted case. But again, transportation and storage is important. The plating of the urine culture should be done as soon as possible and within a couple of hours. If it cannot be done, suppose the child has come at middle of the night with high fever, you are suspecting UTI, you want to start antibiotics, take the urine culture properly and store in refrigerator at 4 degrees till you can send it to the lab in next few hours. Now, once you have thought of UTI, you have sent the urine for routine and culture, and you are awaiting the results. If case it's a simple urinary tract infection with low-grade fever, with dysuria, urgency or frequency, you can start with oral therapy and some of the good drugs. And first UTI are the cotrimoxazole, cephalexin or amoxiclav. And third generation cephalosporins I would reserve only in children who have got recurrent UTI or sometimes resistant bacteria which come after the culture report. Symptoms usually should subside in 48 to 72 hours, and duration of therapy should not be anything less than 7 days. And in sometimes younger children, we might require up to 10 days also. But our main concern comes when this is a complicated UTI, with high-grade fever, toxicity, vomiting, renal angle tenderness, and the creatinine is also high, or if it is a neonate, that is the main concern we have, because these are the children where there can be high fever and renal damage. So we have to treat them like sepsis with parenteral antibiotics. And to start with, before the culture report, we can start with third generation cephalosporin. And if it is working well, the fever has come down in next 24 to 48 hours, we can continue with it. Or else, if the culture report or different shows a different antibiotic sensitivity and the fever is not settling, we can change it. Once we have started on antibiotic and the child is responding, do give a full course of 10 to 14 days. I would err on the higher side and give out for 14 days in very young children and especially newborns. And again, if the response is not quick, we should change the therapy rather than continuing with the same therapy. Other treatment protocols which we follow along with the antibiotics are a good hydration, oral or IV, depending on the child. Again, emphasizing that alkalization of urine is not required. We see so many prescriptions where Alkazol and other alkalizers are being given along with the antibiotics, but with the good antibiotics and all these newer antibiotics, alkalization is not required. For fever, please stick to paracetamol and only paracetamol. Avoid NSAIDs because these kidneys are already on the brink of damage, and NSAIDs can again further damage these kidneys. Repeat urine cultures, I would emphasize, are not required at the end of the treatment unless the fever and toxicity is persisting beyond 72 hours. So we should shun that habit of getting repeat cultures after 5 to 7 days of treatment. We may get some of the bacteria are still persisting, which are of no consequence, and we end up adding another antibiotic and further medications are added unnecessarily. Now, once we have treated the child with antibiotics, our role does not end here as pediatrician. We have to investigate the child, why the child got UTI in the first go. And some of the investigations which would be required is the renal bladder ultrasound, and sometimes an MCOG or VCOG, and occasionally a DMSA scan. So we would know which imaging is required in a particular child. And people are normally sometimes afraid of VCOG, but it is one of the very good investigations if required. Gives us an excellent information about the anatomical things like refluxes, different grades of refluxes, about the posterior urethral valve, about the bladder condition, and about the other sometimes anatomical conditions where recurrent UTIs are there. So let us not get hesitated by not doing MCU if it is required. Again, DMSA scan is required in these children who have got first time or recurrent UTIs. And this is how the normal kidneys look like in DMSA, very regular. This is the kidney with scarring here. And these are both the kidneys, irregular margin with photopenic areas, bilateral scarring here. So this is one of the very good investigation which can give us idea about the scarring in the kidneys if it is going on, and then further precautions. Now, which investigation to do in which child is very important. And if you can take a picture of this slide, I think our job will be done. In children below 1 year of age, either sex, boy or a girl, we have to do all three investigations, a renal bladder ultrasound, a VCUG, and a DMSA. In child between 1 to 5 years, we do a ultrasound and do a DMSA scan. And if either of them is abnormal, then we go on for little invasive test of VCUG. But in a child who is over 5 years of age, trust me, just get an ultrasound done. If there is an abnormality, then you go in for VCUG or DMSA, because after 5 years of age, the kidneys are not going to get scarred now. And it is not, even if the reflux is present, the kidneys are not going to get damaged. But my worry is, as a pediatrician, what you will get is the children with recurrent UTIs who have taken multiple courses of antibiotics. And these are the children where all three investigations are required. So I think this is the slide which is the crux of the imaging in urinary tract infection. And if you can stick to these guidelines, you will not err. Now, other precautions which we have to take for prevention of recurrent UTI, we all know increasing the fluids. Precaution in cleaning the perineal area, especially in girls, is very important. Avoiding constipation is very, very important. almost 30% of children who have constipation will go into UTI and vice versa. Circumcision in some of these boys with high-grade refluxes may be required. Again, tub bath to avoid any contamination of the water with fecal matter in younger children. Diapers, I'm not against diapers, but the way the diapers are used in our hot and humid climate in India, they are not like Westerners where the climate is good. So the use of diaper has to be very, very cautious. Unless it is done, then we end up with recurrent infections, especially in girl children. Prophylaxis again is required in some of these children where there are recurrent urinary tract infections. Now coming to the last slide, for UTI and fever, we must have a high index of suspicion for UTI whenever there is fever. Febrile UTIs carry high risk of renal damage. So always think of UTI when the fever is persistent. Urine cultures should be taken in a proper way of collection. Unless we do it, we will land up with false positive urine cultures and give antibiotics endlessly to these children. Simple UTI, treat with simple drugs. Do not jump onto third generation cephalosporins or IV antibiotics. Use a proper protocol of imaging to not to miss any of these children with scarring. And prophylaxis for recurrent UTI and VUR, we are still advocating. Though the guidelines are changing now, we'll come up with new guidelines maybe by January or so. But till that time, we are using prophylaxis in certain children with recurrent UTI and VUR. Thank you very much for your patient hearing, and I can stop sharing these slides.
Thank you, Anand.
Thank you. Yeah, I can.
So if there are any questions, can we go ahead, Krishna? If any questions are there?
Yes, so there were a couple of questions.
Yeah.
One question was for Dr. On the first session, sir, to Dr. Vikram. People were asking, can he share the website ID where they can find the details? He was telling on the hyperlink, they were not able
Yeah.
to click the photo. They are asking to
Yeah,
put in the
I'll
chat
do it.
box. Put in
That
the
he will
chat
do that.
window, sir. Yeah.
Next
do it.
question. Krishna, next question.
Yes, the next question is for Dr. Sukumaran, sir. What are the newer drugs for allergy and what are the allergy tests in pediatric practice?
See, coming to the newer drugs for treatment of asthma, resistant asthma, I think you can try biologicals, IgE inhibitors like omalizumab, mepolizumab, bendalizumab, dupilumab. These are some of the newer maps that is available. Then other thing is that according to GINA guidelines in category in step 5 or step 4, you can use anticholinergic drugs like tiotropium bromide can be tried. Then coming to antihistamines, some of the newer antihistamines are coming up now. Especially belastin has come. Belastin can be given in children above 6 years. You can use this. And coming to the antihistamines, it is always better to use a second generation antihistamine. Second generation non-sedating antihistamine should be used for long time. The main problem with the first generation antihistamine is that it can produce sedation, cognitive dysfunction, can be there, dryness of the mouth can be there. So it is always better to go for a second generation antihistamines like cetirizine, levocetirizine. Then last is belastin and fexofenadine can be used. These are some of the newer drugs. Coming to immunotherapy in children, there are a few indications for immunotherapy in a child with asthma. In a child with asthma, in step 2 or 3 should be done early. Step 2 or 3, and child is not responding to pharmacological treatment. And after doing a skin prick test, and if there is only 1 or 2 allergens are detected, then you can have an immunotherapy. In those children with allergic rhinitis also, the indication for allergic rhinitis is a child not responding to pharmacological treatment. You can try immunotherapy after doing a skin prick test, and the number of allergens are less. If the skin prick test shows that the child is allergic to 1 or 2 allergens, then you can have an immunotherapy. And immunotherapy, one advantage of immunotherapy in a child with allergic rhinitis, that if you do immunotherapy in allergic rhinitis, you can turn the allergic march. Allergic march can be stopped, and the child may not develop asthma. Then there is no indications for immunotherapy in children with atopic dermatitis is not there. Food allergy also it is not there. So main indications is an asthma and allergic rhinitis. But in children in pediatric age group, most of the children will respond to pharmacotherapy, and immunotherapy is rarely warranted in a child with allergic disorder.
That's it, sir. I think those are the questions for the first session, sir. Yes, sir. Thank you for all the speakers, Dr. Vikram, sir, Dr. Yagnesh Popper, Dr. Sukumar, and Dr. Anand, sir, for the clinical pearls on fever, on global warming, fever following vaccination, allergy, and fever, and with UTI. And also, I thank the chairperson, Dr. Ravi Shankar Marpalli, sir, for the last minute pitching in. And also, thanks, Dr. Basuraj, sir, from joining in from the aircraft. Thank you, sir. And we move on to the next session. We request Dr. Chetan Trivedi, sir, to chair this session. Dr. Chetan Trivedi is a practicing pediatrician and neonatologist from Ahmedabad. He is the honor assistant professor and infectious disease consultant at UN Mehta Institute of Cardiology and Research Center. He is the organizing secretary IPA FeFCon 2023, president-elect AOP Gujarat 2022, executive board member CIAP from 2016 and 2021, scientific convener, and also on the Wednesday Wisdom program, which sir conducts on every Wednesday. He is a treasurer IAP ID chapter 22-23, joint secretary IAP ID chapter, and he has several roles in various organization associations, and also he has been part of the many training modules of the IAP, and also part of the advisory board member and of the Fever Foundation. Chetan sir, welcome to you, and over to you to conduct this session on post-COVID fevers in children.
So much, Dr. Krishna, for this introduction. And good morning, all. It's really a wonderful learning session all throughout going on. Now we are dividing our lives into two sessions: is pre-COVID era and post-COVID eras. So our life has changed from pre-COVID to post-COVID, and the disease also have taken a U-turn or a sharp turn post-COVID era. And so it will be really interesting to know what is happening to a fever post-COVID also. And we have all observed that there is something different. We are not able to give explanation, or we don't have the answers for these kind of fevers, which have changed their direction after this post-COVID era. So it keeps us thinking that something is wrong, something is different, something is very special, which is post-COVID era. And to enlighten this subject, we have a wonderful faculty, a very good friend of mine, Dr. Ravi Shankar Marapalli. He is definitely a good friend of mine. He's very nice academician, but he is very much known for his witty comments on the WhatsApp groups. He is very, very sharp in that. So that's a unique, thing of him. He is, of course, a senior consultant in HOD, Department of Pediatrics, First Children's Hospital, Bangalore. He was past President IAP Bangalore 2020, President IAP ID Karnataka State Chapter 2021. He's Vice President IAP Neurology with Karnataka State Chapter 2021. He was the recent election also, he was Election Commissioner, Central IAP South Zone. So he's been very much active in the association as well as academics. So we will be really we'll be very happy to have him over here. Dr. Ravi Shankara, stage is all yours.
Thank you, Chetan. Thank you. So nice of you. Can somebody stop sharing?
Yes.
Before starting my session, let me thank Dr. Nagbhushan and my good friend Dr. Prabhakar Murthy, Dr. Kashi, and Dr. Jagdishanappa to give me a few hints about this topic, how to go about it. Because a new one, I didn't know what to do and what to include, what not to include, everything. So good inputs from them helped me to prepare this slide. So these are new challenges. Really, it is true. There is no doubt about it. A lot of cases we are getting, which are sometimes typical or atypical, and what exactly ultimately we end up with something else. That's what is happening. So this is the sentence which always I remember: infection-free world. That's what we thought about it. Everybody thought we can have no microbes in our world and we can enjoy our life. And this is the small statement which was quoted to Dr. William Stewart initially, but later they told it is not related to him. But it is one of the fantastic statements which we probably all of us had in our mind. It is time to close the book on infectious diseases and declare the war against pestilence won. This is long attributed to the United States Surgeon General Dr. William H. Stewart. Better he told, somebody told, it is not quoted by him, but a good one. But is it so? Can we live without microbes in our Earth's biosphere? That is the thing. So let us go and see the things. So this is the Chandu 15 years male, complaint of fever another for 1 month. This is what we saw in the last 3 months. Continuously children having fever, very alternative. Almost we can say 2 days of fever, no fever, then another 3 days later of fever. So continuously something the mother always prefer. Last 1 month there is a continuous fever. Though there is in between one or few days of a febrile period, they call like that one. So temperature 102 to 102 degree, cough continuous last 1 month, dry and no phlegm. This is the commonest symptoms along with the fever we saw in our practice. No loss of weight or appetite. Given antibiotics, this is the third thing we saw in our practice. Many times azithromycin, the most abused drug, and muscular was given, cough syrup was given, nebulizer was given, but patient did not improve. This case, the father is a doctor and he's very well known to my close friend. So through them, I continuously got the calls to start him an antibiotic, admit him, do CT scan chest and everything, whatever, because he was so much afraid. He thought his child has got something serious diseases, which if he don't do it, diagnose it immediately, he may die. That's what his apprehension. So the patient stays in a hostel, similar episodes in other inmates. And what exactly I did in last 3 months, that just divided them as sick looking or not sick looking. That way it helped me a lot in doing a good management of the patient. So here in this child, it is not sick looking and continuous dry cough, barking like fever 102 degree, just occasional bronchi. And this is the chest x-ray which I got it. So, and what I am doing that one, most of the times the patient can afford because the insurance is there admitted. Most of the time I'm doing PCR of the respiratory panel for the PCR, where they can easily afford and become a little cheaper nowadays. What I got in this child is influenza A, which is detected, and H1N both are detected. So this is what is happening. That is continuously fever is there. One or the other fever, they're waiting in the queue. Okay, just imagine they're waiting in the queue to attack the child, and one is over, and immediately the another is waiting to attack, or sometimes simultaneously both the viruses attacking simultaneously. That's what we are seeing. So I just started on fluid in this time and gave nebulization with oxygen, and the patient improved within 2 days. So no question of any CTs, any other things. The father was very happy. This is the case too. Patient had 5 years male, 1 month history of fever on and off, similar like the previous case. But what is happening is loss of appetite is there, given antibiotics 3 times. And this is the X-ray which I got. There is some amount of here, of course, in this picture may not be seen well. In the real chest X-ray, I can see that some amount of homogeneous shadow in this area. And it is sick looking. The child was sick looking. See, dehydration was there. Respiratory rate was 40 per minute. Indrawing of the subcostal margin was there. No rashes and other vital signs are stable. So admitted, and here I started straight away on injection muscular, but sent the respiratory panel for both virus and bacteria. What I got in this time, Streptococcus pneumonia detected high level, and RSV virus is also present. So both virus and streptococcal pneumonia, bacteria and virus both were there, and same treatment was continued with the child, nebulization with oxygen, and the patient improved and went home. So this is the picture. Probably all of you will agree with me. In last 3 or 4 months, since the starting of June, we saw in our practice. What exactly is happening? Though we saw it as soon as the school starts, every year we do this one, but not like this way, where just giving 1 or 2 days of rest to the child immediately another virus, or simultaneously 1 or 2 viruses attacking simultaneously. So, and continuously there for 2 to 3 months, whereas we used to see for about 15 days or 1 day or 1 month like that one. But this time it is period. So what exactly is happening here? That's what even Chetan Trivedi also highlighted. So let us see. So let us go back to the COVID era of the a small flashback. Empty OPDs for the 2020 and 2021 in pediatric. In pediatric was what we saw. Empty OPDs, pediatric ward, phone calls to know how long the vaccination can be postponed. This is the one important history that we had to note down. The vaccinations were postponed. Remember this fact. No physical play, children restricted to home alone, and non-pharmaceutical interventions like masks, physical distancing were introduced, hand washing. The children went for the NPI, that using the mask, physical distancing, and everything like that one. So end result, yeah, we were able to contain the COVID infection in the children, but and stop the reducing the spread by containing the carrier state. But what happened? Other side of the coin, what it tells, what we saw all of us, with virtually no physical activity due to prolonged lockdown, obesity increased manifold among the children. The other challenge of joint pain, poor posture, because they used to watch the online classes, lie in a different position, whatever the position they like, to see the online classes. So that's what had happened. Irregular sleep pattern, as there are no schools, anything, anytime they can sleep, anytime they can wake up. What had happened, we saw in our homes also, most of the children. Mental health among children has taken a hit due to lack of poor socializing. They could not meet each other, whatever, so only through the online. So only through the online, they thought they are independent, nobody can see them, and they started bullying the things, getting bullied by others. So many things had happened. So what exactly is happening? Two things we face because of COVID reason. One is a psychological one and immunological one. Still, we are seeing a psychological thing in our children, though COVID is over. So what exactly happened in the post-COVID era? Psychological. When school started, many children refused to go to school. Mostly, many of you might have observed this one. Many suicide deaths, because as soon as the school started, the parents started withdrawing the mobiles given to them, but they were addicted to the mobiles. So when they refused to give the mobile, many threatened and in fact went for the suicide. This is the Googling I did simply out of interest. You can see so many children have died because of that one. So social activities were forgotten in the school and no social gathering, and common sense is almost nil. Talking very loudly as if suddenly calling, Amma, I want coffee, tea, or milk, something like suddenly uttering in the school. So all those things of common sense were nil. That's what we saw it. And cyberbullying, which are already I told, this came in the newspaper. Either they bullied the seniors or the teacher. In fact, one of the New Delhi school teacher, they tried to enter into her Instagram, private Instagram, and posted her pictures in the thing, and she got suspended. So all of these things we have seen that one. So that is about the psychological thing. So what we forget about, one important thing is an immunity debt. Remember, we are not the whole and soul of owner of this earth. We are part of the earth. So everybody has got a right to live on this earth. So what exactly has happened? We went for an immunity debt. So this is easily explained by health professor Michael Baker. If there are no forest fire for 2 to 3 years in a forest, what happened? The many barks, leaves which fell down from the trees, which got dried up. So a lot of fuel is there. Okay. So if every year the forest fire comes, the availability of the subjects for the materials for the fire will be less. Here, 2 to 3 years, there is no fire at all. So a lot of things are there. Once a fire catches that forest, it spreads like a hell, almost kilometers, hectares of things will catch the fire. That's what will happen in our with our children. We protected them by giving the non-pharmacological things like wearing the mask, physical distance. What exactly happened? They went for an immunity debt. Our children went for an immunity debt. For 2 years, they're not exposed to any of these viruses, which they used to get it, and vaccination was delayed, which are supposed to get the immunity, that also not there. So both the things, it affected our children. That led to an immunity debt. This is a famous article by a French scientist, Pediatric Infection Diseases Group Position Paper on the immunity depth of the COVID-19 pandemic in childhood, how we can fill the immunity gap. This is the famous article which has been quoted. What exactly he tells that one, there's a lack of immune stimulation is there, both by vaccination and by a direct infection. So there's a lack of immune stimulation is there. So we have a major chunk of children who are susceptible people for the infection. They're ready to get an infection. That's what we created in last 2 years. So no primary exposure and no reinforcing of the trained immunity. Both were not there. So we know repeated infection will occur, but once the infection enters our body, because the previous exposure, the child's body immunity will fight against it and kill it. meanwhile, it will have a reinforcing of the immunity. So that is also not there. So both things were not there in our children. So this is the thing, probably all of you know it, lack of time. Let me skip this slide. So training is not there. So what exactly is that? So few things he quoted in the news, in that article, that is varicella. We know varicella commonly occurs. So what happened? The children were not exposed to the chickenpox. So these children grew up. So when they grew up, we know more the age of the child, more the severity in the child. So if a chickenpox comes in that child by chance, the severity will be more. So, and people who are exposed, ready to expose to varicella are also increased. So both things happened in this time. Same thing in the RSV. So in the first 6 months of COVID-19 pandemic, the initial epidemiologic data from the southern hemisphere showed almost virtual absence of the RSV infection. So remember this fact. And same thing with the rotavirus and enteroviruses. Remember how how our OPD was filled with an HFMD in the initial 2 months of June and July. Every alternate patient probably we had an HFMD. So whereas during the COVID period, we didn't have such children. So this is the fact we are seeing that one. And streptococcal pneumonia, this is an important thing by work of Gray. He tells that one, all infants will be colonized by various serotypes streptococcal pneumonia in the first years of life. Most of them progressively develop mucosal and systemic immunity against these various serotypes without showing clinical signs of infection. This is an important fact, we always know it. What exactly in these 2 years that one, they were not exposed to the streptococcal pneumonia at all. So there is no, even a subclinical infection is also not there. So no immunity. So they're ready for a infection later. So, and we know pediatric pneumococcal carriage and infection are favored by a viral infection. A post-viral situation is the best time for the streptococci to attack the children. So here we have got a major chunk of children who are ready to get exposed to the streptococci pneumonia. And most of the time, what happened, we know the immunization program, because the health workers were shifted to managing the COVID things, and many materials also went there. Even in fact, our gene expert hardware also went to test for COVID RT-PCR, and most of the doctors also went to manage the COVID patient. So everything we ultimately led to a chunk of a greater chunk of children who are immunity dead. So what happened? So let me see what happened in my hospital. For about 3 months or 2 months, I did RT-PCR in children who got admitted. So there is from June to end of August, 84 cases. Number of positive cases were 73. So positive percent was 86.90%. And double infection was in about 19 cases. That is the thing. And remember, neonate 1 month to adolescent. So as the age increases, the number of infection we got more. That's what thing I told in immunity depth. So we have got children who are ready to get infected, and as the age increases, we got the more people who got infected. So, and this is the coming to the microbes who affected more. See the big man here. So that is the influenza A. So almost 33% of my cases were influenza A. The next one was H1N1 was 17.9%. And the third were human influenza, human metapneumovirus 10.7%, and human respiratory syncytial virus of 10.7%. These are 3 viruses which dominated since last 2 months. Probably maybe same situation with you people if you have tested the same thing like that one. And so what the data shows? The data shows almost more than 95% of the cases were of viral origin. This is an important statement I want to do. Why unnecessarily the antibiotics were started in almost all the cases which are referred to me in our hospital. But the antibiotic never helped them. And in same cases, when I did the RT-PCR, when I did the PCR test, most of them viral in origin. So the more major 4 viruses were influenza A, H1N1, RSV, and metapneumo. And isolated bacterial infection almost nil. So it is the time, the festival for the viruses to get attacked. So what you call the Mela viruses initially. So the bacteria was almost nil. Only 2 to 3 cases I had bacterial infections. So most of the cases were prolonged in nature, lasting 2 to 3 weeks. Or already I was told there was in a queue to attack any child. After you, me. That's the way they're behaving like that one. That's the way I can explain in that one. and cough persisting in majority of cases, and the main concern to get admitted. And antibiotic which was never used. Azithro was a main abuse drug, and RT-PCR really helped me to managing the children more comfortably, more confidently, and almost advising the parents of the same thing, because almost for weeks together children were attacked. So they want to know what exactly is happening to their children. They were apprehensive, and the RT-PCR helped me to allay their tension and anxiety, and also for me to give a good confidence. The immunity depth has created a new scenario where the child is getting infection very frequently, no recovery phase for each infection. So we have to be watchful for other vaccine preventable infection, because the vaccination has been postponed. And in this same 2 to 3 months also, because the continuous attack of the fever, the parents were not willing to come to our clinic to get vaccinated. So it's almost a postponement of the things. That's what has happened. So before concluding, let me go with another interesting case. So not only the children, the neonates, the 40 days old child, history of fever, cold and cough for 3 days, admitted outside for respiratory distress, started an amoxicillin for 2 days, then changed to Piptaz. Patient was on 5 liters of oxygen, no improvement, referred to us. And when we examined, baby was in severe distress, respiratory 75 per minute, saturation 88%, tachycardia tachycardia 170 per minute, indrawing of subcostal, and total count 11,000. Remember, the patient is affected so seriously, but the total count just 11,000, and neutrophilia, and CRP is slightly high, 35, and this is the X-ray. This X-ray probably you can see on the right side, some patches were there. So initially we thought it is a bacterial, and we started an antibiotic, and this is the ABG. And ABG, look, it is very high. This is an acidotic time. So we started the patient on volume mode on ventilation, changed to antibiotics, ceftriaxone because of the X-ray, baby worsening, and needed pressure mode with high PF. So went on worsening even on ventilation also. So CRP increased from 30 to 50, and TLC remained the same. This is an important thing which we have observed it. And when we inquired, once again we took the history once again, we came to know the baby had fever even before this incident also, remained afebrile for 2 days, had fever for 2 days, then disappeared. And COVID antibodies, IgG antibodies, we did that one. Ferritin, LDH, BNP pro were raised. BNP was almost 3,900. It went up to 9,000. Echo of the cardia was normal. So we thought of a MISI in this child, and started on steroids and later IVAG. After that, starting on IVAG, baby started improving by ventilation wise also, and developed frequent bradycardia. When we did the Holter study, it had arrhythmias in that one. So the COVID has affected the myocardium. And finally, baby are able to put the child off the ventilation and went home. So there is something going on along with the sepsis and other metabolic disorders. You have got one more DD in newborn, even up to the age of 3 to 4 months, the MISI in the child. And this is the beautiful child sent by Dr. Maitri, who has managed almost 20 cases in our hospital, Manipal Hospital, neonatal MISI. This is the beautiful slide sent by her. And it is a thing we have to keep it in mind. That's all I can tell about this one because of the lack of time. Finally, as Lord Trivedi told, there are so many cases which are coming, we don't know what exactly is happening. This is what I felt. I had one case, similar cases. 8 years old girl referred to us, history of fever 2 days duration, vomiting 2 to 3 times. Outside examination revealed patient in shock, pH of 6.9, lactic acid of 12, activity is cold, given bolus IV 5 times, no recovery, and referred to us. Our laboratory report told TLC of 24,000, CRP of 60, hypotensive, irritable, bleeding, not stopping at the IV puncture site. Even there also it was bleeding. Platelet count just 17,000, liver enzymes elevated in 1,000. Dengue came negative, and patient died within few hours after referring to us. So finally, let me close my talk. So infection fever. So you all of us, we thought about it, and we dreamt of that one. Please remove this statement. Okay, we had to live with this. This Earth biosphere has got a place for all, including the microbe. A healthy, meaningful, and practical equation among all is a more pragmatic approach, which includes avoiding antibiotic abuse. Any antibiotic abuse, believe me, you're building a group of bacteria which are resistant to it, which may remove us from this earth, remove this fact. We are not removing them; they may remove us. So start avoiding. So avoiding the antibiotic abuse. Stop that one. A robust immunization service and surveillance setup is an important thing. Anytime this never to be. I mean, we never be failure in this giving a good immunization service. What we did during the COVID time. Okay. Thanks a lot. Let me stop my talk here.
Thank you so much, Dr. Ravi. It was an excellent presentation. I think this was the observation of all, I suppose, what is happening, what you presented the cases. What we observed, can you just stop sharing?
Yeah. I'm just trying. Just give me 1 minute. I'll do it.
Yeah, fine. So we also have had this feeling that there's something is changing post-COVID. And it was very nicely been portrayed in this presentation that what we saw is there is something affecting the viral infections more. Maybe RSV, you said, H1N1, our influenza, everything. Simultaneously, HFMD also, we have observed a lot many cases. But we have not seen the similar things in dengue. They are not increased. So that is something to deal with the respiratory infections only. And very nicely you showed that, yes, there is a prolonged fever, a prolonged illness in these kind of cases. And also those patients where single infection you got, the similar data are there. I think we must have seen everywhere. We got so many H1N1 positives, so many flu positives, and dual infections also. So really it was, I must say, it is not an eye-opener, but yes, it made ourselves aware that what we have seen is been seen all across the globe. And maybe this is what is happening post-COVID, immunity depth. That concept is really, we can digest it, that yes, it can be the reason. So overall, it was an excellent presentation. Thank you. And if there are any questions, we can take it, but I don't see any questions. Excellent, Ravi.
Yes.
Thank
So
you. Thank
there
you.
are no questions, but I received almost around 40 to 47 messages saying,
Great.
oh, one of the outside presentations, excellent, sir. Thank you very much. Nice, informative. And there are people requesting for your presentation, sir.
That's the popularity of Ravi.
Thank you.
So there's only one question coming in. This is Dr. I think someone by name Sham from Bhopal. They're asking, so vaccinations, can you enumerate and enlist the vaccinations for pediatrics, COVID vaccines? That's the question, I guess.
So it's not my topic. I mean,
Yeah, that is the question which is coming in.
what is the topic? Can you tell the question once again?
Sir, can you enumerate the COVID vaccinations in children? What are the vaccines available for
Okay.
practice?
As we know, it is about 11 years. The government has accepted the what are the vaccine? Covaxin, Covavax.
Corbevax.
Yeah, that we can go that one. Less than 11 years at present, it is not accepted in India, though it is accepted in Europe, in the America. So as of now, it is only about 11 years. That's all.
So 12 years and above, it is Corbevax what has been given, and more than 15 years, it's Covaxin has been given.
Okay, if I can just make two comments with the permission of Dr. Chetan and Ravi.
Yes, sir, please.
Okay, right now there is a huge wave of RSV which is filling all the hospitals in the United States of America, and it's one of the worst seasons of RSV. Second thing is that post-COVID there is immune suppression. Data for this has come from a very interesting French study which has shown that post-COVID, there is a suppression of the immune system for up to 1 year. And this is in all the limbs of the immune system, starting from antigen recognition down to lymphocytic response and even immunoglobulin production. So it's a very interesting paper which has shown that the immune suppression post-COVID in children, this has been shown in adults, but I'm sure it's very similar in children too, that it affects the immunological system for at least a year. So this is another aspect that we need to keep in mind, that we are going to see this kind of a recurrent infection at least for about a year or two post-COVID epidemic. So this is one more thing. And the third thing is that they are also looking at, there may be an epidemic of influenza complicating RSV. And therefore, I think it's important that we should start looking at vaccinating children, because even with your data, it shows that a large percentage of influenza was the primary trigger point. So I think it's very eye-opening and very relevant topic that you have addressed. Congratulations for that wonderful presentation.
Just one question, Ravi, from your patients. Did you know how many were vaccinated for H1N1?
No, they
Because-
didn't come to the clinic. That's what I told you, no. They were not afraid to come to the clinic and they were not vaccinated at all. Though they knew influenza flu vaccine is available, most of them did not come to the hospital at all, even to the OPDs also.
So it was unvaccinated population. Was it?
Unvaccinated, yeah. Correct,
Same
correct.
thing here.
Same
Same
thing
here.
here.
Thank you.
Thank you, sir. Thank you, Chetan sir, for the wonderful moderation there. And thank you, Ravi Shankar sir, for the excellent talk on post-COVID fevers in children. We move on to the next session, update on dengue and dengue vaccination. To chair this session, we have Dr. Rashna Das Azarika, madam. Yeah, she is the Chief Pediatrics and Neonatology NEMCare Guwahati. She is the Associate Consultant Sydney Child Health Program, University of Sydney, Australia. She is a Fellow Pediatric Infectious Diseases MCMS, Examiner IGNO, and she is also formerly Associate Professor and Founder Head at NEIG RHMS Shillong. And she also has held various positions in her capacity at Indian Academy of Pediatrics, and also she has several papers to her publications, and also she has been part of the editorial board of a few journals, and she has also been part of the COVID-19 task force, and also she is a member of Fever Foundation. Madam, welcome, and to take over the session on update on dengue and dengue vaccination.
Thank you so much, Dr. Krishna and Microlabs for giving me this opportunity. It's my proud privilege to introduce our speaker for this session, the one and only Dr. Abhay Shah. He is very well known in the pediatric fraternity and currently is the Director, Children's Hospital and Pediatric Infectious Disease Center at Maninagar, Ahmedabad. He has been a member of the ACVIP for 2 sessions, also has had various roles in the Central IAP, along with the chairperson of the Infectious Disease Chapter, and I think therefore a very appropriate person to talk on dengue vaccination. He has received many awards, of which the Tapan Kumar Ghosh Memorial Oration 2021, Shivananda Oration 2015, and recently he got the Emerging Gujarat Award in 2022. He's a member of the state mentoring group, Lakshya Improvement Program, Government of Gujarat. Publications and book chapters, more than 100. And he's been on the editorial board of a lot of textbooks which have come out from IAP. So without wasting much time, I welcome you, sir, to present your talk.
So can you stop sharing? I would like to stop. So thank you very much, Dr. Rashna Das, madam, for this wonderful introduction, and thank the organizer, Dr. Jagdish Chinappa, Dr. Manjula, Dr. Krishna Kumar for giving this opportunity. And the topic that is very, very relevant. Are the slides visible?
Yes, sir.
Yeah. So the next for the next 20 minutes, I will going to talk on update on dengue and dengue vaccine. It's a huge topic, but I will try to cover it within the allotted time. And as you know, as per the Lancet, this dengue is one of the fastest spreading infectious disease, and nearly half of the world's population live in the dengue endemic area. And nearly there are 25 lakhs cases with 2,065 deaths across the globe, and the major contributor Brazil, Vietnam, Philippines, Indonesia, and Peru. At the same time, in 2022, India also records a very significant cases as far as the dengue cases are concerned, and that is especially in the post-COVID area as well. And if we look at the seroprevalence, as per the dengue in the SARC territory, the latest report in 2022, dengue-2 virus is the major prevalent serotype over last 50 years. But what has been changed is that now dengue 1, dengue 3, and dengue 4 are also picking up, and there is a co-circulation as well. And because of this change in the seroprevalence, there has been a significant change in the dengue as a clinical manifestation. Majority of the liver enzymes are affected very adversely, and that the leaky phase is going to be a little more longer as compared to previous dengue cases that we are observing over the decades and years. And as you know that there are 4 different serotypes of dengue, and infection with any one serotype will give a lifelong protection, but it will not give cross protection to the other dengue virus. And therefore, when there is secondary infection with heterologous serotype, there is a mechanism which is described as antibody dependent enhancements. And this ADE, along with the cytokine storm, will lead to severe thrombocytopenia, capillary leakage, and sometimes it may cause a life-threatening complication and death as well. But what is important that I want to emphasize that what is the similarity or the dissimilarity between the COVID and dengue? So it is very, very important that both the disease, that is COVID-19 and dengue, will have antibody dependent enhancement. Both can have cytokine storm. Both can have vasculopathy, and both can have coagulopathy. And therefore, in an area where the COVID pandemic is going on, and when the dengue outbreak is going on, probably as a clinician, we are often perplexed. And therefore, what is common to both clinically is that a short febrile illness with fever, leukopenia, and thrombocytopenia. But in COVID, most of the time, the respiratory symptoms are more common. Retrobulbar pain, body ache, rash, and bleeding manifestation, especially petechiae, is common found with the dengue. But remember that dengue is a disciplined illness. Dengue is a disciplined illness, whereas as far as the course is concerned, COVID is concerned, it's quite uncertain, especially a child who is obese and with a comorbid conditions. And therefore, when there is a fever, diarrhea, headache, chest pain, myalgia, orinophagia, arthralgia, and when the respiratory manifestations are not there, we are often difficult to find out whether we're dealing with a COVID or dengue. And therefore, extrapulmonary manifestation of COVID-19 and dengue co-infection is also there, that has been reported in the literature as well. We also know this new classification, the dengue with warning sign, dengue without warning sign, and I will not go much into detail because to another time, but any child who has the probable dengue will require a OPD treatment. Child with warning sign, that is abdominal pain, persistent vomiting, clinical signs of third spacing, mucosal lethargy, liver enzyme and rising hematocrit, falling platelet. These are the cases we need to be admitted. And child who has a severe dengue, that is shock, respiratory distress, severe bleeding, or organ involvement, AST more than 1,000, they require ICU admission. As far as diagnosis is concerned, it is always the epidemiological background is very important. At the same time, a clinical pattern that I have already described, CBC, that is rising hematocrit, falling platelet, NS1, serology, PCR. These are the various modalities that are available. But most of the time, dengue is a clinical diagnosis. NS1 is a foolproof, nearly 100% specific, but negative NS1 does not rule out dengue. At the same time, if NS1 which is persistent beyond 4 or 5 days, usually the dengue is going to be a serious one. Similarly, the IgG and IgM, by the time they appear by day 10, usually the clinical course often becomes obvious. Either the child will have gone into a shock or the child would have recovered. So what is required is the clinical parameters, epidemiological pattern, and the serial hematocrit. That is very, very important as far as the diagnosis and monitoring case of the dengue is concerned. As far as monitoring is concerned, once the case is diagnosed, it is a clinical, nothing else. So temperature, tachycardia, narrow blood pressure, cold extremities, these are the signs of that the child is going for a dengue shock. Remember that USG can detect the plasma leak earlier than the rise in the hematocrit value. Similarly, appearance of the tenderness in the hepatomegaly, edema, mental status, respiratory distress, diminished urine output, these are the findings which suggest that yes, this child has got a severe dengue. When you're starting an IV fluid, when the hematocrit is rising and the child is still unwell, the child needs the fluid. But if the hematocrit is falling, and in spite the child is not doing well and deteriorating, probably there must be some internal hemorrhage. So this is very, very important that rising hematocrit in an unwell child requires fluid, but falling hematocrit in an otherwise undeteriorating child, that you have to suspect that internal bleeding might have taken, and probably the child may require blood product. So most important for preventing morbid mortality is a serial hematocrit, and do not withdraw the fluid therapy pending the laboratory report. Now it is very important for all of us to find out that whether we are dealing with a shock or not. And for that, any child of a dengue who has got a sweating, abdominal pain, restlessness, altered conscious level of sign, cold extremity, prolonged capillary refill time, more than 2 seconds, these are the cases which require to be to look for the shock. Similarly, unexpected tachycardia, increasing diastolic pressure, narrow pulse pressure, and unexplained leukocytosis. So when you're doing a serial CBC, if there is an unexplained leukocytosis, probably in a child who is deteriorating, if the hematocrit is falling, probably we are dealing with a case of internal bleeding, and the child is going for the shock. Now, this is the typical algorithm. I may not go into this. This is the algorithm for the complex shock, where we start with the fluid that is 10 to 20 ml, and then they will decrease, titrated as the child is improving. And this is for the hypotensive shock. Again, this is, I'm not going to detail this because it's available in all the textbook. But what as an update, what I'm going to present to you, that this is the fluid therapy, that is the current concept. And therefore, both oral as well as IV fluid should be considered as per the ideal body weight or the actual body weight, whichever is less. If the child is more than 50 kg, it should be treated as an adult individual. See, and for the entire critical phase, irrespective of the length of this critical phase, the amount of fluid required is maintenance plus 5% of the body weight, that is 50 ml per kg, to maintain the perfusion of the vital organs. And at the same time, when there is a guideline for the fluid critical phase, without shock, remember that the fluid requirement is now less and less. Now we are starting with 1.5 ml per kg, not the 3 ml per kg, gradually increase to 7 ml per kg. And once the child is breathing, well, gradually coming down. So within 48 hours, the fluid requirement will be less and less, and the target urine output should be 0.5 to 1 ml. Remember, if the urine output is more than 1 ml per kg, you are doing a fluid overload. So the target urine output should be 0.5 ml to 1 ml per kg. So now we are opting for less and less fluid as far as the dengue management is concerned. If there is no response to this, then again, back to the basic, you have to look for the ABCS, that is acidosis, bleeding, calcium, and sugar. So you have to must take. So do not just go on pushing the fluid. Look at the other metabolic parameters as well. That is acidosis. There may be some internal bleeding. There may be hypocalcemia, or there may be hypoglycemia. Similarly, colloids are required only after the failure of the tuberculosis, or when the shock is there in a child who is otherwise loaded with the fluid. And for that, dextran or starch can be used, but never used FFP as a bolus as well. Blood products, that is PS, is required only in case of internal bleeding. Platelets are not required unless you are going for some procedure or some central line, and the platelet is less than 50,000. Similarly, inotropes are not required. They give a false sense of security, and usually CBP monitoring is required when you're going to use the IV. But what is I want to emphasize that always go, if the facet is available, always go for the functional echo and look at the inferior vena cava. If the inferior vena cava is collapsed, child requires more bleeding. If the inferior vena cava is full, probably child does not require. So functional echo is very, very important. And these are the discharge criteria. When there is no fever for at least 24 hours, at least 2 days have left after the recovery from the shock, child condition is good, appetite is good, hematocrit is near normal or around 38 to 40% when baseline is there, and platelet count is definitely above 50,000. These are the criteria where discharge is there. And our own experience in the post-COVID dengue cases, in nearly 80 cases, the common age group was 5 to 14 years. A younger age group are no more affected. We have 2 cases below 1 year, youngest of 7 months, which was not having fever but have a very serious course as far as dengue is concerned. Elevated enzyme in thousands are common nowadays. Second phase is more prolonged compared to previous dengue illnesses. CNS complications, including galvanization, we have seen in two cases, and we have seen lots of hyperferritinemia as far as the dengue cases are concerned. And those children who have got a severe dengue, they have a ferritin level was very, very high. So that is all about dengue. As far as vaccines are concerned, it is a need of the hour. Why? Because the dengue outbreaks overwhelm the healthcare system. There are no specific dengue therapeutics available, and there is a great pressure in endemic area for a dengue vaccine. And as you know that there is no lifelong homotypic protection and there is no cross protection, and therefore there is a need for the broad spectrum tetravalent vaccine. As far as the vaccine is available, there are different live attenuated vaccines are available. That is, one is from the Sanofi, that is CYD-TDV, other is Tetravax, that is TV003 and TV05, and other is tetravalent dengue vaccine from Takeda. So out of this, the vaccine, the whole list there, only 2 vaccine has passed the phase 3 trial, that is CYD, the dengue vaccine license, but the post-license evaluation is ongoing and has been already withdrawn from the from India market because of this side effects. And other is the Danvax Tech 03, again a live attenuated vaccine that is in the phase 3 trial, and other is a Tetravax DB. So these are the vaccines which has entered the phase 3. Other vaccines are in the either in the phase 1 or phase 2 trial. As far as the dengue vaccine from Sanofi is concerned, is a live attenuated chimeric tetravalent vaccine administered in 3 doses, that is dose 0, 6 months and 12 months. Is a very long duration of the steroid as far as the vaccine is concerned. First license in Mexico in December 2014, commercially available in Philippines and Indonesia in 2016, and registered in more than 20 countries, but registered more than 20 countries and substantial public health program in Brazil and Philippines. So majority of doses has been used in Brazil and Philippines. But what is important that this vaccine has a rapid fallout because it is a very low efficacy as far as the younger children is concerned. In children between 2 to 5 years, the efficacy is nearly less than 33%. There is increased risk of hospitalization, severe disease, and death after the dengue vaccine. So the safety issues are always there, and the dengue is found to be more effective and seropositive and was not effective or efficacious or immunogenic in an immunological naive patient. And so, as far as the 211 serious cases with dengue vaccine is concerned, 87 cases had a dengue fever, 14 cases have a fatal outcome out of 87 cases. So, this dengue has vaccine number. So, the limitation of dengue vaccine is that there is poor efficacy in younger children, poor efficacy in seronegative children, less immunization for dengue virus 2. There is safety issue, high chances of dengue hemorrhagic fever, and even death following the vaccination. And there is a long dosage schedule that 3 doses require as long duration as 12 months. And therefore, we need to have a very important ideal vaccine, which is useful in children, safe, effective, even in the seronegative children. It should be a broad spectrum covering all the 4 dengue viruses, short dosing interval, and fast onset of action. And a new vaccine that is Takeda is a row of hope at the end of the dark tunnel. Again, it's a live attenuated vaccine. And as far as immunity is concerned, it creates neutralizing antibody. It also imparts cell immunity. It imparts antibody to NS1 as well. And the 2 doses are given here instead of 3 doses, 3 months apart, and single dose is also being under evaluation as far as this vaccine is concerned. This vaccine has been deeply studied in nearly 20,000 participants. And if you look at the efficacy in a tight study, that is vaccine efficacy of 62% against all viral confirmed dengue cases, 65% vaccine efficacy in seropositive individuals, and 54.3% vaccine efficacy in seronegative individuals. As far as the hospitalization against dengue is concerned, the vaccine efficacy is 86.3% in seropositive individuals, and in seronegative, it is nearly 83%. So the vaccine is effective in all the age group, irrespective of seroprevalence. The rapid onset of action is also there with this Takeda vaccine, that is 97.7% efficacy against type 3 after 1 dose, 73.7% against type 1, and 63.3% against type 2. So the vaccine has also a rapid onset of action as well. As far as safety is concerned, it is generally well tolerated, and there were no important safety risks. There is no evidence of disease enhancement or antibody-induced enhancement as the vaccine is concerned. So the vaccine is very, very promising. And if you look at the 4.5-year study of this Takeda TIDE study, the tetravalent against dengue vaccine is there because the safety and efficacy has to be obtained for consecutive 3 to 5 years as per the WHO recommendation. And this vaccine has proved his credibility, that is that 84% prevention of the dengue hospitalization, 61% prevention as far as symptom dengue is concerned, and overall the vaccine is found to be safe and also effective in seronegative cases. So, but in spite of this, all this safety and efficacy, this dengue vaccine has not been licensed anywhere in the world. The only recently in August 2022, Takeda dengue vaccine has been approved by Indonesia for the age of 6 to 45. So in spite of all this credential vaccine is now started approved in Indonesia. Otherwise, it has not been available approved anywhere. As far as Indian scenario is concerned, we are working on 2 different vaccines. That is Tetravax dengue vaccine, a live veterinary vaccine licensed from US NIH to Indian Pfizer company, and DS4 indigenous subunit protein vaccine. However, none of these vaccines have started even their phase 1 trial. So what is future is that the Takeda will seek an indication for TAC 003 for the prevention of dengue vaccine in individual 4 to 6 years of age, regardless of the previous virus exposure, based on the data in both adult and the children. And there remains a need for the dengue vaccine that can be used in both dengue naive and dengue exposed adult children. So thank you very much for sharing. If you have any question, I will be very happy to answer. Thank you so much.
Thank you so much, sir. I think it was a very nice eye-opener of a talk, I must say, especially regarding the vaccination. Some of the salient points which I thought required a second mention was that you have mentioned a very important point, that if the NS1 is positive on day 4 or 5, then it indicates the patient is going to have severe disease. This is something new for me. And we are also seeing not only hyperferritemia, but also in the second phase, we do get some cases of macrophage activation syndrome, which requires steroids. And as far as the dengue vaccine is concerned, I think I hope that the Takeda vaccine will come to India, because recently I've had a lot of my patients who have gone to Goa and some going to Vietnam, and then we know that these places are having a lot of dengue cases. So even planning a holiday is becoming a problem. Thank you so much. If there are any questions, Krishna, if any...
Regarding that hyperferritemia, Rasna, there are interesting papers. So in the Caribbean countries, they have studied a long study about this, and the children who have a short febrile illness during dengue season, but their NS1 is negative, their IgM is negative, means there is no clue what they're dealing with. In that case, they studied ferritin on day 4 and 5. And if the ferritin is more than 1,000 in that cases, the chances of getting serologic IgG or PCR positive dengue was very high. And when the subsequently they have treated these cases accordingly, and when they have some complication, majority of them have ferritin which was more than 5,000. So I think it's a new emerging area, and the PGs must have some thesis on this, that ferritin and dengue.
Yeah. So I think all the viruses are causing all kinds of immunological problems.
Yeah.
So thank you very much. If there are any questions or any comments from the other learned.
One quick question to Dr. Abhay. There were some reports from Thailand that there is cross-reactivity between COVID and dengue.
Yeah.
As far as testing is concerned, any comments on that?
No, it's a very so when there is a co-infection is there or single infection, either of them can cross-react between. So chances of getting false positive COVID is also with the dengue, and false positive NS1 is also there with the dengue. And PCR, false positive PCR positive is also there. So it's a well-established case. And therefore, we look at the only clinical pattern. If there is rising hematocrit, falling platelet, and the child becomes serious by day 4, edema is there, I think we are dealing with dengue. And most of the time, fortunately, COVID is asymptomatic, mild disease. So this pattern is not observed, and we forget about the positive COVID, and we consider on the positive PCR for the dengue.
Yeah, another one small point was in your wonderful slide where you had distinguished between COVID and dengue. One more feature was dengue by the 14th day is over. I mean, it's either this or that, whereas COVID is not over. COVID continues even beyond that.
So unprecedented course with COVID, disciplined illness with dengue. Yeah.
Correct. Very, very, very nice statement. Excellent. Thank you.
Thank you so much. Yeah. Thank you for the opportunity. Yeah.
I don't see any questions. Everybody has said excellent, brilliant, superb. So thank you so much, sir. It's always a pleasure to listen to you. Thank you so much.
Okay.
Krishna, we hand over to you for the next session.
Thank you very much for the wonderful deliberation there, and thank you, Abhay sir, for the talk on the update on dengue and the dengue vaccination. Moving on to the next topic, to chair the session, we have Dr. Ananda Kesavan sir. The next topic will be hectic fevers in children. How aggressive should we get? And the speaker is Dr. Palani Raman. Dr. Anand Kesavan sir is Assistant Professor of Pediatrics at GMC Thrissur, is the IAP National Vice President 2020, past National President IAP Neurology Chapter, past President and Secretary IAP Kerala Chapter, is also been the Editor-in-Chief Indian Journal of Trauma and Emergency Pediatrics, also Chief Editor IAP TB on TB book on pediatric radiology, frontiers in pediatric neurology and recent advances in neonatology. He is also the member of the National Advisory Board, Indian Pediatrics, also member of the FEO Foundation. Welcome you, sir, Anand sir, and over to you.
Thank you, Dr. Krishna. So we'll have another great speaker, Dr. Palni Raman, my friend from Nandivanam, Tamil Nadu. He's a practicing pediatrician, over 28 years experience, very academically active, and also trying for excellence in office practice. He won the National Practicing Pediatric Quiz Award in 2002, and his areas of interest include infection, hematology, and also rational antibiotic use. He's an active propagator of rational antibiotic use, and we will hear from Pani Raman about hectic fever. He heard about the intermittent fever, remittent fever, continuous fever. Hectic fever, I think it is a very high-grade fever with a wide fluctuation. So over to Pani Raman to say more about the hectic fever. Over to you, sir.
Okay, thank you. Thank you. Can I share the screen? Hello.
Yeah.
Can you? Is it visible?
No, not visible.
1 minute.
Hello.
Hello.
Yes, sir. There is a below green button, share screen.
Yes.
Yes. So
Yeah, I'm screening that only.
please share your screen from there.
Maybe you close everything, sir. Close the PPT again, reshare it, sir. Sometimes if you have kept it open, it will not share it.
Sorry for the delay. Very sorry.
No
Okay.
problem, sir. It happens.
I have shared with you. Can you share the presentation with you?
Yes, sir. Okay, I'll just check. So you emailed me, sir, or WhatsApp?
Just open this thing, Dr. Palniraman, just open hectic fevers.
Yeah.
Open the slides.
Yeah, I'm not able to.
Or can you send it to me, Palni? I'll open it.
Okay, just I'll send it. Send you. Jagdish, it is with you. Now it is with you in your.
Right. I'm just getting downloading it.
Yes.
And not reached as yet.
Sir, even it does not come to me.
Yeah, it is there with you, Jagdish. In the WhatsApp I sent.
On the WhatsApp, is it? Okay.
WhatsApp. First of all, I thank the organizers of the Fever Foundation and particularly Dr. Manjula and Dr. Krishna and my close friend, Dr. Jagdish, for giving this opportunity. And the outline of my talk will be, what do you mean by hectic fever? What are the fever patterns tell to us? Or fever patterns are relevant today in clinical practice, some case snippets and message from case snippets, and finally the PU and hectic fever. First of all, I was thinking why Dr. Jagdish has given me this topic of hectic fever. When I gone through the literature, even the Nelson gives 1 or 2 lines here and there very rarely. So everywhere you don't have enough literature on hectic fever as such, but still this topic has been given to me. But let us see at the end of this lecture, what is the importance of this hectic fever in pediatric practice. And as late as 2nd century, the Gallen Roman physician has been mentioning about the hectic fever as the patterns of the fever. So what do you mean by hectic fever? Any high spiking or wide swinging or highly fluctuant fevers with a 2 to 5 degree difference between the peak and the nadir is known as the hectic fever. And what does the adult physicians mean? Usually they mean that some serious suppurative infections are there. So this is the reason, and usually they ask, particularly when they ask us, particularly as a pediatricians, sir, my child is running hectic fever, whether anything serious is to be. So this is the common question by a general practitioner or a general physician to a pediatrician. So what does it mean to a pediatrician? So the 2 important questions to be answered at the end of this lecture is, how common is hectic fever in children? What is the utility value of it in day-to-day practice? So this is the essence of this lecture. Okay. So coming to the fever patterns, we know fever patterns has been dating back to as during even the Hippocratic days, the malarial pattern has been described. So fever pattern has been appreciated for centuries by clinicians as an important diagnostic science. When methods for diagnosing infections were primitive or non-existent, this analysis of fever curves often provided the only way to differentiate acute febrile illness. And particularly when there are no localizing signs, the temperature analysis and the characteristic fever patterns are of clinical importance and may provide the only clue to guide further testing or suggest a diagnosis. This is true particularly 100 years back, particularly before the antibiotic era and before the antipyretic era. What do you mean by fever patterns? And the fever patterns as such actually taken a great role only after Professor Wunderlich from Germany, who has recorded more than 25,000 patients who has recorded the graphs. And finally, he has analyzed more than 5 million temperature. And finally, he has come out with the thing. So only he is known as the father of clinical thermometry. So what are the common fever patterns described in the literature? The former are intermittent, remittent, continuous, and hectic and relapsing. The hectic fever is one of the fever pattern. So before going to the hectic fever, we should know about the other fever patterns too. So when it comes to sustained fever, usually the temperature variation is less than 1 degree Fahrenheit. Some tests say some less than 1 degree centigrade. There is no fluctuation. Then it is says a continuous fever or a sustained fever. But whenever the fever touches the baseline and the temperature variation is there, every day there is a temperature peak, but it touches the baseline, it is known as intermittent fever. Whereas whenever the temperature doesn't touches the baseline and the fluctuation is more than 1 degree centigrade, it is known as a remittent fever. So what do you mean by hectic fever? Whenever there is a wide swings of temperature each day, more than 2 to 5 degrees centigrade, it is known as hectic fever. Here again, there are further graphs to explain this thing. The first one is the intermittent fever graph. Here you can see there are temperature swings going up to 104 degrees centigrade, but touching the normal to 98. This is the intermittent fever. Every day the temperature touches to normal. So this is the classical example of malaria, like a quotidian fever, tertian fever, quartan fever, everything comes in the thing. Coming to the second, here comes the remittent fever. Here you can see the temperature goes up to 104 or 103, but it doesn't come below 99. That doesn't touches the baseline. This is known as the remittent fever. Usually majority of the viral illness we face in day-to-day practice are mainly comes under this category of remittent fever. Coming to the third graph, you can see this is a graph, this is a step ladder pattern, and finally the temperature becomes a continuous or sustained fever where the temperature variation is less than 1 degree centigrade and it keeps going on. This is known as the continuous fever. But these days are pre-antibiotic era and pre-antipyretic era. Now the people are so notorious in using the antibiotics and antipyretics. This continuous pattern fever and all doesn't exist because of that is the very potent antipyretics or potent antibiotics. So the temperature is made to come down to normal. These continuous fevers are everything becoming an intermittent fever nowadays. So they are becoming irrelevant as days passes on. So here again, I have shown the intermittent fever and remittent fever thing, but here there are wide swings of temperature, more than 2 to 3 degrees centigrade. So here you can see it goes from the 99 to 104. Here you can see it goes from actually 100 to 103. So wide swings of temperature, whether it is a remittent or whether it's an intermittent, they are known as hectic fevers. So what does hectic fever means? Whenever there is a wide fluctuations in temperature, whether they reach the baseline or doesn't reach the baseline, then it is known as hectic fever. This is the thing. Here is again, there is a representation of hectic fever showing the wide swings of temperature. Okay. So in clinical practice, what does it mean? So now the many typical fever patterns are rarely observed. Why? Because of the several confounding factors. We all know the age of the patient, the immune status of the patient, what is the physical malnutrition of the patient, and antibiotic use, and many confounding factors. See, they doesn't allow these fever patterns to appear in day-to-day practice. For these reasons, the utility of fever patterns in clinical diagnosis is often limited. This has been stated as early as 1980 by actually Mosher et al. So the clinical pattern is getting less and less relevance in day-to-day practice, even for an adult, than what's so about children. Definitely, they are having a very less significance in children. What about, so if the fever patterns are not of significance, what do about the height of the fever? Even the height of the fever, there is a weak correlation between the height of the fever and severity of infection, whether it is a viral or bacterial. The overwhelming majority of high fever is caused by viral agents. So even the height of fever doesn't make any significance. Then what about what is significance? So if the pattern is not significant, height of fever is not significant, what is significant in day-to-day practice? Only the clinical appearance, the level of alertness in behavior help in determining the child is serious or not. And so the focus of the parents and physicians should be on the child's appearance and behavior, not the height of the fever. So in summary, as Professor Amdekar says, particularly whenever it comes to fever, you should analyze in the pattern whether it is a high fever or a low-grade fever. It is not. It is only the onset and progress of the fever, whether the child is responding to antipyretics or not, and behaving during the interpidal period of and toxicity and vitals. For example, if it is a high-grade onset and the child is responding to paracetamol, and in between the fever, the child is playing around, the child is not looking toxic, definitely we are dealing with a well child, most commonly a viral infection. Whereas even if there is hectic fever, but if the child is toxic and the child is not behaving well in between the temperatures, definitely we say something is fishy and serious bacterial infection has to be ruled out at any cost. This is the summary of particularly when you are applying to day-to-day practice. Then what is the fun of discussing this topic? And definitely whenever Dr. Jagdish gives, there is some sense in the topic. And when I go through the thing, whenever infants and young children are more prone for particularly making the fevers high as well as prolonged, more rapid temperature increases and greater temperature fluctuations. Almost all short duration fever we see in pediatric age group are particularly the 3 to 36 months are hectic fevers. Hectic fevers are common. So that is the reason this topic has been given. So what does it really mean to me? Whether it really means that, unlike particularly it has told already, hectic fevers means it is mostly septicemia, mostly endocarditis, mostly abscess, toxic shock. Is it true always? Is it true always? Let us go through these case snippets. Here is a 8-month-old baby with a high spiking fever for 3 days. On examination, the baby is not sick looking, the vitals are stable, but still because of the parental pressure, we go along with the investigation. Urine is the normal, that is the first investigation. Then the CBC shows leukopenia with other cell lines normal. On day 4, but we told the patient to wait because there was nothing in the investigation. But the next day, the fever settled with appearance of the rash. We know the diagnosis roseola infantum. So here, there is a high spiking fever. But what does this mean? So viremia can cause high spiking fever. This is the second case. Here is again a 8-month-old with high spiking fever with rigor of 3 days duration. Mother says the child shivers a lot whenever the child starts getting the temperature, which is a high and spiking. On examination, the child is looking sick, and in between the paracetamol, the child is also not looking good. But there are no other localizing signs. On examination, find out to be the child was having urine plenty of pus cells with neutrophilic leukocytosis. Mostly we are dealing with a case of serious bacterial infection, that is pyelonephritis. Here is a bacterial infection with a hectic fever or high spiking fever. Okay. Case number 3. Here is again a 8-month-old infant with a high spiking fever of 5 days duration. The child is irritable all the time, incessantly crying. And so on evaluation, found out to be a neutrophilic leukocytosis with CRP in hundreds, but you are not able to find out other common serious bacterial infections, meningitis, pneumonia, and all other infections are ruled out. Finally, it turned out to be a Kawasaki disease. What does this mean? The high spiking fever can be a feature of a toxemia or a super antigenemia. Here, the super antigens are known to be the cause for the Kawasaki disease. So finally, what does a hectic fever, unrelenting fever means? That is, what are the most common etiologies in day-to-day practice are any viremia, whether it is a measles or roseola. For example, on the other day, I had a friend's wife calling me that my child is running 104 fever. What does I do, sir? So I told first 48 hours if the child is looking fine, don't do anything, give paracetamol. The next day I got a phone call, sir, my child is having plenty of oral lesions and drooling of saliva. It is nothing but HFMD. So even a simple viremia of HFMD can cause a hectic or unrelenting fever, and bacteremia can cause high fever or hectic fever. Occult bacteremia is known in the pre-vaccination era. Now it is coming down and down. We all know septicemia presenting with the hectic fevers, and toxemias like scarlet fever and Kawasaki, and finally parasitemia, malaria. So in short, all emias, viremia, bacteremia, septicemia, toxemia, parasitemia can produce hectic or unrelenting fever. So what do as a practitioner I want? I want to know whether I need only a supportive therapy or antibiotic therapy. When it comes to hectic fever, definitely it is not useful in differentiating the thing. So the utility of value, application value of hectic fever is not much, not of great significance in short duration fever in children. So how aggressive the approach should be? This is the second part of my question. Hectic fever plays a no role in the management approach. This is the final statement. Unlike an adults who ask whether I should give antibiotics, hectic fever doesn't play any role in the differentiation of a viral and bacterial infection. Only if the child is sick and toxic, be aggressive in evaluation. If child is non-toxic and well-looking, conventional conservative approach is the norm. If the baby is well-looking, look for the focus or no focus. If there is no focus and well-looking, just paracetamol for 48 hours, no investigation, no antibiotics, evaluate only after 48 hours, whatever the hectic temperature the child may be having. So this is the way the approach should be whenever you come across a hectic fever. So then the next question is, what about the role of the hectic fever in the PUO? Definitely in a controlled environment, when you are admitting a fever in a particularly a child, a PUO in a hospital, definitely fever patterns are useful in pointing to or establishing a diagnosis in children with FIU. However, the character of fever also can be helpful, particularly when you are having high spiking fevers. Definitely it indicates mostly you are dealing with a sepsis related to liver, kidney, or biliary tract, or infective endocarditis, or occult abscess anywhere, brucellosis, rat bite fever, malaria. Unlike a low-grade fever, low-grade intermittent fever, it can be extrapulmonary tuberculosis. So definitely it gives a clue that something you are dealing with this in these lines whenever you come across a case of PUO. So definitely a hectic fever plays a role beyond 7 days of fever. Less than 7 days of fever, hectic fever doesn't mean anything doesn't mean much for a pediatrician, whereas in case of PUO, definitely hectic fever plays a major role. So finally, what are the take-home messages? What about the fever patterns? Fever patterns still play a role in reaching a diagnosis for an obstetric clinician wherever, particularly when it is applicable. Hectic fever in an infant and young child is the norm. But during consult, hectic fever doesn't play a major role in diagnostic and management approach. Only the sickness and toxicity decides everything in short duration fever, not the hectic fever. Whereas in case of PUO, certainly hectic or high swinging fevers point towards certain specific diagnosis. Now you come to that thing, final norm. The answer of the question is how common is hectic fever in children? Definitely very common in day-to-day practice. It is the norm in 90% of the or 80% of the children. Then what is the utility value of hectic fever? Definitely it is not of utility value in young, not of utility value in a short duration fever, whereas it is a utility value in a PUO. Thank you, one and all, for the opportunity. Thank you very much.
So thank you, Dr. Palinaman, for the excellent talk on hectic fever. As you already mentioned, treatment depends upon the patient is sick or not, and you have to look for any focus for the fever or not. So more than you don't get the proper pattern nowadays due to overuse of antibiotics and antibiotics. That is some of the presentation by Dr. Palinaman. Any questions there in the chat box? There's no questions in the chat box. Any questions from the panel members?
Dr. Palani, can you explain why small babies get hectic fevers?
Small babies hectic fevers. There are 2 to 3 philosophies. One of the philosophy is they are immunologically actually not one explanation is immunologically not potent. So the antigenic load or infective load is more and the body is reacting high. This is one of the explanation in the earlier literature. Now the reason Nelson has told, young children mount a high temperature febrile response for any given antigenemia. This is the second explanation. These are 2 explanations given in the literature.
Hectic fever, not very, the terminology, as you mentioned, it's not a very common issue. Fever followed by crisis and followed by lysis. It was there when we are studying.
Yes. Particularly the pneumonia by crisis and the typhoid by lysis were known for a long period. Particularly when we are undergraduate days, these fever patterns are a very role. Now the latest Harrison even doesn't mention about the fever patterns. So that shows it has lost its significance in nowadays.
So nowadays we are giving antibiotics before vaccination. So there's not time to develop fever.
Even the pneumonia child is not having fever, as Amdekar says, by giving a potent antibiotic like Nimucilide. Even the pneumonia or meningitis doesn't respond with the fever. So that is the way our people are handling with respect to fevers.
So if there's no more further questions, we'll wind up the session. Thank you, Dr. Palniaman, for the excellent talk. And also, I would like to thank the Fever Foundation and Jagdish Chinappa sir for the opportunity. Thank you.
Thank you.
Thank you, sir. Thank you, Anandkesavan sir, and thank you, Palaniaman sir, for the nice talk there. Hectic fevers in children. How aggressive should we get?
Krishna, you're not audible. You're not audible.
Yeah. So I thank both Dr. Anandkesavan sir and Dr. Palaniaman sir for the previous talk on hectic fevers in children. How aggressive should we get? Now moving on to the most awaited or the different thing which we are introducing for the first time in the FeFCon conference, the clinico-pathological cases. I hand over the session to Dr. Jagdish Chinappa sir to deliberate and to take over and introduce our moderator, Dr. Subbarao sir and Dr. Nagbhushan sir, the discussant for the CPCs.
I think I've got a very easy job today because I don't need to introduce either of them. I think they are known wide across the country for their expertise in clinical medicine. Dr. Subbarao is a senior consultant in Manipal Hospital. He was formerly the professor in HOD at St. John's. He was the president of the IIP respiratory chapter. He has got numerous publications, and more than anything else, his passion for teaching knows no bounds. He's always teaching PGs, UGs, and wherever he gets a chance. So today he's going to teach us a lot about the case scenarios. So thank you very much, Dr. Subbarao, for being there. Dr. Nagbhushan is one of the most astute clinicians who's been very, very famous across the
Next slide,
country.
please. Next slide.
Well, I don't need the slide. I know
Yeah,
him so well that
fine.
I don't need a slide at all.
All right.
If anybody asks who is one of the most leading organizers of teaching sessions for UGs and PGs, it is Dr. Nagbhushan. He is right now attached to the Rainbow Children's Hospital. Formerly, he was with the CSI Hospital. He has been the lead person for the asthma training module. He's been running the ATMs very successfully. Very astute clinician, and we will have a wonderful session with these two senior teachers of both PGs and UGs. So I hand it over to Dr. Subbarao to grill Dr. Nagbhushan and see how much he doesn't know.
Yeah, thanks, Dr. Jagdish, for the kind introduction. Since it is a new format for this conference, I'll just give a brief of how it goes about. Then we can have the session starting. Generally, in clinico-pathological conference, we have a case given and it is circulated to all the participating members who make an effort to analyze and have their own opinions. And here, the discussant I have chosen, Dr. Nagbhushan. Same material has been given to him, but let me assure you that he doesn't know anything about the case. It is an actual case which has managed. So whatever he is discussing, as though he's seeing the patient for the first time. So that is the inside information. Now, as we do in our day-to-day teaching, what we do is Dr. Nagbhushan will present the summary of this case in three split patterns. One, at the end of history, he will deliberate on the points that have been given, history and examination. Then we will open this discussion to other panelists and other participating members to either put their points of view or seek some clarifications on Nagbhushan's line of thinking. Then he goes on to analyze the investigations and gives his opinion. And similarly, after he finishes his talk, then the panelists and the participants either can put in the chat box or openly ask questions or air their points of view and clarify certain points what Nagbhushan has raised. And finally, before Nagbhushan tells his diagnosis, we'll have the session open again to see what they would like to do. And then Nagbhushan will tell the diagnosis. And then finally, I was a treating physician, hence I shall reveal the diagnosis. So here the platform is more for Nagbhushan and I shall be only doing the moderating job. So if that pattern is clear, we'll request Dr. Nagbhushan to share his slides and go on with the discussion. Nagbhushan? Nagbhushan, you can start. You're not audible.
Unmute, sir. Dr. Nagbhushan.
Yeah, at the very outset, thanks to Dr. Jagdish for choosing SEPC. And I would thank Dr. Subbarao in the end because he has given me a difficult job to begin with. And I tried my best to question him this way or that, but a tough nut as he is, I was not able to crack it. Be that be as it is, let me try to do my best with the motto of saying, how do I move the slides? Krishna, how do I move the slides? Enter or
You can either the up and down button, sir, or just click on the space bar, sir, once. Then it will become unfreezes.
It will click on the
space bar.
It's not happening.
Maybe that's what it has got stuck. Yours, the slides has got stuck.
What shall I do? Shall I stop sharing and do it again? Dr. Subbarao also has these slides.
It is coming, sir. It is coming up again. Yeah.
Yeah.
It is coming through. Yes,
Yeah.
sir. It's moving across.
Let us start with the case scenario. This is a 9-year-old girl. And we know in pediatrics that age and sex matter when children present with illnesses. And she was a girl who presented with history of fever of 12 days duration. The fever was moderate to high with chills and rigors. It was a continuous fever with the temperature being relieved temporarily with antipyretics. Fever spikes would occur every 4 to 6 hours. There was no diurnal variation, and the fever would not touch baseline despite antipyretics. So, what do I understand by this very first slide? In a 9-year-old girl, if this girl has fever of 12 days duration, the usual fevers in children, most of which are viral, which are much more common in preschool children, is not an entity to be considered here. Number two, a fever of 12 days rules out common infections which would settle down by this time. Further, this girl has a fever which is not accompanied by any other system involvement as of now in the form of cough, cold, sore throat, red eye, watery eyes, vomiting, loose stools, or a skin rash. However, the possibility of Epstein-Barr infection can be considered because that is one fever that can go on and on and on. In a continuous fever with regular spikes without diurnal variation, not touching baseline despite antipyretics, would generally make the common viral infections less likely. Now, as Dr. Palini Raman very clearly said, response to paracetamol does not differentiate an illness between bacterial and viral. So we have a child who is showing fever as a sign of inflammation. Whether this inflammation is infection triggered or triggered by anything else is what we have to look for. 4 days, and before I go into the next slide, a 9-year-old girl, what are the common infections that we would look for? The common bacterial infections in a 9-year-old girl could be pneumococcal, streptococcal, salmonella, tuberculosis, mycoplasma, and rickettsia. So these are the common bacterial infections that we would look for. Now, based on only the history, a good number of these can be ruled out. As we discussed, Epstein-Barr virus is to be kept in mind. And since this is the age of 9 years, inflammatory disorders, particularly in a girl child, autoimmune conditions, and malignancy, in that order, we need to keep in mind. 4 days after the febrile illness, she was noticed to have bilateral cervical lymphadenitis by the referring doctor. The child received oral amoxicillin for 7 days with no clinical response. Baseline investigations done by the referring doctor, including urine routine and microscopy, were normal. I need a little more details here. Number one, this cervical lymphadenitis, was it tender or non-tender? If it is a tender lymphadenitis, then my thought process would be a acute inflammatory, mostly infective lymphadenitis. Number two, I need to know the dose and the compliance when amoxicillin was given. Amoxicillin in a good dose of 50 milligram per kg given for 7 days would be a good antibiotic for acute suppurative lymphadenitis. So presuming that this child has taken the oral amoxicillin in the right dose, right frequency with normal compliance with no response, this child is unlikely to have the common bacterial lymphadenitis that we would generally encounter. And for a bacterial cervical lymphadenitis, there should be a focus somewhere in the throat or in the skin or in the scalp, and that is not forthcoming. She has no significant past illness. Growth and development were age appropriate. She was fully immunized, including typhoid vaccine. What do I understand by that? A child whom we consider the possibility of a autoimmune condition or a immune deficiency condition is unlikely not to have any symptoms by the age of 9 years, whether it is T cell mediated or B cell mediated. A de novo primary immunodeficiency disease at 9 years is a little unusual at this age. And whenever children have any of these disorders, the growth and development will generally not be age appropriate. Despite the child being immunized with typhoid vaccine, still paratyphoid infection is possible. That is one consideration that we need to keep in mind. Now, at this point in time, I would like to ask myself three important questions. Am I dealing with a normal host or an abnormal host? Looking at this child's growth and development, looking at this child's past history, I would consider this girl as a normal host. She has no antecedents to consider her abnormal all of a sudden. The second question I would like to consider is whether this child is at high risk for serious bacterial infection or not. This child is less likely to be a child considering for serious bacterial infection. One, because of her age, serious bacterial infections are much more common in infancy, not at 9 years. And number two, 12 days of fever and she is stable. So the chances of a serious bacterial infection, I would put it a little lower on my cards. The third question I would ask myself is whether this girl is stable or unstable, meaning whether her vital parameters are normal or abnormal. So the fact that she has tolerated fever for 12 days without significant problems means that this girl is a stable child. So that's the understanding. The family history was not contributory. There was a history of contact with tuberculosis. Her second cousin, age 16 years, was suspected to have systemic onset JIA 2 years ago and is now okay. Now, none of these seem to me very specific to me, and this red herring of her second cousin having JIA may not matter much to us. However, JIA is still a consideration in this child because many times up to 4 weeks, these children present only with fever and the other manifestations of JIA can occur later on, but that may not have a bearing to her cousin having JIA. What is more important to me is her travel history. She has gone to her native village and stayed there for 2 weeks. What she did there, did she go hiking? Was she in contact with animals? Was she in contact with pets? Did she eat any unusual food like squirrel meat or etc. etc.? These are possibilities that we need to consider in considering the possibility of a zoonosis that would cause fever in this 9-year-old child. Now, what could be our deductions at this point in time? Tuberculosis is the commonest. Can tuberculosis present with high fever? Rarely, yes. That is a consideration in any child in our country. And tuberculosis can manifest with any sort of presentation. A fever of 2 weeks is something that we need to consider. The next consideration, as we discussed earlier, would be Epstein-Barr viral infections. The third possibility I would consider, particularly because she has traveled, is the possibility of leptospirosis. It would be good for us to understand that even if pet dogs have been given leptospira vaccine, it does not prevent the pet animals to harbor leptospira in their body, though they may not suffer from it. Is typhoid possible? Typhoid is a common illness that we would keep in mind. However, in typhoid, the possibility of cervical lymph nodes is very, very unusual, though the lymph tissue in the intestine are affected. Can she have rickettsial fever? Possible, because she has fever, she has got a cervical lymph node enlargement. But the only point that is not favoring rickettsial fever in the history is that the incubation period of rickettsial fever from the time of contact is between 1 to 2 weeks. And this duration does not fit in this particular child. I would also like to consider the possibility of infective endocarditis, because these days we know that infective endocarditis can occur even in a child with normal heart anatomy. So that's a possibility that I would like to consider. Which zoonosis comes into my mind, and that is acquired toxoplasmosis. They can have fever, they can have lymphadenopathy, they can have organomegaly, etc., etc. Would I consider non-infective illness? Yes. The first non-infective illness top in the list would be juvenile idiopathic arthritis, because this is a girl child, she has got fever of 2 weeks. That is a possibility. Autoimmune disorders like SLE or the other vasculitis are also a consideration. Lymphoreticular malignancies are very low in the list. Is she likely to have a fungal disease? She has traveled, so all these fungal diseases are still a possibility. Ravi Shankar discussed something post-COVID. Am I dealing with an atypical Kawasaki? The clinical features do not give us much clues to consider the possibility of Kawasaki. Last but not least in the list, am I considering the possibility of drug fever? Drug fevers are known to occur in children who are on medications. The classical presentation of drug fever would be that the fever spikes occur at the time of administration of the drug, and within 3 days of stopping the drug, the fever touches normal. So that would be my take as far as the history is concerned. Thank you.
Okay. This is like the first 6 overs of a T20 match power play. You have wild hits, you may get sixers, you may get no runs, sometimes you may get out also. So Nagbhushan had wild swings at infections, at inflammations and autoimmune, and also at drug fevers. So with his line of argument, he has ruled in and he has ruled out certain conditions. Just for a clarification, he had asked for one doubt whether the lymph nodes were tender or not. The doctor clearly said they were not tender lymph nodes, right? And the antibiotic course was given, was appropriate for duration. Now, with that thought process, I'd like to see if any of our panelists have any other different line of thinking, or would you agree with Nagbhushan's line of thinking? So before we go further into the discussion, you can raise your hand and please answer so that we save time. Anybody?
Yes, sir. Me.
Yes, Jagdish, sir.
I think it's a very interesting case and well discussed by Dr. Nagbhushan. I have some more thoughts which I would bring in here. Right now, we have a child who has had fever for about 12 days, a 9-year-old child, and has had basically just the only physical sign that you have told me right now is that this child has bilateral cervical adenitis. But we don't know whether this child had any inguinal adenitis, any axillary adenitis, any splenomegaly. That has not been mentioned. So this seems to be, is this a generalized disease or this is a localized disease? We do not know that. So while I agree with Dr. Nagbhushan that we should definitely consider EBV as one of the possibilities and toxoplasma, which will produce an EBV-like picture, we also need to consider other disorders like CMV, which also can come with cervical adenitis, IM-like picture. And also we need to look at whether there is a possibility of HIV, because HIV also can come to you with prolonged fever at this stage. It's not as if that this should be a chronic disease. It could be an acute HIV. So that is one thing we need to keep in mind. The absence of tenderness probably at this stage may rule out Kikuchi, but that's one thing which I would keep in mind. The other things, as far as travel is concerned, brucellosis, especially if she's traveled to a village, needs to be kept in mind, because that again is an RES disease with prolonged fever. Now, as far as the one observation is that this child was given amoxicillin and did not develop a rash. So infectious mononucleosis may be slightly lower on the cards on that kind of a finding. Now, the typhoid vaccine was given, but we don't know which vaccine was given and when it was given. So if this vaccine has been given at 1 year of age, then this probably is of not much significance. So typhoid also needs to be considered. We have also looked at other possibilities, but see, these are some of my thoughts. I would still say that the door is wide open. We have basically 5 groups of conditions we need to look at: an infective disease, either bacterial or viral, a rheumatological disease, an immune-mediated disease, a malignancy, and disorders of unknown etiology, like even, for example, Langerhans cell histiocytosis could come with prolonged fever. So any of these are still possible. We don't have anything specific to tell us which one it is.
Yeah. So basically, you are agreeing with Nagbhushan's line of discussion. In the chat box, we have got an additional differential of Kikuchi's disease, which Jagdish has just touched upon. For want of time, we have no other raised hands. So I'll ask Nagbhushan to proceed.
The only point that I would like to also add is that if you are considering the possibility of Epstein-Barr virus infection, skin rash is much more common to ampicillin and not to amoxicillin. Ampicillin-induced skin rash is something that is known. Now, on examination, she was toxic and febrile. Recorded temperatures ranged between 101 to 103. She had chills and rigors with raised temperature, bilateral cervical lymphadenitis, non-tender, non-matted, measuring 1 to 2 centimeters. There were no signs of inflammation and no sinuses or fistula. She had a single left axillary lymph node measuring 2 centimeters, non-tender. BCG scar was visible on the deltoid aspect. What do I understand by this slide? This girl has got subacute lymphadenopathy because the lymphadenopathy is almost occurring at around 2 weeks of time. The non-tender lymph nodes also gives us clue that they are in 2 anatomical sites, particularly the axillary lymph node. Now, are they significant? Any lymph node in the cervical or in the axillary area, which is more than 1 centimeter, is clinically significant. And in the absence of tenderness, acute suppurative inflammation of the lymph nodes are a little less likely. I would consider the axillary lymph node much more significant than the cervical lymph node, because the axillary lymph nodes do not generally enlarge except in situations where you have a BCG vaccine. If the axillary lymph node is involved in any particular situation, it is very important. So where do we stand now? We have a child who has got systemic onset illness with fever and toxicity, and the fever is quite significant with involvement of the axillary and the cervical lymph node. Now, I was interested to ask Professor Subrao whether there was a reaction around the BCG scar. Because if you have a typical
BCG scar was normal, no reaction,
so
no flare.
that is not there, then I would keep the Kawasaki disease a little below in my list. Now, I would want to do a clinical examination in this child, completely undressing the child to try and see if we could get an HR. Where would I look at? I would look at the axilla because I have a lymph node there. I would look at the nape of the neck and the hairs around. I would look at the perineal and the perianal areas as well as the inguinal areas. She had mild pallor and no icterus on admission. Her weight was 25 kg, expected is 27. She is 25th centile and her height was 133 and expected was 131, which means this girl is a well preserved child before the onset of this febrile illness. Pallor could indicate many things in a febrile child, and with the significant lymph node involvement and pallor, we also need to consider the possibility of whether the bone marrow is involved. Now you have this child who has a 4 centimeter spleen, which is soft to firm, non-tender. Her liver was palpable 4 centimeters below the costal margin and non-tender. The other systems were normal. In view of the cousin having diagnosed Sogia, a detailed musculoskeletal examination was done, which was normal. For any signs of joint inflammation, there were no signs of admission. Now, in addition to fever, which started first, in addition to bilateral cervical lymphadenopathy and left axillary lymphadenopathy, we have an addition of the hepatosplenomegaly, which means this child has got a significant febrile illness with involvement of her lymphoreticular system. And therefore, we need to focus on diseases which could cause the involvement of the lymph nodes as well as the hepatosplenomegaly. One thing that bugs me is the soft to firm spleen. Generally, in an acute infection, the spleen is soft to palpate. A firm spleen will always tell us that the spleen has been there for quite some time. And most of the acute infections, particularly hepatitis, the acute inflammation generally causes little bit of pain and tenderness, and here both of them are missing. Whether she had an evanescent skin rash with high fever is something I would want Professor Subbarao to answer. Now,
No
there
rash.
are
No evanescent rash.
So now there are a few no's here. We considered enteric fever, but enteric fever does not cause cervical and axillary lymphadenopathy, nor does it cause a soft to firm spleen. In fact, the spleen in enteric fever is soft and small. Many times we struggle to feel the spleen, and a 4 centimeter spleen in a child with enteric fever is very, very unlikely. And a girl with enteric fever has the timetable that in the first week it is non-specific symptoms. In the second week, which this girl has, is a week of respiratory symptoms. And this girl does not have any respiratory symptoms. And the third week is the week of GI manifestations. At this point in time, I would like to remember that great dictum that uncommon manifestations of common diseases are much more common than the common manifestations of uncommon diseases. While in working diagnosis of enteric fever, we have discussed this. Mantoux test was done at 72 hours and the induration was 8 millimeter. I have two comments on this. Number one, in a 9-year-old child, even without tuberculosis, we are likely to get a positive Mantoux because that is the age at which Mantoux positivity increases. And this girl has got just a 8 millimeters Mantoux. So that makes tuberculosis less likely, but she has been subjected for lymph node biopsy. So I didn't think that the lymph node biopsy would yield tuberculosis because of the acute response as well as the age of this child. And in cervical lymphadenopathy, Mantoux positivity is likely to be much more than in other forms of tubercular disease. Our understandings and possibilities so far. I think I will go to this and come back. While on antibiotics, she was found to have mild icterus and the liver, which was palpable at admission, increased in size and became tender. And then the abdominal ultrasound, which said hepatosplenomegaly with a few mesenteric lymph nodes, etc., and normal ecotexture. So what is our understanding about this? Now you have lymph nodes in the cervical area, you have lymph nodes in the axillary area, you have lymph nodes in the mesenteric area also. Plus you have hepatosplenomegaly. What are our possibilities we would consider? And the liver, which was non-tender, has become tender now with increasing size. That means this liver is acutely inflamed. Is this liver acutely inflamed due to an infection, or is it part of an inflammatory process? The common things that we would consider: hepatotrophic viruses. Common among them would be hepatitis A and other viruses. Hepatitis A can cause fever, non-specific symptoms, and may or may not develop jaundice. That is what most children have, but this girl has got uh, fever, lymphadenopathy, hepatosplenomegaly, and tenderness. So that is one possible consideration of a viral etiology which has tendency to involve the liver. Does she have Weil's disease? Now, leptospirosis can present in eight anictric and icteric forms. This is the icteric form of leptospirosis. Now, the point which is against leptospirosis is the absence of severe muscle and joint pains. These children have intolerable muscle and joint pains before they develop icterus, and that is what is missing. Now, are we considering the possibility of brucellosis? Because this girl has traveled to her hometown, she would have consumed milk which was not pasteurized. The ultrasound does not show microabscesses. Does that make brucellosis unlikely? The answer is no. Less than 50% of children whom we suspect brucellosis only have microabscesses in the liver, and the others may present with no microabscess in the liver. But the other features with which brucellosis manifests are not forthcoming. Lymphadenopathy is a possibility. Now, I would continue for
one second, Nagbhushan. Just for a few seconds, ask the opinion of the panel. At the moment, you have brought in hepatotropic virus, and secondly, you have said tuberculosis is unlikely in this situation, and you have brought in a possibility of brucellosis. My question is, what is the explanation for a liver which has 4 centimeters to suddenly, under supervision, become large, and then child is having icterus? That's the question you have to answer. But before that, let me see if any panelists have got a different viewpoint, and Nagbhushan can answer this acute onset liver insult. Anybody?
Yeah. I think Dr. Nagbhushan has very nicely analyzed the case. Now let's go back to, I think, looking at to why this liver has suddenly enlarged in size. How can the liver enlarge? Basically due to either there is a congestion in the liver, either there is an infection in the liver, either there is an infiltration in the liver, or there is an immunological reaction in the liver. So something like that is happening here. So what is happening here? Is this a congestive hepatomegaly? Or is this a infective hepatomegaly? Or is this related to an infiltrative hepatomegaly? Or the other possibility is this drug induced. You have been giving ceftriaxone. So what was the liver function prior to starting, and the alkaline phosphatase prior to starting ceftriaxone? So is this child going into hepatocellular involvement because of a drug? So I think we need to look at it from various viewpoints rather than just one. And if you ask me, my overall look at this child is this child has a RES disease, some reticuloendothelial disease, because you have all organs of the RES primarily affected. You have the lymph node in multiple sites, you have the liver and the spleen. All these are affected without much involvement in any of the other organ systems. You don't have any other organs which are primarily there. Now, basically, how can this happen? This can happen due to 4 conditions. One is this could be an infection which is producing it, which is primarily an RES infection. What are the primary RES infections? Basically, 3 of them, which we need to look at chronic infections. One is this likely to be tuberculosis? Is this likely to be brucellosis? Is this likely to be something like a rickettsial infection, which can affect the RES? So these are the 3 main bacterial disorders. The other thing, of course, viral, we have already discussed, EBV and the EBV group and HIV. So I think what we need to do is to look at what is the cause of this RES involvement. The second group is the immunologically related issue. The third group is the storage disorders. Is this something which is causing a problem? And finally, is this a malignancy, which we have missed completely? So I think what we need to look at is we have to go back into our history, look at all this. The other thing which can do it, which Dr. Nagbhushan mentioned, is this likely to be an SBE, which is producing a high immune load, and therefore the RES is getting stimulated. So there is a combination of both infection, immunological reaction, and probably some degree of congestion, which is causing the jaundice. So I think we need to look at all possibilities, because right now we don't have any clear idea.
Yeah. Thanks, Jagdish. And Nagbhushan, your take on this sudden liver enlargement tenderness.
I would consider the increase in liver size as a part of the primary inflammatory process itself, which means that the ceftriaxone that you had started made no difference to the child. And therefore, that same inflammatory process that had started the hepatosplenomegaly increased further. To me, the same inflammation is increasing and getting further. Now, the other possibility that I would consider is that of a vasculitis. Now, in vasculitis, the only point that is unlikely is that the lymphadenopathy. Vasculitis generally does not cause lymphadenopathy, and therefore that is the point that I won't consider only on this basis. Now, is
this
it
child, one second, this child has been in the hospital for some time.
Yes.
Could the liver instability be a super added problem on top of an underlying already liver disease?
Now, this child has got a hepatomegaly of 4 centimeter, and that had happened before the child came into the hospital. And this child continues to have fever. This child has no other symptoms, and therefore to consider another infection on top of this infection, to me appears a little less likely. As they say in medicine, put your apples in one basket. And before I conclude, this child is unlikely to have a metabolic disease or an infiltrative disease. Age-wise, 9-year-old to get any infiltration, like Gaucher's, etc., is a little unusual. And there, the involvement of the organs would be much more than what this child would have got. And number two, there it is an interstitial inflammation, and jaundice or the pain is a little unusual. So I would consider acute ongoing infection, an inflammatory process, much more in the list. Number three, Dr. Jagdish mentioned about malignancy. Now, malignancy is one disease which can present with many symptoms. Now, what symptoms of malignancy are okay in this child? Number one, this child was well preserved before she started fever. That could happen. Fever is okay. Lymphadenopathy is okay. Hepatosplenomegaly is okay. But she has very mild pallor. Pallor is something that usually accompanies a lymphoreticular malignancy, and that is not very forthcoming. So I would rather keep malignancy low in the list.
Just to put things in proper perspective, the liver was palpable 4 centimeters at the time of admission, but the new symptom of it enlarged more than 4 centimeters while in the hospital. The liver, which was not tender, became tender in the hospital. So that is what you have to look at. Before that, I'd like to say, I want Nagbhushan's response on Palini Raman has said, is there a possibility of HLH in this patient?
The possibility of HLS is less likely in this child, particularly because HLH is an acute rapid presentation. And this child is not going in a rapid way. This child is going in a much slower way as compared to the presentation of HLH. And I wouldn't consider HLS as the possibility in this child.
If I can come in here, I think we need to look at it in a different way. And that is, see, this child has been running fever. Maybe the initial fever was dengue. We don't know. We only are seeing that child after so many days. So this could be a post dengue HLH complication. So I don't think we should go by saying that HLH is not possible. I think the important thing that we need to note is right now we have certain probability of disorders and less probability of disorders. But everything needs to be kept in the basket because we still don't know what's going on. We still need a lot of information.
Yeah, I think HLH as a possibility is necessary because line of treatment and aggression with which we do affects the mortality and morbidity. So I would not totally discard. I would probably investigate for it, and if it's negative, probably rule out. Okay, Nagbhushan, over to you.
Lymph node biopsy reported as reactive adenitis and was negative for gene expert for Mycobacterium tuberculosis. This is what we expected. In view of continued fever, doxycycline and ofloxacin were added to the treatment. She developed a erythematous malar non-pruritic rash. The repeat musculoskeletal system exam was done and was sent for connective tissue workup, and ANA and anti-dsDNA was negative. A rheumatology consult did not consider SLE in view of negative lab reports. In view of travel history and persistent fever, possibility of rickettsial fever was entertained, and oral doxy was changed to IV doxy as she was not tolerating the oral medication. Despite this, the fever continued and the child was discharged on IV antibiotics with a request to continue. Now, the comment here, now we were having fever, lymphadenopathy, hepatosplenomegaly, and now we have a malar erythematous rash. So that would make us consider the possibility of a connective tissue disorder in the differential diagnosis. A word about anti-ANA and anti-dsDNA. Now, it is always possible that the immune responses occur in three zones, the pro zone and the other two zones. In the pro zone, there will be an excess of the antigen or the antibody. And so sometimes it is possible that despite this being an inflammatory disorder, unless you do this test in frequent low dilutions, there is a possibility of missing the test result here. And a comment about persistent fever, which was considered as rickettsia. As we discussed earlier, the incubation period for a rickettsial disease is maximum 2 weeks from the time of exposure. And this girl has gone to her village a month ago, and the fever has been about 12 days. So rickettsial fever, according to the way it behaves in its natural history, is not very high. Number two, IV oral or IV doxycycline, it is said that if it is a rickettsial infection, the response to doxycycline, either oral or IV, is relevant and it is evident within 48 hours of treatment. And here you are given oral doxycycline followed by IV doxycycline. If this child had rickettsial infection, she would have at least shown some partial response. And a word about the use of ofloxacin. The IAP guidelines on rickettsial infection 2017 says that doxycycline is the first drug of choice and azithromycin is the next drug to be added if the response to doxycycline is not very forthcoming. So if the response to doxycycline is not satisfactory, the possibility that this girl had a rickettsial disease is lower on the cards. But we would also like to look at the other non-specific markers of rickettsial fever, like hyponatremia, like hypoalbuminemia, like thrombocytopenia, like leukocytosis, etc. They would give us some corroborative clues to the possibility of rickettsial infection. She was last for follow-up for 2 weeks. She was found that she got admitted to another tertiary care hospital where antibiotics were upgraded to meropenem. A bone marrow aspiration and biopsy was done, which was negative for malignancy. What do I understand by this? Number one, that this child continued with the inflammatory process, and that is why she got admitted to the hospital. Number two, the treating pediatrician has been seeking solace with upgrading the antibiotics, but then there has been no response. So that means upgrading antibiotics is not the answer to this child. We need to look at the differential diagnosis. A bone marrow aspiration and biopsy was negative for malignancy. That is fine, but I don't know what else the bone marrow found. What else can you find in the bone marrow? Number one, bone marrow is a good site for aspiration and culture. We were considering the possibility of brucellosis. We know that brucella grows slowly on the heart-brain medium, and therefore bone marrow could have been a good opportunity for us to draw blood. Even enteric fevers are much more likely to be positive in the bone marrow if you miss it out in the peripheral blood. Well, apart from malignancy, what else they found in the bone marrow is something that we are not aware.
The information, what I got later on, after I did this summary, was that the bone marrow cultures were negative. Bone marrow is again sent for tuberculosis workup, that was also negative. That's the only two investigations they sent.
So at this point in time, we have probably ruled out malignancy because the lymph node did not reveal anything, nor did the bone marrow reveal anything. High on cards would be a chronic infective process, and next to it would be an inflammatory process, the classical feature of which is not very, very evident to us. It is still possible that some of these features may come up over point in time, but at this point in time, that is what we are finding. Now,
shall we assume, Nagbhushan, that you have ruled out some of the conditions that you had entertained initially? That is, your common infections like typhoid and rickettsia you ruled out.
Yes, yes.
Tuberculosis you have ruled out.
Yes.
Malignancy is definitely not on your cards.
No.
So at this stage, what is your thoughts as far as the initial DD and now what is it changed into?
Now, I would still consider the possibility of brucellosis, which is still possible because she has had a travel. I would still consider the possibility of other zoonotic infections because she has had a history of travel. I would keep on cards the possibility of an acute, subacute inflammatory process like the connective tissue disorders in my mind in view of her age and sex.
Yeah, Dr. Palani says he would like to keep in mind a condition called melioidosis.
That is also possible, like the unusual infections which I discussed earlier, but that again will be diagnosed only by investigation, and there are no other clinical clues to the possibility.
There's a suggestion query whether child lost any weight, significant weight during the hospitalization. The answer is no. Whatever was recorded, there was no significant change in the weight. Okay, any other thoughts?
How was the clinical state after 2 weeks? I mean, what happened to the liver? What happened to the spleen, the lymph nodes, the fever pattern?
No, there was no change in the liver size. No, lymph nodes are the same. The only thing, the jaundice, which is clinically apparent, probably subjectively it was looking little less, but tenderness was definitely there when they requested for discharge against advice.
No, when the child was seen after 2 weeks, was it the same?
We don't have the information because it's another hospital.
Shall I go ahead?
Any other thoughts? Okay, go ahead, Nagbhushan.
Investigations. Let us look at the CBC. The hemoglobin is 10.5. The other things are okay. Look at the neutrophil count. It is grossly low, which is 9.7%. I was just looking at a primary immune deficiency in view of absolute neutropenia called the autoimmune neutropenia due to Na2 deficiency. But this is a chronic autoimmune neutropenia, which means that this girl should have had this recurrent infections even in the past, and therefore based on one value and a girl who was normal until the age of 9 years, that is little unlikely. Platelet counts are slightly low, and let us look at the ESR and CRP. I think I've learned from Dr. Subbarao that when you consider a connective tissue disorder, the ESR and CRP will be sky high, meaning which will be in hundreds. And here you have a girl who has got a CRP and ESR, which are not very grossly high. And therefore, considering the inflammatory disorders, including the atypical Kawasaki and other inflammatory disorders, this ESR and CRP makes them a little less likely. So where are we? We are at mild anemia. And look at the WBC count. This count rules out quite a few things. Number one, it rules out malignancy in addition to the normal bone marrow examination that has happened. Now, it also rules out those acute infections where leukocytosis is very, very likely. A low WBC count can happen in a very few bacterial infections. The commonest among them is typhoid. You have given ceftriaxone, and the clinical features are not like typhoid. Now, in typhoid, you will have eosinopenia and lymphocytosis, but you don't expect a neutrophil count as low as 9.7. So there is something that is happening with the WBC count with a low WBC count despite the fever of quite a few days. Now, bilirubin 2.2 and 1.94 unconjugated hyperbilirubinemia. But look at the albumin. We were looking at the possibility of rickettsial disease where hypoalbuminemia could also be a feature. Now, when does albumin become low? Albumin becomes low in your LFT when the child has got a significant liver involvement of more than 3 weeks. But here we have got a child who has got fever of 12 days duration and the total protein is normal. So is this albumin low a technical error, or if it is low without a technical error, then we would consider the possibility of the child going in for a chronic liver disease or the possibility of a rickettsial fever with a low albumin. And the enzymes are high, but they are not very high to indicate the possibility of a drug-induced liver disease. Because in a drug-induced liver disease, the enzymes are pretty high, and that rules out the possibility. So where are we now? We are looking at the possibility of involvement of the liver by the inflammatory process, which is significant as evidenced by the decrease in total albumin. The blood cultures, no growth. As we discussed earlier, Brucella culture takes quite some time, so we have still not ruled out Brucella with the blood cultures. What the blood cultures would rule in, if it was done before the taking of an antibiotic, salmonella is one thing that you can pick up easily with a blood culture. So that is a little unlikely. Typhi.im and Vidal are negative, which was expected. Now look at these tests. It is said that all these immunological tests are significant if the derived values are at least 2 times or more as compared to the cutoff values, and none of these are 2 times more. But these values should be considered with a pinch of salt because they would be done at a particular point in time. And we know for sure that the immune response gets better with time. So I would rather repeat these tests after a gap of at least a week or 10 days in order to see if there is a rising titer to the IgM or immune response for these situations, because we are considering the possibility of typhus and brucella quite significantly in our discussion. Now we have discussed about these tests, and probably repeating these tests with dilution is what we would like to do, because she is a girl child, 9-year-old, hepatosplenomegaly, lymphadenopathy, and a skin rash. So the possibility of a connective tissue disorder is also possible. But in a 12-day history child, to have as many as these in a child with collagen vascular disease is a little unusual, because these diseases unfurl themselves over a period of time. And this 12-day time is too short a time for me to consider the classical presentation of a collagen vascular disease. As expected, chest X-ray is normal. What have we ruled out? We have ruled out the possibility of those disorders which will involve the mediastinal lymph nodes. For example, tuberculosis. In a 9-year-old girl, tubercular lymphadenopathy is unusual because that is the presentation of infancy and younger age group. In 9 years, we expect more of fibrocavitary tuberculosis or reactivation tuberculosis. Hodgkin's and non-Hodgkin's can present with lymphadenopathy. They are ruled out. And the other diseases which present with mediastinal lymphadenopathy are ruled out. Lymph node biopsy has not given us.
This is a review of the previous biopsy slide in the different institutions.
So it has not given us any new insight into the possibility of the infections. Now, we have not done a rheumatoid factor test. Toxoplasmosis is generally manifested with eye symptoms and isolated cervical lymph nodes, many times with myocarditis, encephalitis, etc. And toxoplasmosis can occur in a immunocompetent host. What is my take? This child had a cervical lymph. 2 minutes, sir.
Yeah,
the
okay.
child had a cervical lymph node biopsy, and as I discussed earlier, I would probably do an axillary lymph node biopsy too because the cervical has not picked up anything. But as a clinician, what would I do? A second look at the clinical history and clinical findings, as well as repeating the investigations which were done already. I said they were cross-sectional in nature, can sometimes give us clues because most antibody-based tests show raising titers after a time gap. In short, this child has got an inflammatory process which is persistent and unresponsive to the antibiotics that have been given to the child. I rest my case.
Okay, just before we go, just read some things that has come in the chat box. Palani has said, leukopenia and ANC are very low. That will direct to bone marrow issues. If the ANC continue to persistently low, we have not done any repeat CBCs, only 2 values they have. Hence, that is not valid. And Dr. Ashwini has said, why not stop antibiotic? Yes, in the second admission to other hospital, a trial of stopping of antibiotic for 48 hours was given and the fever did not change. Dr. Ashwath came late and we already discussed Kikuchi, but I think his comment is in the context of presence of histiocytes in the biopsy. So what is your comment on the histiocytes on the biopsy? That is for Nagbhushan. And rest of the panelists, if you have got any different thoughts on the after the history, physical examination, progression, and the history. You got 5 minutes before we conclude.
I would like to add that the possibility of Epstein-Barr virus and Kikuchi disease goes low down in the list because both Epstein-Barr virus and Kikuchi, we expect a generalized lymphadenopathy. It is said that in Epstein-Barr virus, the presence of a epitrochlear lymph node is very, very suggestive and this child does not have it. The same thing is for Kikuchi disease. Kikuchi disease can be very easily picked up on a lymph node biopsy, which this lymph node biopsy has not picked up. The possibility of a Langerhans type histiocytosis is considered lower down in the list because there are no other clues for the presentation of Langerhans type of histiocytosis.
Okay, any other panels on the investigations?
Can I come in now?
Yeah, please, Jagdish.
So I think now if we put this whole thing in summary, we have a child who's had prolonged fever now going on for almost a month. Okay, and we don't have anything to suggest an infective disease, either acute or chronic. None of our tests have shown that. Second important thing is that it doesn't look like a malignancy because your bone marrow is normal, lymph node biopsy is normal. So neither lymphoma nor leukemia is common. The immunological disorders which Dr. Nagbhushan has mentioned, like SLE and RA, are possible still, but very low down. what is more likely or what is most likely here is that it seems to be something that is infiltrative into the RES progressive, which is not a malignancy. So I would put first possibility as sarcoid here, which has got which can present right now, which can present unusually, which can present with fever, prolonged fever, which can present with lymphadenopathy. We do not have a CT scan to show what the lymph nodes in the lung are, but this seems to be more and more looking like an infiltrative disease, unlikely to be malignancy or infection. This is my take.
Dr. Nagbhushan was suggesting lymph node biopsy at a different site. What is the take of the panelists on this comment?
I would do a liver biopsy more than a lymph node biopsy.
Okay. Nagbhushan, would you want to do liver biopsy?
There are two investigations which you have not done, sir. One is liver biopsy and one is a CSF. Now, to do CSF, I have no clues. To do lymph node biopsy, I don't think I would get any more information from the lymph node biopsy because that is an infiltrative process, probably infective. So how much I would get from the liver biopsy, I am not sure.
Dr. Jagdish, you said for sarcoid you want to do liver biopsy. Why not do CT chest and maybe serum calcium and enzyme levels?
You can do that also. You can do an ACE level. You can do a CT scan of the chest. But here you have direct. See, you need, even if you get a CT scan, you will only show lymph node enlargement. You won't be 100% sure it is sarcoid. So again, you will have to get a biopsy from somewhere to prove that it is sarcoid. The other tests you can do, like for example, acetylcholinesterase and other tests which you can do are not definitive. You can get or you may not get. A biopsy definitely will tell you that.
Okay. The only other addition is generally sarcoid will manifest with mediastinal lymphadenopathy, much in addition to other lymph nodes, but here the chest X-ray was normal.
Yeah, I think with that we have unresolved febrile patient. At the end of what is the most common investigation done, some more investigations have been suggested by Jagdish. So I'd like to go back to Nagbhushan to wind up and tell me what he wants to do and what is his differentials.
Now, as I said, this is the statement I would go by. I would like to repeat the investigations which have been done so far. And if I don't get any clues from repeating these investigations, then I would go in for an invasive investigation.
Any specific investigation you have in mind for repeat?
No.
All you want to repeat?
Yes, because there have been, see, as Palini said, I would like to see what has happened to the WBC counts and the platelets in addition to the antibody tests.
Okay, with that repeat tests in mind, does your priority for the differentials change, or what is the order of differentials you think of, you'd expect to get with the repeat investigation?
Now, I would like to see whether that persistent neutropenia is still there, number one. Number two, I would like to see if I can get any clues in the peripheral smear. Number three, I would like to repeat the ultrasound to see whether the spleen now shows something more like a microabscesses. And number four, the IgM and IgG for rickettsia, which we have not completely ruled out whether there is a rising titer. So these are the things that I would like to look for.
Yeah. Any other panelists would like to add on what they would like to do and what is their differentials? Jagdish says it could be sarcoid. He wants to investigate for that. And there is a suggestion of primary HLH, and the investigations we have not done for that. So that we'll keep in mind. Any other thoughts other than this? So I think a PET-CT is a suggestion that I think it's mainly for looking for lymph nodes and other masses. So I think that's one suggestion. Fine. So can we reveal the final diagnosis, what the treating team decided? Can I share my slide? Okay, I think that's an excellent discussion by Nagbhushan, and there's no match fixing here. So what we did, can we see my slide?
Yes, sir. We can.
Hello?
Yes, sir. Yes, sir.
So what we did was, like Nagbhushan suggested, we did a repeat ultrasound. and that definitely showed multiple abscesses. You can see lot of hypoechoic areas. And we did a repeat brucella, and that showed a twofold rise, 2.57. And that concluded that this could be a brucella. We went back to the history, and then there was definite confusion that the child, in the 2 weeks stay, 2 months stay in the native, she was regularly consuming unpasteurized milk. And then, but then we had the diagnosis, but we didn't have the answer why the fever is not coming down, despite doxycycline, it's a good drug. So we went through the literature and we added gentamicin for 7 days and continued oral doxy for 3 weeks. She became afebrile after 5 days of gentamicin and continued to remain so. So final diagnosis is a brucellosis. Some of you may ask why gentamicin, and there is enough literature to say that combined use of gentamicin and doxycycline, number one, it reduced the relapse rates, and the frequency with which the remission occurs is also better. There is enough number of evidence to show that. So hence, gentamicin would have been probably the better choice if I had known this information earlier. So with that, we'll conclude of a wonderful discussion of, like Nagbhushan said, usual case with an unusual presentation and not responding to the standard therapy. So I'd like to thank your foundation and all the panelists who participated actively. And I'm sure, like me, Nagbhushan and Jagdish, everybody has enjoyed this session. Thank you very much.
Before we conclude, I won't thank, but I would always share that Dr. Subbarao gave me sleepless nights. And anyway, the sleepless nights made us learn more of clinical medicine. So for that learning, I thank you, sir.
Thank you.
Yes, sir. So there's a question coming in from Dr. SBS, sir. Was PID ruled out?
Was what?
PID ruled out. Dr. SBS sir is asking a question.
No, we didn't. Actually, my stupid brain did not entertain the possibility of PID. One small bit of information I want to give you. I work in 2 hospitals, both related to Manipal. One is a small hospital, Malati Manipal, and the other is the main Manipal, bigger hospital. This patient went discharged against medical advice from Malati Manipal because they thought my treatment was not good. And they came to main Manipal, they got admitted under me again. So the patient's bad luck got stuck with me, which made me stimulate, but my dumb brain did not even think of primary immune deficiency as sarcoid at that time. Thank you very much.
Thank you, sir. Thank you very much for the wonderful CP case deliberation, Subbarao sir and Nagbhushan sir. Thank you very much, sir. Sir, moving on to the next session, we have the chairperson coming in, Dr. Bakul Parekh, sir.
Yeah, hello.
Yes, sir. Bakul sir, welcome, sir. Welcome to the 5th annual conference of FeFCon Foundation. And to give a talk for this session, drug fevers in children, a clinical approach, we have Dr. Shyam Kukreja, sir. And can I have the intro slide of Dr. Bakul Parekh, sir, please?
Hello.
Hello. Yes, sir. 1 second. I just introduced the audience to you, sir. 1 second. RX team, Ria.
I think it is okay.
Yes, sir.
Don't
Yes, sir.
because we are already running late.
Okay, sir.
I think
Yeah.
we can quickly introduce Dr. Bakul Parekh again as a person who does not need any introduction to the pediatric audience in this country. He was a past president of the Indian Academy of Pediatrics, very close friend of mine, and now, yeah. So you want to continue, Krishna? You can
No, yeah, please, sir, please continue, sir.
So he's a professor of pediatrics at the Bakul Parekh Children's Hospital and Research Center, Multi-Speciality Center. He's also was the national president, is the secretary general, treasurer, academic affairs administrator, and a lot of other posts in the central IIP. He is now, more importantly, the organizing chairperson of the next FeFCon, which is going to be a mega event. So I request all of you to please be in touch with him and register yourself for this event. So over to you, Bakul.
Yeah, thank you, Jagdish, for your kind words. And I must thank you as well as Fever Foundation for giving me this opportunity. And after listening to a very interesting discussion by Dr. Nagbhushan and Subhasra, we move over to drug fever. We know that any fever without focus lasting for more than 7 days is always a dilemma in everybody's mind. And drug fever, especially when to suspect, whether we have any clinical clues by which we can pick it a little early, and what it dress. All these dilemmas, let it be solved by none other than Dr. Shyam Kukreja, who has been a consulting pediatrician and specialist in pediatric infectious disease and immunization. He's practicing for last 35 years and is director and head of the Department of Pediatrics at Max Super Specialty Hospital, Delhi. And he has held very key positions like as past chairman of Pediatric Infectious Disease chapter of IAP, convener of Immunization Committee, and so on. He's a very popular speaker and most sought after speaker in all the infectious disease conferences. So over to Dr. Sam Kukreja to let us lead through this particular interesting topic. Over to you.
Thank you, Dr. Bakul Parekh, for this nice introduction. So I'm sharing my screen. So, the topic given to me is a drug fever. What should be the clinical approach? So this is not a, I'll say, a rare condition, though uncommon in practice. We tend to see it very often on. And I'm going to discuss this. Straight away, I start with the case which I have seen very recently. Then we'll discuss. This is a child who's 3 years old male, fever for last 5 days, intermittent high-grade fever up to 105, and it started with 100, 101, and on day 2 it became 104, 105. Pain abdomen for last 2 days, intermittent and periumbilical, decreased oral intake, and the child was taking ofloxacin and metronidazole from a private practitioner for 3 days and had received 1 dose of typhoid vaccine. So a clinical diagnosis was enteric fever. That's the commonest cause of fever. And ceftriaxone and supportive treatment was given in this scenario. So once we investigated, we found there's anemia. Then there is TLC is only 1400. There's platelets are 2.3, and there was a concern that possibly are we dealing with straight away HLH. So ferritin and triglycerides were done just to rule out HLH. LFT, KFT were normal, urine was okay. And after 24 hours, we came to know this most likely salmonella typhi. There were NLF growth. And after 48 hours, the child was found to be sensitive to ceftriaxone, and we continued with ceftriaxone. On day 3 of admission, just I think after maybe third day of admission, the child's worsened. Fever pattern remained as hectic as it was at home. The child was became irritable in the morning, excessive crying, and the pain abdomen increased. The child over 3 years was just pointing towards the abdomen. Weak and rapid pulse, and he was tachypnic as well, shifted to the PICU. On examination, it was found that the abdominal fullness, rigidity, guarding, and the right iliac fossa was appearing quite tender. Ultrasound and CT were immediately done, and they confirmed that this is perforated appendix. The child was operated, appendectomy was done with peritoneal toileting, and antibiotics in view of hemodynamic instability was upgraded to meropenem. Now, child gradually improved in ICU over a period of 72 hours, and he was shifted out to the room after 72 hours, and the child was given a treatment with meropenem for 7 days. And we planned the child to discharge on day 10. I was quite afebrile for last 3-4 days, active, accepting orally. And there was a discussion that we must complete 14 days of enteric treatment because otherwise the chances of relapse are higher. But the father on the same day evening talked to our one of the unit consultant. He said the child is still having, now child started having fever after 4 or 5 days, is 101. The consultant advised continue same. Fever increased over next 3 days, 102, 103, and there were 3 spikes a day, no shivering. So we readmitted the patient on day 14. So we are counting the day from day 0 as a date of admission. Okay, no thrombophlebitis, no cough, cold, no urinary complaints, abdomen is soft, no pain abdomen, vitals are stable, and we sent the investigations. So what was in our mind? We thought most possibly some collection left inside because of peritonitis, maybe some intra-abdominal abscess, or is it a hospital-acquired infection the child has picked up during the stay? And the third discussion in the unit was, most possibly we are given lesser days of management of peritonitis, even if the recent data tells 5 to 7 days after source control is sufficient. They said possibly it was inadequate. We restarted this after sending blood and urine culture and other investigations. Uh, Other possibility was, is it a drug fever? We are giving beta-lactam antibiotics. First, we gave cephalosporins for 3 days. And after 3 days, we changed over to meropenem, which we gave for 7 days. So is it a drug fever? And that was one of the possibility. With these possibilities, we kept the patient for observation, and these were the investigations. Hemoglobin 8.7, counts look okay, and then platelets are quite okay. CRP is normal, urine routine is okay, ultrasound was normal. We observed the patient for next 48 hours in the hospital. The fever pattern continued same as at home. So the fever was going on similarly for almost 5 to 6 days, 3 spikes a day, and the fever was going up to 102, 103, and there was no shivering. The child was not sick, he was active, accepting orally. Even during the fever, the child was not looking very unwell. So we reinvestigated after 48 hours of admission, reinvestigated. Again, we found count, CRP, PCT, urine, routine, culture, blood culture, everything came normal. So we thought of possibility of drug fever was considered. We stopped meropenem. Child became afebrile after 72 hours, and then the patient was discharged in good general condition. So this is a story which is fitting into drug fever. And the drug fever is a disorder which is characterized by fever that occurs with the administration of drug and disappears after discontinuation of the drug. It is also defined as febrile response to a drug without much cutaneous manifestations. It's not something like dress and all that. So what are the mechanisms of drug fever? Most likely it is a hypersensitivity reaction to the drugs like carbamazepine, phenytoin, abacavir. These are the classical drugs which lead to hypersensitivity reactions. Or it could be idiosyncratic reaction like a malignant hyperthermia with muscle depolarizing drugs, something like succinylcholine. Reactions may be due to direct pharmacological action of the drug, like killing the bacteria and releasing a lot of toxins. And this can be similar to Jarrick's hexamer reaction, or this is an altered thermoregulatory mechanism which happens with atropine being an anticholinergic drug, or amphetamine or cocaine, which are sympathomimetic drugs. Now, to what should be the clinical approach? We have to evaluate for other causes of fever. Short duration usually not associated with drug fever. Most cases of drug fever occur after first few weeks of drug administration. Drug fever is generally a diagnosis of exclusion. So the clinical approach will be, first step will be to rule out other causes of fever. And the concept is no harm to the patient. If you're very sure that this is most likely to be drug fever, only then go ahead. Now, if we take the causes of fever after 7 days, there can be infection, rheumatological diseases, neoplastic disorder, you heard in the last discussion. And these are the causes of fever more than 1 week. And if you say drug fever, in one of the study, it is contributes just less than 1.5% of the cases. So these are the common cases which can happen after one fever, after more than 1 week of duration. Now, if you take the general appearance of the patient, generally the patient appears okay, feels well. But there have been cases reported where the patient is sick and ill appearing. So you cannot rule out that possibility, but mostly the patient appears okay. Relative bradycardia, I think, more recorded in adult patients and lesser in the pediatric patients. The timing of fever. Now, there is a highly variable lag time between initiation of drug and the onset of fever. It can be sometimes few hours to few months. The median reported time is something like 8 days after starting the medication. Most cases tend to occur after first few weeks of drug administration. Cases have been reported where people have used drugs for months of several months, and then the drug fever comes. What is the pattern of fever? There's no pattern of fever which is specific to drug. For example, in our case, it was an intermittent high-grade fever. The fever pattern, the severity of temperature, they are very variable in drug fever. It can be low grade, it could be high grade, it could be half temperature, it could be remitting fever, it could be intermittent. All patterns have been reported with drug fever. So you can't say this pattern of fever should fit into drug fever. If you take skin rashes, something like 18 to 30% of the patients may have associated drug fever. They may have rashes, skin rashes, but the absence of rash definitely doesn't rule out the diagnosis of drug fever because the rash only occurs in 18 to 30%. The type of rash varies. Even the rash is not very specific. You may have just erythema, morbilliform eruptions, urticaria. It could be rash with lymphadenopathy, and sometimes they can be some serious cutaneous reactions, exfoliative, something like erythema multiforme, Steven-Johnson syndrome, toxic epidermolysis, toxic epidermal necrolysis. All these things of rash have been reported. What are the underlying conditions in pediatrics where we are likely to see a drug fever? It is HIV and cystic fibrosis. And in adults, malignancy, liver, and renal impairment, a lot of drug fevers are reported. Now, investigations against are not very useful. The TLC is elevated in 20% of the cases with eosinophilia. CRPS are again not particularly useful. Neutropenia, agranulocytosis is reported with drug fever associated with penicillin and cephalosporins. Disturbance of liver function may be there. And creatine kinase and myeloglobinuria could be there in a case of neuroleptic malignant syndrome. So all these investigations may be abnormal. So then what is the clue? Like back to our case, I think it was an easier case if you see the literature. General appearance of the patient was well. There was no bradycardia. The fever pattern was intermittent high grade. There was no rash. Timing of fever, received 11 days of beta-lactam antibiotics and then started having fever. Investigations, luckily there was no focus on infection. There was no abnormality, made my job much easier. And we ruled out other probable causes of fever. And after that, we discontinued the most likely offending drug. Now, before we take away this offending drug, we must review the medication history and drugs that are more frequently associated with drug fever. I think it's very important, particularly in a patient who has got some comorbidities and being treated with several drugs. There it becomes very, very challenging and very, very important. If we see the list of drugs, just to summarize, anticonvulsants, which I named earlier, carbamazepine, phenytoin, phenobarbital, primidone, the reaction is supposed to occur to the tune of one reaction per 5,000 treated patients. Antimicrobials, the most notorious are beta-lactam and sulfonamides. Minocycline is also reported in nitrofurantoin. And if you take other idiosyncratic reactions where lead to very high-grade fever, sudden onset, malignant hyperthermia is because of succinylcholine, which is a muscle depolarizing agent. Inhaled anesthetic agent like halothane can lead to malignant hyperthermia. If you take serotonin syndrome, dextromethorphan and tramadol, which are the drugs which are used in pediatrics, may cause high-grade fever because of drug. Hemolysis can lead to G6PD deficiency, and we know what are the drugs which can lead to that: pimacine, quinine, sulfonamide, and nitrofurantoin. They can lead to hemolysis and release of endogenous pyrogens. Now, fever can be just an extension of pharmacological effect of the drug, like chemotherapy. leading to cell necrosis, lysis, after leading to fever after 4 days of chemotherapy. Similarly, in syphilis, this is Jarrett's eczema reaction occurring after killing of bacteria in secondary and tertiary syphilis. So then the drugs can lead to they alter the thermoregulatory mechanisms and lead to fever, like exogenous thyroid hormones, L-toxin. Drugs with anticholinergic activity like atropine, antihistaminics, phenothiazine, sympathomimetic drugs like amphetamine and cocaine, and some drugs like amphotericin and bleomycin also have intrinsic property of causing pyrogenic reaction and fever. No drug cessation to establish the diagnosis. If we discontinue all drugs in a patient who is receiving a lot of drugs and we have a question mark which particular drug is causing this drug fever, then we can put the patient at risk. So in that situation, I think due diligence should be paid to find out which is the most likely drug. And it's a good idea not to stop all medication, but one by one, which can be the offending drugs with the list I have given you. So care should be taken that not to put the patient at a risk of greater harm. And I tell you, this is not an easy decision. Even in my simpler case, it is not an easy decision in clinical practice. You always worry the patient should not worsen. Okay. And offending drug cessation to establish the diagnosis, I think the result comes after 48 to 96 hours of discontinuing the offending drug. In our case, they came just before, I think, 72 hours. In case of suspected antimicrobial induced drug fever, in this case, in our case, it was easier because we have completed 14 days of drug therapy. And suppose, for example, the fever is coming after day 7 or day 8. In that situation, what could I have done in case of enteric fever? Possibly, I could have gone to maybe another class of drug, that is azithromycin. Now, confirmation of diagnosis with re-challenge. This is very controversial, should be performed with extreme caution. Now, this child is sensitive to or a hypersensitive to beta-lactam. And in future, this child is just 3-year-old. He may need these beta-lactam in future. And we'll closely watch what happens to this patient. But the literature is sort of silent regarding the reuse of drugs. What is holds for the future? In the future, there's going to be a personalized medicine because role of pharmacogenetics is coming in a big way to find out which are the drugs which can lead to adverse drug reaction to a particular individual. Now, give you an example, hypersensitivity is the most common cause of drug fever. Genetic predispositions to drug sensitivities have been described. Now, drugs which can have a genetic predisposition have been described as abacavir, your carbamazepine, allopurinol. Now, abacavir induced hypersensitivity reaction, but it's an antiretroviral drug. We know that this is associated with HLA-B5701. So if you test for this allele, the clinician can know who are the patients who are likely to get hypersensitivity reaction to abacavir, and you avoid this drug in that particular patient. So this is something like which is going to happen in the future. With these words, I say thank you very much for your attention.
Hello, Dr. Syam. Thank you very much for the excellent session, and you gave us the idea as to when to suspect drug fever, and most of the time it is by ruling out other diseases. And of course, when you have introduced a new drug, and after 7 to 10 days, if fever comes again and you have not concluded the diagnosis, you may think about drug fever. So, any questions, Dr. Krishna? You can take it forward.
No, sir. No, there are no questions coming in yet. There's one question from our panelist itself, Dr. Ashwath. Do commonly used penicillins and cephalosporins cause these fevers?
Yes, I think the most common are these beta-lactams only. They are the ones commonly used in our practice, and they are the commonest cause of fever, and they cause fever by a hypersensitivity reaction.
Dr. Syam, can I ask one more question? When will you suspect DRESS?
I think DRESS is a more of a systemic disease, sir. Here you have other organs involvement also with eosinophilia. And that is also reported with the anticonvulsants and several drugs. In that situation, like in drug fever, the system involved is only just patient is having fever or maybe some little bit of rash. In case of DRESS, there's an organ involvement, there can be liver involvement, the skin is badly involved, and all these things are there, and the patient is a sick looking child.
Thank you. Thank you.
So there's one more question coming in from Dr. Palani Raman. Apart from this encounter, how commonly you had encountered in 35 years of experience, and what are the other drugs?
I'll say, let's put it like this, ki how commonly I see drug fever in my practice. I'll put it as something like one patient in maybe 8-9 months, or maybe in 1 year, one patient. I can remember a list of maybe 8-10 patients in last 8-7-8 years. So not many. And to me, the figure of, which is according to one study, 1.5% of all of these fever, it appeared to me little more than what I see in my practice. Or maybe we are missing something, maybe I don't know.
Okay. So a question from Dr. Rashwini Kumar Sood. What should be the advice to the patient being just 3 years old?
Advice to the patient?
Just 3 years old.
It's not, question is not clear.
Ashwini sir?
What's the question like?
Yeah, sir is here only. Sir?
Yeah. This patient is just 3 year old, and he is going to be prescribed number of antibiotics in the coming days, because we all know that less than 5 year febrile illness, and if he happen to visit North Sham or Bakul or other one, he is definitely going to be prescribed some or other antibiotic. So I think we need to give them a red IV.
Yes, I think we have given them a diagnosis that this is a drug fever due to beta-lactam antibiotics, and the relations are very educated. And the father, I think, is from the IT industry, is well aware. He's read a lot of literature and all that also, and came to us and asked this question to me regarding re-challenge. And I, to be honest, I couldn't answer to his satisfaction. So I told him, in my experience, I think we tend to avoid, but these are the drugs maybe the child will receive in future. But whenever I tend to give this drugs to this patient, I'll definitely keep a very, very close watch. And maybe the first 2 doses or 3 doses, I'll like to keep him in the hospital for maybe a daycare and then give it. It's just a precaution. And maybe now next time, will the fever come after 7 days or 8 days? Because most antibiotic therapies, I think patient take is 4-5 days and all that. But if that again is required for more than 8 days, or this patient had fever after 11 days. So that's a question, to be honest, I wanted to answer. I searched a lot, but unfortunately I couldn't get the answer. Any other experts who have experience of this? Dr. Jagdish, you can tell, have you any experience of that?
Sir, two things are there. As you rightly mentioned, we probably suspect drug fever maybe very occasionally. And most of them are beta-lactam antibiotics when you're giving beta-lactam. And the issue is that we have never tried any re-challenge. Once we stop it, we generally say, okay, now we please don't restart this drug. So I think the drug fever, as you rightly mentioned, is a diagnosis of exclusion. When you're reasonably comfortable that you can withdraw the antibiotic and you're not going to worsen the clinical situation, you will be brave enough to do it. And I think if the patient is getting a parenteral beta-lactam, then I would do this only in the hospital. I won't take the chance of stopping it and trying to see what's going on. Because again, it's not very easy to be 100% sure it's only drug fever. It could be anything. And as you rightly mentioned, you'll have to look at all the possibilities before you stop.
And I think in adult practice, there can be a lot of difficulties because the patient is receiving maybe 8-10 medicines, and it becomes very tough for them to diagnose. I've reviewed the literature and found in HIV, piperacillin, tazobactam leading to that. Regarding the re-challenge, will this behave like FDR? I'm not sure. FDR means fixed drug reaction. Like you give a drug and the skin reaction comes from the same place repeatedly. Will it behave that way like FDR? I'm not sure. And I couldn't find the answer to this, but this gave me a lot of curiosity after going through this topic and going in detail. I want to know the answer of this. Maybe I'll find out the answer and may give it in the next fever fever conference.
I think maybe we can even take some of the help from our allergy specialists, because they do challenge tests, food challenge and whatnot. So maybe we can see whether they can do a drug challenge and see whether it is related or not.
Yes.
Yes,
Thank
sir.
you very
Thank
much,
you
Dr.
very much, sir.
Kokeja.
Thank
Dr.
you.
Bakul. Thank you.
Yeah. So thank you, Shyam. And one more question was like, what is the importance of relative bradycardia? They say that when fever is very high during drug fever, but child otherwise looks quite fine, and there is relative bradycardia, because with fever usually there should be tachycardia. So
Yes.
is it a very important clue?
Yes, I think it's an important clue, but I find hardly any mention in the pediatric pediatric drug fever. Hardly any mention of that. And we see a lot of bradycardia, I think, in one condition most of you must have seen, particularly in a recovering dengue patient. I've seen a lot. I don't know what's the experience of others. In a recovering dengue patients, bradycardia is very, very common. But what is the mechanism in that, we do not know. Bradycardia and typhoid we have seen in children, but not as commonly as in adults. And I think in this case, the bradycardia is there not proportionate to the degree of fever. As we know, with a degree rise of fever, you tend to have more of tachycardia, like 10 per beat, 10 beats per minute from every rise of temperature of 1 degree. But this doesn't happen here.
Okay. So thank you, Dr. Shyam, for an excellent talk. I am sure dilemma continues. It has not ended, it just begin. So maybe next FeFCon, you will come with better answers to some of the dilemmas. Thank you. Over to Jagdish and over to Dr. Krishna.
I think this relative bradycardia is a phenomenon primarily in adults, and in children it's not so well defined. So as Dr. Sham mentioned, I think dengue is the commonest, recovering dengue. Once a patient starts getting a relative bradycardia, you're almost sure that he's fit for discharge. So I think those are clinical signs which are not often mentioned. So I think Dr. Krishna, over to you.
Yes, sir. Thank you very much, sir, Sham sir, for your wonderful deliberation on drug fevers in children. Thank you, Bakul sir, there. And I request Dr. Jagdish Chinappa sir to continue this session, chair the session for red herrings and identification of etiology of fever.
I think you can just move on, remove my slide and put Dr. Supraja's slide. Please.
Right. Yes.
So I think we are going to have a very interesting session today, and that is on red herrings in the identification of fever. We know that, as we had seen in the last case presentation, there are a lot of red herrings which come up, and we have to sort them out when we are looking at fever. And to do this, we have a extremely good speaker and teacher, Dr. Supraja Chandrasekhar, who is a consultant pediatric intensivist at the Manipal Hospital at Yashwantpur. She has done her fellowship in pediatric critical care with a gold medal, and she is an MRC PCH and a former course director of the National RGHS and PICU fellowship courses. She's got many awards, and she's one of the members also of our ICU task force. She does a lot of teaching in schools on safety and emergency care. So I'm handing it over to Supraja to take it forward.
Thank you very much, sir. May I please share my screen? I hope this is visible.
Yes.
Okay. Thank you very much to the organizers for giving me this very interesting topic and making me part of this excellent academic session. Red herrings in fever etiology. So I'd like to start by a disclaimer. I'm certainly not an ID expert or an academician to be with the panelists that I've just heard exemplary talks. I'm, after all, a pediatric intensivist with some working knowledge of infections and a slightly better knowledge of the deranged physiology in ICU. With this background, I would just like to go through few cases which we came across in acute critical care, where we did come across red herrings in reaching a diagnosis and the learning points after each case. I use 5 filters to come to an etiology in critical care. The first and the most important filter being the history and the clinical examination. However much we think that it's investigations, it's the fancy monitors, it comes back to only history and clinical examination. Yes, with backup of investigation, our next filter, and one of the most important filters in acute care is reassessment, how the child is actually responding to the medications. Also, what the parents feel takes a lot of precedence. And finally, our gut feeling. If we think this is not right, it's probably not right. So the first child is a 4-year-old girl with 8 days history of fever, progressive lethargy, and poor feeding. She was admitted in an outside hospital, noted to have a very low hemoglobin, tachycardia, developing shock. She was given ceftriaxone fluids and supports, but once they saw her hemoglobin being so low, they urgently shifted to our PICU. She was definitely tachycardic, low saturation, impending cardiac arrest with low blood pressure. She had severe pallor, mild icterus. Her chest was clear, but she had all the features of shock with a dropping blood pressure. She wasn't giving us much time. She was acidotic with a very high lactate. Her hemoglobin, which was 5.4 in the outside hospital, by the time she reached us 3 hours journey, was 2.7. We knew there was some sort of active hemolysis. Total counts were very high. CRP was high. Bilirubin was high. She was coagulopathic. Features of multi-organ dysfunction. Her DCT was strongly positive that the lab actually called the emergency and mentioned it. She had bilateral X-ray infiltrates, probably pulmonary edema, mild cardiomegaly, LV dysfunction. Now we have a sick child who was anemic, who was previously completely well and getting worse, developing shock and features of sepsis. We did all the tropical infection screen, which came negative. So we thought there is some sort of sepsis with secondary hemolytic anemia and shock. We started her on the same ceftriaxone, but then realized that she was way too sick. We started meropenem, added vancomycin, doxycycline, and azithromycin. As we know, when we are at the end of the spectrum, we don't have much time. So we hit it hard for atypical cover, tropical infections cover, as well as gram-positive and gram-negative. We also gave her steroids as per the hematologist advice before giving her the transfusion, and had to intubate her, do the usual fluid resuscitation as well as inotropes. Now, this was the little girl on the ventilator. Her chest X-ray after intubation and now opening up the lungs looked a little better. But she continued to have raging fever. She tolerated the blood transfusion well without any massive hemolysis. We could not come to what could be the cause. Her cultures till then on day 2 was negative. Her CRP, of course, was coming down. So we thought we are on the right track with the antibiotics. We also added clindamycin in case there was a component of a toxic shock. And because her shock was still not fully better, but the rest of the clinical parameters were inching towards normalcy. However, the fever was still there. Now, with persistent fever on day 4, and initial cultures not showing anything, we had to do the last thing which we do in the ICU, which is add colistin, thinking of some sort of resistant bug. And that's when we sent a repeat blood culture. On a delayed growth on the primary blood culture, we actually got Klebsiella, which was carbapenemase resistant organism. If you look at the sensitivity, it was actually sensitive to doxycycline, cotrimoxazole, and gentamicin. She was on doxy already, but was not fully improving. So at this stage, we started meropenem, colistin, and gentamicin. All her clinical parameters started getting better. CRP started becoming better. Her hemoglobin was holding on. There was no further hemolysis, but her fever did not go. So we removed all the lines, changed the cannula. Still, the fever was there. And as Dr. Kukreja had so beautifully pointed out about drug fever, we thought when everything is getting better, it's probably drug fever. We were so tempted to stop everything else, especially since by day 5, the parents had exhausted their resources and said, look, our child is much better. We want to go home. But the gut feeling did not let us. Klebsiella, which was carbapenemase resistant, are we missing something? So I forced them to do a molecular diagnostics. And that's when we got the carbapenemase resistant organism, which was NDM positive. Now that clearly tells us that they won't respond to colistin. We had to start ceftazidime, avibactam, and aztreonam. We stopped everything else. This was her looking very well in no time and no fever, making a card for the whole team. And she was discharged with normal ejection fraction and on follow-up, no further hemolysis. So what was our learning point? Even when all the labs and clinical parameters are improving, if the fever still persists, we cannot ignore, especially when we have a resistant bug. So here we use the filter of reassessment and, of course, our gut feeling. Case 2, a 1-year-old child with history of waking up in the morning with increased phlegm. She had a fever of only a day, but she was noted to have breathing difficulty and profuse nasal discharge. She was very drowsy, taken to a local center where she had a convulsion, thought to be febrile seizure, and then referred. Apparently, child was completely playful till the previous day evening. So this was her. She had a temperature of 99. Her blood pressure was okay. She was saturating well, but she had severe encephalopathy, lot of secretions. Her GRB was okay. She also vomited and finally got intubated in the emergency itself. Interestingly, she came during the COVID phase where she was COVID positive. Now, we thought, could this be one of those rare presentations of acute COVID, which is described in the literature? All our registrars and team got very excited. Could this be something which was causing encephalopathy? So we urgently did an MRI brain, which was strikingly normal. Now, we had a child with severe respiratory distress, but an X-ray which was normal, hardly any oxygen requirement, so we decided not to do her CT chest. She also had severe altered sensorium, which was not explained. And if we look at the inflammatory markers, they were all normal. Her organ function was also normal. Are we missing something else? What was really striking was the profuse secretions that she was having. And I looked at her pupils, which were pinpoint. I don't know if you can actually see it. It was actually pinpoint. This was very striking. We revisited the history and asked the parent, was there any possibility of exposure to a fertilizer? By this point, they thought we don't have a clue of what we were doing because we had just told them of COVID positivity. They were extremely upset seeing the child intubated and they thought they're going to lose the child. So I had to sit down and tell them there is a toxidrome, which I'm thinking about. Think about anything that they did with a fertilizer exposure, and they vehemently denied. The only history which came up was they had moved to the house only the previous night. 7 days they were outside the house, and I asked why. Well, they said the house was being rigorously cleaned by a pest control person. I said, what was the agent used? And they did not know. So we actually called the pest control guy and asked him to send the picture of what he used. And clearly it was metacid. It was one of the OP poisons. So then we did an atropine test and she actually passed the test where she did not have any pupillary changes despite a high dose of atropine. So we sent a cholinesterase level. Now, is this an unusual COVID presentation or simply OP poisoning? The bloods were normal, organ function was normal, normal CRP. So we decided to simply treat her with PAM, atropine, and see what happens. Within 6 hours, we got a cholinesterase, which was almost undetectable, less than 10% of normal. We had a diagnosis and in no time she was home. So what really happened was this was a crawling child. There were pieces of the pest control powder which was left about in the house. When they went back, they found all the powder. There were 3 other children. So we decided to clean the house properly and the family were extremely grateful. So the learning point, COVID positivity is not a diagnosis, especially during a pandemic. COVID could probably be a bystander. We need to think when there is an unusual presentation. History and clinical examination was very important, reassessment, and of course, the gut feeling. Next case was a 1-year-old child who again presented with fever, lethargy, and altered sensorium. Now, this child came in severely hypoglycemic to our neighborhood hospital, was given glucose correction, and subsequently presented to us looking extremely sick with severe metabolic acidosis. The initial blood gas had a pH of 6.9 and severe shock and anemia. We had no idea. The child was completely well, had mild developmental delay, but otherwise okay. And it was an breastfed child who was just in the 11th month. We did the fluid resuscitation, bicarbonate infusion, but the acidosis didn't improve. We had to go to peritoneal dialysis. Again, this child was RT-PCR positive. Now, by now we understood that RT-PCR positivity did not mean anything. The child was very sick and we had to just treat the deranged physiology. Now, this child being well before this, one of the things which come to our mind is definitely an IEM. Is this a metabolic syndrome? The parents were not consanguineously married. There was nothing to suspect the IEM for 1 year, and then this catastrophic presentation. This was a child having the dialysis in our emergency. But we looked again. The child definitely had these striking features. And I know you're thinking of what I'm thinking as well. We saw very dark toenails, beefy red tongue, very black knees, and this was very different from the parents. When I took the history again and said, could you tell us what you did differently in the last few months? And she said, nothing at all. The child had an episode of diarrhea vomiting in the last few days, was on nothing excepting breastfeeding. And the mother's diet, I just happened to ask in passing by, although we had so many things to deal with in the emergency. And she says she recently became a vegan and was on completely vegan diet. That's when it hit a bell. Anemia, severe acidosis. We sent a vitamin B12 levels, which came completely undetectable. We gave vitamin B12 as part of the metabolic cocktail as well, along with fluids and peritoneal dialysis. But what we saw was a dramatic response. This child, within the next day, was sitting about, still the dialysis catheter sticking out of him, but made a complete reversal. And literature search then showed us that severe vitamin B12 deficiency can present this way. And in no time, the child went home. So learning point here is a thorough clinical examination with an open mind is important even in emergencies, especially with unusual presentations. Always talk to parents if they were doing something different, like an unusual diet, or even started with new drugs like alternate medicines. Here, the history clinical examination filter, as well as the parents, gave us the clue. The next case is a 3.5-year-old girl who presented with a fall from a cycle. She complained of back pain following the fall, but seen by a local orthopedic surgeon and reassured after X-ray, said the spine is normal. Thereafter, the child the next day developed fever. She was seen by a local doctor, GP, who had noticed cold and cough, started Augmentin and Ibugesic. The child was well for 3 days, but then restarted with fever. By the time she presented to us, she was febrile, toxic, and in early shock. There was no focus of infection. My registrars was very clear. The chest was clear. Abdomen was normal. Limbs were normal, and there was no rash. The child clearly had sepsis with shock, and investigations were congruent with that, with a high total count, high neutrophilia, lowish platelets, high lactate, very high CRP. And the urine showed pus cells positivity, which was not dramatic. It was only 8 pus cells. So we thought, okay, this is a probable UTI with pyelonephritis. However, the ultrasound was normal. Our working diagnosis still was urosepsis with shock, so we started ceftriaxone and amikacin. We expected her to get better in the next 48 hours. However, she continued to remain toxic. She had fever spikes, she went into capillary leak. Her repeat counts on reassessment showed her total counts were 22,000, further increase in neutrophilia and a CRP. And now we thought this is high time we do the LP. That's when, because we've ruled out all other foci of infection. When we considered LP, we actually looked at her back and she kept saying she had back pain. And then it occurred to us that it was tender in the lumbar area. Are we missing anything? So we went ahead with an MRI spine. And there was clear-cut paraspinal abscess. We ruled out TB, started her on ceftriaxone vancomycin, and after completing 14 days, she did not require removal of the pus. With antibiotics, it melted and she made a complete recovery. So our learning point here, parents usually relate events to a recent trauma. The trauma was trivial, it was incidental. She actually all the time had a paraspinal abscess. We don't know why she developed that. Back pain in a child is extremely unusual. So if it is present, we need to relook and look again and reassess every time. If not following the usual path, look for an alternate foci. The next case is an interesting adolescent girl who was 15 years, weighing 68 kilos. She presented with fever of a week. She also had headache and vomiting for 3 days. She was from the Tumkur belt. She received IV ceftriaxone and amikacin for 4 days at the local hospital. And because her fever, her headache did not get better, the parents then transferred her to our hospital. There was nothing else in the history, no recent travel, no contact with TB. The child was otherwise well. One thing which the parents were concerned about is they said she had gained 4 kilos in the COVID times, and she was just sitting and preparing for her 10th standard exams, which was due in the next 2 months. And she was otherwise a completely well immunocompetent child. When we examined her, she definitely had a board-like neck stiffness, but her sensorium was normal. She did look very tired, lethargic, and febrile. We did an urgent MRI, which was normal. Her hemoglobin was lowish. Her total count was okay. Not much neutrophilia. CRP was mildly positive. Electrolytes, liver function test was normal. We went ahead with this CSF study, which showed 110 cells, 10% neutrophils with a high protein and sugar low. So all this was fitting into a partially treated bacterial meningitis. We were happy with our diagnosis, started on ceftriaxone and vancomycin. Now, day 3, the fever persisted. The parents were behind us that they did not have insurance and the costs were building up. They said the child is still looking dull and vomiting despite anti-edema measures. 3% NaCl was also given. So we upgraded to antibiotics to meropenem and vancomycin. The CSF and blood cultures came as no growth. Fever was there and the child was simply not looking fully right. So we thought, could this be tuberculosis? Well, there was only an 8-day history of fever. She was an obese child. She had a recent weight gain. There was no contact. She was immunocompetent. Only 10% neutrophils were there in the CSF. Everything was screaming as partially treated bacterial. MRI also being normal. Chest X-ray was normal. So we reassured parents that the child may take some time. It should resolve and she should start getting better. And we also shifted her to the ward. The next day when I came for rounds, I had a mini heart attack. The child clearly had false localizing signs. She did not look right. She had a 6th nerve palsy. The mother said she started drooling, so she had lower cranial nerve palsies. Now it was screaming that we were missing something, and it's most likely to be tuberculosis. So we convinced them for a repeat LP. The cells had increased, her protein had doubled, all of them were lymphocytes, and the gene expert was positive. We started her on steroids, 3% NaCl, ATT, and she made a complete recovery. This girl was a fighter. She actually wrote her board exams, did well, and studying to be a lawyer. So TB will remain a differential for all infections not responding in India. And so we need to keep our eyes and ears open. However, when not showing the expected improvement, as always, we think of an alternate diagnosis. The next case, this is a 2.5-year-old child who actually had a fever for 7 days, was not investigated. Father was known to be COVID positive a month ago. So they thought this child has probably something related to COVID. They were from the outskirts of Bangalore, rural Bangalore. The child became progressively drowsy, then developed rashes. In the in villages, they say these rashes are normal, so they did not show anybody. But then the child started developing distended abdomen, puffy face and eyes, looked more sicker, did not take feeds. That's when the child went into status epilepticus and had seizures, shock, had a respiratory arrest, and finally reached our hospital. Was given 3 anticonvulsants, was intubated, fluids, inotropes, the whole works. The child had an extensive petechial rash all over the body, strikingly on the palms and soles as well. And there were few discrete lesions also. There was anasarca, there was a large liver spleen, and MRI showing meningeal enhancement. We stabilized the child, went ahead with doing a septic screen. Everything was positive in the septic screen, including LDH, D-dimer, and ferritin. The troponin I at that time was also high. The child was persistently tachycardic. So, looking at this child, we thought this is straightforward rickettsial encephalitis with status epilepticus. The child should improve with meropenem as well as doxycycline. And we started the same. We had evidence of coagulopathy and multi-organ dysfunction. The wheel Felix came as positive, higher than 320. So we said we are on the right direction. We also went ahead with an LP on the second day, which showed 35 cells. So we started Miro, Doxy, and Vanco was added in case of any secondary infection because the child had gone to 2 other local hospitals and taken some sort of IM injection. The child did not recover the way we expected. The echo done at that stage was normal. Now, considering very high inflammatory markers, we did an echo in case this was anything to do with MISC, but it was normal. Now, the shock did not improve fully. It persisted with edema and leak and the multi-organ dysfunction syndrome. So we kept in mind that this could still be MISC, and so we gave the IVIG. and later the steroids. Within 24 hours, the child was extubated, did dramatically well, and all the inflammatory markers reduced. Well, was this MISC or was this a tropical infection? We saw the literature, there was a lot of overlap, and spoke to our PICU colleagues. They were also dealing with a similar situation where at the peak of MISC, we also had tropical infections, which was probably triggering it. So we had to treat both. The child on follow-up did well with a normal echo. So here our learning point was tropical infections are most common in India. We do treat them, but we're not showing expected improvement, especially with the recent COVID exposure, multi-organ dysfunction. We had to keep MISC in mind and treat for the same. So in summary, we need to apply all 5 filters each and every time we approach a child with an unusual presentation or an unexpected response, or even when the values of clinical and investigations are incongruent and do not match. We always need to be ready to question and revise our diagnosis. Thank you very much for your attention.
Thank you, Supraja, for a brilliant presentation. Absolutely brilliant. I think you brought out a large number of the red herrings that can happen in the intensive care unit. Thank you very much. Are there any questions? Anybody wants to comment? If there are no comments, there are no questions in the chat box. So I think we can conclude the session. I hand it over back to Krishna to take it over.
Thank you, sir. Thank you, ma'am. With wonderful cases enlisted there on red herrings. And
thank you so much.
We move on to the next session, Fever Pay Charcha, the much awaited panel discussion. And we have the elite panelists with coming in Dr. S. Balasubramaniam sir, SBS sir, there as the moderator for the session. And I welcome you, sir, for the 5th Annual National Conference and this panel discussion. Also, we have other panelists. Yeah, Dr. SBS sir requires no introduction, but again, as a formality, he'll just run through. He is a visiting consultant in pediatrics and former medical director.
Krishna, I have already been introduced yesterday. Don't worry. Take time.
Yes, sir. Thank you, sir. And the next panelist we are coming in is Dr. Ashwath Durai Swami. Dr. Ashwath Durai Swami is a consultant pediatrician at Kovai Medical Center and Hospital, Coimbatore. He is also consultant pediatrician at City Center of Kovai Medical Center and Hospital, visiting the Faculty of Pediatrics at KMCS Nursing College. He has numerous papers to his credit, has been awarded at various forums, national and international forums, as well as an ardent speaker at various forums. Welcome, sir, Dr. Ashwath, sir. Also, we have Dr. Professor Ashwini Kumar Sood. Is a medical superintendent and professor of pediatrics from the Maharshi Markandeya Institute of Medical Sciences, Haryana. He has held various positions: President, HPNNF, President, Haryana State Chapter, Chairman, Advisory Board for Pediatric TB under NTF on NTEP. He is the Vice Chair, IIP Infectious Disease Academy 2020. He is also the EB Central IAP 2011 and 13, President, HP IAP 11 and 12. He has numerous papers to his credit, and his areas of interest include infectious disease, immunology, infant nutrition, quality in healthcare, and medical education. Dr. Ashwini, sir, welcome on board. Next, we have our Dr. Jaideep Chaudhary, sir, Professor, Department of Pediatrics, Institute of Child Health, Kolkata. He is currently the Vice President, EZ Central Chapter 2019, Chairperson, IAP Infectious Disease Chapter 2020, Convener, ACVIP 2015-16. He also has numerous papers and books to his credit. Welcome you, sir. Sir, with this, the session is open to SBS, sir. Thank you, sir.
Thank you, Krishna. Let me share my screen. Okay. Yeah, is my screen okay and my audio okay, Krishna?
Yes, sir.
Yeah, thank you very much to Dr. Manjula, Krishna, and all others at the Fear Foundation, of course, Dr. Jagdish. We are going to have a very light discussion after a lot of, brainstorming sessions. What are we going to do over the next 40 to 45 minutes? Basically, for pediatricians in office practice, we see different types of practice, different types of fever, different etiologies for fever. but I'm going to narrow down to some different types of fever suitable for practitioners. And then I'm going to put some case scenarios to our three very distinguished faculties, Dr. Ashwini Sood, Dr. Jaideep, and Dr. Ashwat. In these case scenarios, there will always be dilemmas in decision making. Let's see what the experts have to say on it. Let us hear their verdict. And of course, we will summarize and give you some take-home messages. For a pediatric practitioner, if you ask me what are the types of fever you get, student might say remittent fever, intermittent fever, continuous fever, Bell-Epstein fever, biphasic fever, etc., etc., etc. I think all those types of patterns of fever are rarely important in practice. So there are only 4 problems of related to fever that a pediatric practitioner in office practice comes across. The most difficult one is the first and the last. The first is fever without focus, short duration. You may get frightened when there is nothing serious, or you may not react when there is something serious. Both can happen. The easy bread, butter, and jam, short duration fever, most of them resolve. They don't give us much headache. Fever more than 1 week, within 2 weeks, most of us are able to solve it by treating it as enteric fever or scrub typhus, and we get away with the majority. The last difficult one is the PU. These are the 4 types which I thought we should stratify in practice. Let us take the most difficult scenario. In fact, I often find it very difficult to handle any infant or a young child who comes without focus, with a very high temperature. Parental anxiety is very high. You also don't know at times what to do. Let us look at this scenario. 4 months old, fever only for about 12 hours. The mother has documented the axillary temperature with the digital thermometer, 103. No other signs. Birth weight was 3 kg, growing reasonably well, 4.5. Mother has correctly given the correct dose of paracetamol. The fever comes down, goes up, again shooting up. This is a frequent scenario. Now, I'm going to ask Dr. Ashwini Sood to start with. In this scenario, how do you manage, Dr. Ashwini Sood? How do you manage?
Good afternoon, everyone. Am I audible?
Yes, Ashwini.
Yeah, thank you, the Fever Foundation. And this is an interesting scenario. And if I want to say, this could be the number of cases around 60 to 70% in day-to-day practice of all our colleagues. So before I would like to proceed, I would like to know that one is immunization. Second, I would like to know that what is the feeding pattern, whether this baby is being exclusively breastfed or on top feed or mixed feed. And definitely, I would like to know that what has been the activity of this child, because I would like to categorize him fever without toxic look or fever with a stable child, because my further management will depend on this. If a child is playful, he is accepting the feeds, I'll just discuss out with the parents to wait and watch to maintain a temperature diary, give optimum dose of paracetamol that can be repeated as early as up to 4 hours if we are getting a delay response after 6 to 8 hours. And if it is a toxic one, then definitely 4-month-old, I won't take a chance. I'll admit him and send his investigation and start on empirical antibiotic, which we are going to discuss later on.
Okay, now.
And then like to ask them to come after 3 to 4 days.
Okay, now.
If it's a stable child.
Would you admit this child or treat it as OP? See, baby is breastfed, baby except for fever and a little bit of fussiness. Otherwise,
based on his look, if it is a toxic, I will definitely admit.
How will you decide the child is toxic?
That I will look into is hemodynamical stability.
Everything is normal except fever.
Yeah, then I'm not going to admit him. I just discuss with the parents, because most common is we see the viral. And the one thing which I forgot to tell you, I would like to elicit history of viral illness in the family also.
Okay, now I want to ask the others. Dr. Jaideep, what are the common causes you have seen in your experience? Fever without localizing signs. And again, I'll add one more question to you, Dr. Jaideep. Do you have a strict protocol or individualized approach depending on the patient's socioeconomic status, educational status, whether it is the first time they are coming to you or if they are regular patients for you? Dr. Jaideep.
Yes, sir. Good afternoon.
Common ones you have seen in your practice.
Yes, sir. Yeah, good afternoon. Now, can I make a comment about this child that you are discussing also?
Yes, yes.
Yeah. Basically, sir, this child is a 4-month-old infant.
Yeah.
So I will be a bit cautious because of the severe bacterial infection, or SBI that we call, because 30% do present with fever, and an infant presenting with fever, I will be a bit cautious with this child. So first of all, if the fever is documented, if the fever is documented and the child needs observation, it's better to admit the child. But if the fever is undocumented, then we may just ask them to document the fever and come back if the child is looking well and stable. Okay. Otherwise, it's always better for investigation. And regarding the causes of, if you say that in an infant, you mean the fever without focus? Sir, in an infant, the causes you want to discuss?
No, so you also would admit this child. Am I right, Dr. Jaideep?
I will admit this child because
let's move on to Dr. Ashwath. You would admit or treat it as OP, Ashwath? And when
I would
treat it as OP?
Good afternoon. I would probably evaluate this baby before I decide one way or the other.
Yeah, how will you evaluate? What will you do to evaluate, Dr. Ashwath?
So the first thing is it's a very young infant. So bearing in mind the possibility of this child having an invasive bacterial infection or serious bacterial infection, which is what we don't want to miss, I will look at the wellness of the child. Is the child interacting well with the caregiver? Is the child breathing normally? Is the capillary filling time normally? Is the child sucking well at the breast? Is the child passing out enough fluid? If the 3 B's, the behavior, the breathing, or the bleeding, or the blood pressure are abnormal, and be very careful. So for me, the starting point is the wellness or the sickness of the child. Well child, fever without focus, immunized, thriving well, breastfed, appearing happy except for fever, I'll be very happy to evaluate the baby with basic investigations and then take a call on admission rather than admit upfront and scare the parents.
Yeah, I'm happy that I created some controversy with 2 of the panelists saying they will admit and one panelist not agreeing. But then the problem here is that the protocols that are seen in textbooks and guidelines, again, they are not uniform. There is no uniform guideline for fever without focus anywhere in the world. It varies from geographical area to area. But I think all the 3 of the panelists agreed the infant is toxic and his child is having signs of sepsis. Yes, you give the benefit of doubt, admit, investigate, and then give IV antibiotic. In case the infant is not toxic, even if it is not toxic, even if there are no signs of sepsis, if the infant or the young child, particularly below 3 years, is a known case of immunodeficiency, for example, HIV or hypogammaglobulinemia, yes, you will definitely evaluate, do cultures, and probably err on the side of giving IV antibiotic. The infant is not immunocompromised, is over 24 months. Generally, the risk of serious bacterial infection comes down. Then you go by the physical finding. That is where what Dr. Ashwini Sood said, the baby is otherwise well, active, nothing is happening over 2 months, not 4 months like this. then if there are no physical clues, you can even wait and watch. If the child is less than 24 months, you always look for an obvious source of infection. It could be as simple as otitis media, as simple as some paronychia or an abscess somewhere, as simple as something like a pneumonia where you can make out some tachypnea without fever or tachypnea out of proportion to fever. Then you go by the physical findings to manage. No source of infection, then you should look for UTI. In fact, one investigation which probably will be most important is a urine routine analysis. I put here risk factor for UTI. I would say any fever below 3 months is a risk factor for UTI. At least urine analysis routine should be done. In the slightest doubt, you should do a urine culture and treat based on report. And if it is unimmunized, then again, err on the side of investigating and giving antibiotics. Completely immunized, child is well, above 24 months, you don't do anything. This is an algorithm which is practical. In fact, I'm going to ask again Dr. Ashwath and Dr. Jaideep, do you have a strict protocol for this or you individualize? Say it is educated patient, you have a protocol. Uneducated patient, rural patient, you have protocol. Do you have like that? Or first time visitor, you have a protocol? Do you have like that? I'm sorry, sometimes I've seen doctors following that. What's your comment on it?
So since we have postgraduate students training with us, we are very keen that we disseminate some sort of rational concepts and approach to fever in the different age groups. So we teach them again and again to go back according to the pediatric assessment triangle first. If you identify anything life-threatening or if you see abnormalities in the appearance of the baby, the behavior or the breathing pattern, then we proceed with admission, speedily evaluate the child for a probable bacterial source and treat. On the other hand, that's a well-appearing child where the only problem is the fever without focus. After taking history, doing a thorough physical examination, our instruction is for them to stratify according to the age group. This child comes under the age group of 3 months to 36 months, and the child is thriving well. There is no localizing focus. The very minimum, we would require the baby to have a CBC, a urine complete analysis, and a CRP before we decide one way or the other.
Okay.
Physical examination followed by some screening investigations for probable bacterial sepsis.
Okay, now to Dr. Ashwini again.
Yeah.
What do you think are the red flags in such fever without focus or short duration fever, which I think it is our duty to train the parents to recognize? What are the most important red flags, Dr. Ashwini? You tell them that if this is there, you come call me back, you go to hospital, get admitted. How do you advise them? What are the red flags you teach the parents, Dr. Ashwini?
So I'll start from the lethargy which we come across in this age group. That's very common. That's why I try to look into the eye contact to the patient. If there is some issues with the feeding pattern, or if baby is going to be losing the consciousness. In addition to that, if baby develops seizures or abnormal body movements, or there is appearance of rash, as we are seeing a number of patients these days, and as you rightly pointed out, whether fast breathing, and in fast breathing, if it is going to be the distress of which extent, then decrease urine output, and if there is any discoloration of sclera, jaundice, and in addition to that, if a baby is not accepting the feed at any time, even a single feed miss, 4 months old, I would like to tell them to rush to the hospital in the emergency.
So do you give any temperature point as a red flag to parents? Do you give any age as a red flag for fever, Ashwini? So I have specifically not mentioned here, but I want to ask you.
Definitely there are two issues. One, we definitely tell them to record the temperature, put a time, and also mention the dosing, because they need to be sure regarding the complete dosing of paracetamol. Plus, because we all know that if it's definitely a fever without focus, because as my co-panelists were discussing, that we have excluded urine abnormality. We have looked at ear is normal. There is no other sign right now as we just only fever. Then at least I can safely wait for 72 hours if this baby is feeding well.
Okay. If it's a neonate, you will always ask them to go to hospital. Am I right? If they call you over phone, the document.
And if a neonate comes to me less than 3 months, I am not going to let him go back to the home. I'll admit him and watch him for 2 to 3 days.
Do you have any temperature point at which you would say you go to hospital? Because most of the parents will call you. Her temperature is 103.5. Will you tell them?
Not like that, because we try to look into that how much paracetamol they are giving, and then as I was sharing with you, we can reduce the interval because some babies may only need paracetamol another dose after 4 hours even.
Okay. Now let's move on to our breadwinner, short duration fever. 2-year-old fever for 3 days. The fever is going up. Severe cough and cold, parents visiting you daily, they are a very anxious, precious child, and paracetamol, cetirizine, and some saline nasal drops. How often do you give antibiotics in such a situation? And rising trend, day 3 fever. How often will you consider giving antibiotics? And when will you give antibiotics? Dr. Jaideep.
Yes, sir. 2-year-old fever for 3 days. Important point is rising trend. Now, most often the viral fever starts with very high fever, then it persists for 2 to 3 days, then it usually shows a falling trend. Number 2, cough and cold are not very specific. Definitely, this child needs an upper respiratory examination, including an otoscopy. Or if there is obvious ER discharge, then it's okay. Third is regarding the respiratory system. So empiric antibiotic for 3 days fever, even if rising trend, it's no. Because without any other focus other than cough and cold, it's likely to be a viral fever and we can wait for 5 days. But of course,
even if it is mucopurulent discharge, day 3, will you consider antibiotics or not consider?
That's what I am coming. Of course, if there is any ER discharge, if there is mucopurulent discharge, or if there is some findings in the chest like crepitations, then definitely I will start antibiotic because it's a rising fever beyond 3 days.
Okay. Now to Dr. Ashwath. Dr. Ashwath, you are a very seasoned practitioner in Coimbatore. When do you give antibiotics in your practice empirically, either with investigations or without investigations, without waiting for investigation reports? And how often do you do that? What are the classic examples in which you would give antibiotics, say, without investigations for fever? Or you send some investigation and start antibiotic. Can you give examples as well?
Sure, sir. I think there are 2 issues here to be considered. When there is a choice of empirical antibiotics for fever, one is the probability of this disease being a bacterial infection should be high enough to justify antibiotics. 2, I have to give antibiotics upfront even without waiting to confirm the cause, which means there is an element of urgency. So when is it possible? If the classical clinical features are very consistent with a presentation. A child comes with fever, the child has odynophagia, dysphagia, the child has a toxic appearance, tender cervical lymph nodes. I can see a membrane on the tonsils. I would not do any investigations. I'll probably initiate amoxicillin at 50 milligram per kg. Here the diagnosis is obvious. I need not do any investigations in a run-of-the-mill case. 2, if there is a high probability of a bacterial infection, but the child is in an immunocompromised status where waiting would be dangerous. Let us take the example of a child who's an acute lymphoblastic leukemia patient who's currently on chemotherapy. Now, I know that this child is on chemotherapy, the child is likely to have a febrile neutropenic sepsis. In this situation, I would probably draw blood for cultures, urine counts, and then start antibiotics because of the potential for harm is more if I wait. Third, if a clinical situation, let us say the example of a child who is recovering from measles, If the child is brought with respiratory distress and the child has got focal or generalized respiratory findings, I'm almost always going to err on the side of antibiotics because I think it's a post-measles bronchopneumonia. These are just some examples where I would give antibiotics after drawing investigations or probably even without investigations.
Excellent, excellent. Very rarely only we actually resort to investigations in office practice for antibiotic. For example, as Ashwat mentioned, if there is an abscess, if there is acute bacterial tonsillitis, you don't even have to do any investigations. You can give antibiotics straight away. Otitis media, we don't do investigation. Some diseases like UTI entry fever, we ask for tests, we start antibiotic, wait for the confirmation. And as Ashwat said, febrile neutropenia, that's not often seen in practice, but you have a child with tachypnea suggesting pneumonia, meningitis, then you're going to admit, start antibiotic where waiting is dangerous. Some situations, you don't even ask for proof. Acute suppurative tender lymph nodes in the neck, softening. You're not going to get proof. You're not going to do aspiration, then start antibiotic. You're going to start antibiotic. Abscess, you're going to start. And as rightly pointed out by Ashwat, measles, fever goes beyond 7 days, 8 days. Secondary infection, pneumonia. Chickenpox fever more than 4 days might indicate soft tissue infection. And last but not the least, you have dysentery, blood in the stools, fever, tenesmus, sick child. You're not going to ask for stool culture and wait for the results before starting antibiotic. Let us move on to Dr. Jaydeep. Jaydeep, this is a child with fever for 1 week, 5-year-old. Parents have given azithromycin for 3 days, cefixime for 2 days on the advice of a GP. Child is not getting better. Counts are 5,500, platelets normal, CRP 24, urinalysis normal. What do? Do you give antibiotics or no? Or you will say you can wait, child is not sick. Or if you decide to start antibiotic, what is your choice of antibiotic? Jaydeep.
Yes, sir. It's a fever for 7 days. So we cannot take it lightly because this fever is there for 7 days. The problem is that the child has taken azithromycin for 2 days. We are not sure about the dose. Usually it's a low dose that's given, and cefixime for 2 days. So 2 days cefixime will not serve much of a purpose, and particularly we are not sure about the dose. And 3 days azithromycin also is probably inadequate if we are thinking of, say, typhoid fever or something else. The child is not getting better. Total count is around 5,000, which is also low. Platelet is normal, CRP 24, urine normal. So what to do? Point is that this is a fever of unknown origin, as we say by definition, and it's also persisting for 7 days. Though the other causes like rheumatological malignancy and all we have to keep in mind, but most commonly and most probably this is a infection. So we have to do a good blood test, including the complete blood count, a bacterial culture. That's very essential. A chest X-ray is essential at this point of time. And
no respiratory signs, will you ask for an X-ray?
Yes, sir. Still we will, because it's a fever is persisting for more than 7 days. And at this point of time, we might think of doing a sputum or a gastric aspirate for AFB also, if we have any doubt. And then if we start an antibiotic, that should be an oral azithromycin, because the child is still not that sick that the child needs an injectable antibiotics. But investigation for infections has to be done and has to be complete at this stage before we jump to anything else.
Ashwat, your action at this point of time. You want to agree with Jaydeep, or I'm trying to create a divide among the panelists?
Yeah, Dr. Bala.
No, I think
the lighter vein.
Yeah.
Yes, Ashwat.
Definitely, the child needs to have a relook. Going back to the history physical examination, as Dr. Jaydeep said, the cefixime duration is too short for us to draw any conclusion as to whether this is the appropriate antibiotic or whether this dose is appropriate for the clinical illness. So these are the things. I'll revisit the history, reassess the child with physical examination, and then take a call whether I need to continue with the antibiotic.
Okay, the same child,
Dr. Bala.
Yeah, 1 minute. The same child, the parents show you a temperature chart, that the temperature over the last 7 days, maximum temperature has been 99.24 times once a day. What do you do, Ashwath?
I think I'll stop the antibiotics.
Absolutely. I think that's what of course, Dr. Jaydeep clearly mentioned, but I wouldn't do anything for this child. First thing is to revisit, ask them for a temperature chart. I can tell you 9 out of 10 cases, there won't be any temperature chart at all. They will say high fever, and fever would not have been checked even more than 2 or 3 times a day. Child will be playful. I think the best is that temperature chart before you go into it. Of course, if you have documented pyrexia for 7 days, there's absolutely no doubt you investigate. And in this child, Dr. Jaydeep says you start azithromycin. What is your choice, Ashwath?
So not azithromycin, I told amoxicillin.
Amoxicillin. Why amoxicillin for what?
No. If the child has any
So what are you trying to cover with amoxicillin for 7 days?
First I told that antibiotics should not be continued and do all the investigation.
Absolutely.
Now, if at all we find some focus, like say the low total count, the CRP is borderline, if we at all have to start any empiric antibiotics, then it has to be amoxicillin and not azithromycin or cefixime. This was my
amoxicillin for 7 days fever. I don't know. The Ashwath and
investigation is the first step. Investigation is the first. That's what I meant.
Okay. Let's move on to the fourth case before we enter into further arguments. This is a 10-year-old child who has fever for 2 weeks. Unlike the previous one. Actually, previous one, I can tell you, the temperature chart showed 99.4 for 4 days. I stopped everything. Next day, child was febrile. No antibiotics were given. The moral of the story, always check the temperature. Okay. Case 4. This is documented fever for 2 weeks and treated at several places, multiple antibiotic, only 5. Cefixime, amoxiclav, okay, 2 days of doxycycline, and then ceftriaxone for 3 days and quinolone, all for 3-4 days, hospitalized. And Dr. Ashwini, what will you do for this child? 2 weeks fever, multiple antibiotic. You have a lot of investigations, nothing is conclusive. How will you proceed? Dr. Ashwini Sood.
The first will be to look into as you rightly pointed out, that we will try to look into the fever.
Please go ahead.
What happens? Parents say that there's a fever for 2 weeks and you admit for a day or so. There's not even a spike of fever. Secondly, I do try to do a physical examination and try to look for the localization of, if I could get localization, starting from sinus tenderness, lymph node involvement, hepatosplenomegaly, or any other lymph nodes. I try to look into, or is there any rash. It's important in this patient because this patient has been given 4 sets of antibiotics. So I would like to correlate this illness to a particular time.
I think Dr. Ashwini's connection is good.
Sir, can I just make a comment on this?
Yeah, please go ahead, Jaydeep. Yeah.
Sir, it's a prolonged fever. One, we have to take the history of a good temperature record, whether the fever was persisting or whether it was small episodes of fever, 2 to 3 or 4 days duration. In between, the child was well, going to school, again developed fever. So these type of short duration fevers, which the parents often coalesce and make it a long duration fever, is usually due to recurrent viral infection that they acquire from school.
Okay.
If the fever is documented and persisting for a long duration, then definitely along with the medical history, a routine examination, definitely a CBC smear, as you are showing in the algorithm. But one thing, my personal preference will be to do a chest X-ray and a sputum examination for tuberculosis ahead of any other investigations like USG or rest. And the tuberculin skin test I will not do. That I will not do, but rather I will go for AFB CBNAT. So this is, I think, and then sir, that's all.
Okay, Ashwath, how do you have admitted this child, Ashwath, 10-year-old, and you decided to investigate? What is the protocol you follow in your practice? Ashwath? Hello?
I think he's also not there. You please continue, sir.
Ashwath, his connection is lost?
Yeah.
Okay. Okay. I think what Dr. Jaydeep said is extremely important. First is you check the temperature records. Second is to take a good history. In fact, many a time when I admit a PU in the hospital, I ask the junior most postgraduate to take a good history for about 45 minutes and I sit down and check. That's what you should do. Then, of course, complete examination from head to foot, lymph nodes, as somebody fundus examination, blood pressure, pulse check, everything has to be done. Of course, the basic ones are a complete blood count, peripheral smear, and of course, urinalysis, perhaps urine culture also. Blood culture is very important. Manto, older child is of less value, but if it is going to be positive, then it could, you can start targeting for tuberculosis, X-ray chest, ultrasonogram, liver function, and renal function test. In fact, having done all this, do you start antibiotics, Dr. Jaydeep?
Dr. Ashwath has joined.
Start antibiotic and which antibiotic you choose? PU, 3 weeks, like I mentioned here, this is 2 weeks fever, 10-year-old, absolutely nothing localizing, documented fever. You have done these tests and everything is borderline. Culture is awaited. What do you do?
An admitted child, if we do not find any focus and we have to start an antibiotic, then the first line should usually is ceftriaxone. But again, I would stress on the fact that if the fever is persisting, definitely all out effort should be there to determine the cause of fever, including tuberculosis, including tubercular meningitis that we have to think of. And beyond that, the non-infectious causes of fever should also be explored. Considering all the fact that, yes, if we have to start an empiric antibiotic, 10-year-old ceftriaxone will be the antibiotic of choice, but 100 milligram per kg, because otherwise, even if it's a clinical typhoid fever also, 100 milligram is the dose.
Would you add doxycycline or will you give ceftriaxone alone? Ashwath also.
Definitely scrub IgM I will do. And usually a scrub typhus patient, fever for more than 7 days usually becomes very sick. And if the child is very sick, then an empiric doxycycline is worth considering, because scrub typhus may deteriorate very fast. But other than that, if a stable child with the investigations ongoing and if the scrub IgM is negative, I will not start doxycycline because usually the sensitivity of scrub IgM is quite high, and specificity also.
Yeah, once you do a blood culture, I think you can be questioned in a court of law if you don't start antibiotic. Once you have suspected an infection, if you don't do blood cultures, you are very confident this is non-infectious, then it is different. Once you have done a blood culture, I think it is legally probably not appropriate if you don't start an antibiotic. And most of the time, based on epidemiological data, you decide on starting doxycycline or not. Dr. Ashwini Sood had prepared this chart. Unfortunately, he couldn't join. But I will just sum up what is here. Basically, when you have fever for 4 weeks or more than 4 weeks, you have only 4 groups. One is infection, infection, infection. Second is inflammation, non-infective inflammation. You are vasculitis and collagen vascular disease. Third is the malignancy. Fourth is miscellaneous. So basically, you start working towards infection. And this is where, other than blood cultures, depending on the finding, like lymphadenopathy, if you find you do EBV, you do HIV, and you start suspecting bone pain is there, you start suspecting leukemia, do a bone marrow, Brucella antibodies. Okay. If there is a lymph node, you start considering a connective tissue disorder or a malignancy. Look at the peripheral smear. Of course, bone marrow is a must, particularly in these days. When you think of MIS-C, you always tend to start IVIG and steroid. I think in such situations, you have to consider bone marrow for PU. Lymph node is accessible, you can do a biopsy and you can target the diagnosis. And of course, once you start thinking of a rheumatological disorder, you are going to ask for vasculitis test like ANA and your dsDNA, etc. And there may be clues like a low CRP and a high ESR, which could suggest in an adolescent female, particularly if there is albuminuria, multisystem manifestation, SLE. So your workup should be multidisciplinary, trying to rule out infections first, quickly ruling out malignancies, and looking at the possibility of autoimmune disorders. I think I'll ask some open question. I don't know if Ashwath and Ashwini are there. Jaideep?
I'm here, sir.
Ashwath is here.
We'll start with Dr. Ashwath. Dr. Ashwath, do you use NSAIDs for fever? When do you use it? What NSAID do you use it? And how do you use it, Ashwath?
So I use primarily NSAIDs when there is a strong inflammatory component to the fever, sir. Like, let us say it's a septic arthritis or an osteomyelitis, or there is a tender cervical lymphadenitis. I would prefer ibuprofen over paracetamol at the dose of 10 milligram per kg thrice a day for 3 to 4 days. Once the pain is inflammatory signs are down, once the abscess
I'm not asking for anti-inflammatory effect. I'm asking for fever, antipyretic. Do you use NSAIDs, and what NSAIDs do you use?
I use NSAIDs for fever, mostly for non-infectious fever, sir. So if it's non-infectious.
And what is your preferred NSAID?
If it is juvenile idiopathic arthritis, I would use naproxen, sir.
Okay. Dr. Ashwini, do you use NSAIDs for fever? I think he's not there.
We lost him again.
Jaideep?
For fever, no, it's paracetamol only for fever. But I totally agree with Dr. Ashwath that if it's an inflammatory fever, then the question is different. Then we have to go definitely for NSAIDs. But for fever alone, paracetamol, because our main target for fever, not the inflammatory condition, is not to bring down the temperature, but to make the child comfortable. So paracetamol and as on when required, other physical measures.
Do you use mefenamic acid, Ashwath or Jaideep?
No.
I don't even know the dose, sir.
Dose. Okay. Let me be very honest in telling you.
Yes.
I do use ibuprofen above 6 months of age for fever, not routinely. Okay, not routinely. If I know my patient well, patient is a very, very otherwise well child, okay, and they already have some ibuprofen, and they ask me whether they can give ibuprofen for fever or not, above 6 months. Only thing is I use a lower dose, 5 milligram per kg. In fact, if you look at the dosage of ibuprofen, it's 5 to 10 milligram per kg, only 6 hourly. Only for anti-inflammatory effect, you may have to use a high dosage of 10 milligram per kg. For antipyretic effect, it's 5 milligram per kg. Only thing is, I may not use if there is the slightest suspicion of dengue. And I don't prescribe if the parents already say that after fever, the child's intake is very poor for fear of gastritis. At the same time, if you look at literature, ibuprofen is as safe as paracetamol. It's not a dangerous drug. In fact, there is enough information that even in asthmatics, even in atopics, ibuprofen is not contraindicated. It's tolerated as well as paracetamol, except for longer duration of action. It has not got many benefits over paracetamol. And I always prescribe ibuprofen in parents who are paranoid about fever, whom in whom I am worried they may end up giving too much of paracetamol and produce toxicity. Right? Okay. Now, regarding naproxen, naproxen is a much safer amongst all the NSAIDs. Naproxen is perhaps the safest NSAID in terms of renal effect, but it's not used for fever. It should not be used for fever. Mefenamic acid, I'm afraid it's not a good drug at all. Now to Ashwini, if he's there, or to Ashwath. Do you advise tepid sponging at all? Ashwath? Ashwath?
No, sir.
No.
The answer is a big no, sir.
You never advise tepid sponging?
No, sir. Advice to the contrary, always.
Okay. What about Jaydeep?
Yeah, I do advise, especially for older children. I do advise.
When do you give them? When do you give it? What advice do you give?
Yeah, because usually the viral fever, what happens if we advise paracetamol every 6 hours, after giving paracetamol within 2 to 3 hours, the fever starts to rise. Then the parents are very anxious and they go for a shorter interval and also higher dose. So I usually counsel them, when I advise paracetamol, I usually counsel them that if a fever recurs in between the doses, then you can initially start with the tepid sponging, wait for 6 hours, give the next dose.
How do you ask them to do tepid sponging correctly? Jaydeep?
Normal tap water, use normal tap water.
Tap water in December may be 20 degrees temperature. Will you use that in Delhi or even 40 degrees?
Yeah.
Chennai tap water will be 30 degrees.
No, I always advise the water should not be very cold. So that's a normal room temperature is around, say, 30 degrees, but that's 30 degrees. I do not mention at all.
Which patients you select? Which patients you select for tepid sponging, and how do you categorize?
See, infants, they will scream if the tepid sponging is done. But in an older
child, why give at all?
Child again with high fever coming at very, yes sir.
Yeah, go ahead.
Yeah, children above 1 year, when the fever is recurring at very short interval, then the tepid sponging helps and it keeps the parents engaged also.
Okay, Ashwath, why you are not using tepid sponging? Why you are not using tepid sponging? But I have again created a division. Dr. Jaydeep appears to favor tepid sponging. You are not favoring tepid sponging. Ashwath, your comments.
Sir, as we understand, temperature is basically elevated because of resetting of the hypothalamic thermostat. So by tepid sponging, I am bringing down the skin temperature. I am not bringing down the core body temperature. So core body temperature is what makes the baby child uncomfortable, and the child's risk of seizures or the metabolic demands are driven by the throttling. At that burning temperature, the water will evaporate and produce a transient drop in the skin thermometer temperature. The core body temperature is uninfluenced, and people who have had sponging, I have personal experience, it is extremely uncomfortable to have somebody apply a wet cloth on you when you're burning inside.
Yeah. I agree with Ashwath. Tepid sponging, I would say, yeah, it's non-pharmacological management. Yes, you should encourage. But I think there are a lot of problems in doing tepid sponging. One, it's very difficult to teach parents how to do tepid sponging correctly, starting from the temperature. And more importantly, you should do tepid sponging after a dose of paracetamol when the fever is coming down, not at the height of fever. When there is a rigor, if you put a cloth on the child, wet cloth on the child's rigor will worsen. Actually, it will have more discomfort. Third is that young children don't tolerate. Fourth is that parents really, in their panic, they really lose their cool. They don't do it correctly. In fact, I have known a doctor who used to go and keep the child in the shower whenever there was fever because of fear of febrile seizures. I think with all these caveats, that there have been a lot of debates, and the final consensus is that tepid sponging, though beneficial, is not recommended. In fact, if you go to the NICE guidelines, please do not do tepid sponging. That is what has been given. But if somebody wants to do tepid sponging, say non-pharmacological management, you don't want to give drugs at all, you want to be a naturopath, then in that case, you must advise tepid sponging correctly. Now to Dr. Ashwath again. Ashwath, do you treat fever differently in children with febrile seizures? You know, The parents with febrile seizures are a very, very worried lot. Fever means it is panic. Do you treat the fever differently?
So you said it rightly. I think more often than the child is the parents who need clobazam. I think they start going ballistic when the temperature doesn't come down and there's a demand for antibiotics or more powerful medicines than the tried and trusted paracetamol. I think I take the time out and tell them again, sit with them for 5 minutes and explain to them that it's a bit of a fatalistic view, if you want to say. A child who's going to have febrile seizures will have febrile seizures no matter what you do. So the height of the temperature is a very poor predictor of the chance of recurrence of a seizure, first time or a recurrence. So I would tell them, please give paracetamol, make the child comfortable, and if the child convulses, don't panic, wait for 5 minutes and use an intranasal midazolam spray and stop it. Just because the child has got febrile fits, I would not advise ibuprofen upfront or cycling paracetamol, ibuprofen, or still worse, give ibupara fixed dose combination or give mefenamic acid.
Okay. What about temperature chart, Jaideep? Do you have one temperature chart which you give to the parents when you have child with fever in front of you for home monitoring? And when do you give? Do you give it routinely? And what is the temperature chart that you use? The hospital charts are very confusing. Dr. Jaideep.
It's a simple temperature chart. The time and the temperature, definitely try to give to all the parents. Most of the parents are quite educated and they can do it. And of course, with a column which mentions that when they are giving paracetamol, that also shows me the duration, the interval, and also at what temperature they have given. They should not give below 100. So definitely I do advise that simple temperature chart.
Do you give it routinely or only in selected cases?
I ask in 90% patients.
What about Ashad? What about Ashad?
I would not do that routinely, sir. I'll ask them to keep a track of the paracetamol dose. For each and every child, I tell them what is the maximum permissible dose and put 15 milligram lower than the maximum dose. So even though the textbooks say 50 to 60 milligram of paracetamol is fine, because in their parents, I believe that in their panic situation, they will tend to overdose. I tell them don't exceed 40 milligram per kg paracetamol, come what may. I said, if you're very anxious, you admit the child, keep him under observation, but please don't overdose. That is what I would say.
I have a temperature chart. I'm not showing it. I give a temperature chart where I ask them to measure 6 a.m., 10 a.m., 2 p.m., 6 p.m., 10 p.m. And I generally advise them if there is any distress or the temperature goes above 101, if you are worried, you give paracetamol. And I tell them not to give more than 5 doses of paracetamol. I usually ask them to give 10 to 15 milligram per kg of paracetamol. And my temperature chart actually contains the warning signs which I showed in the earlier slide. One last question.
So Dr. Ashwini sir has joined, sir.
Yeah,
Ashwini sir has joined. Ashwini sir has joined. Ashwini.
Join. Yes, we will start with Ashwini. Ashwini, please give an example of an unusual case of fever from your experience. And that's my last question to the panelists before we give the summaries. Yes, Ashwini. Some unusual case of fever. You must have seen lots and lots.
We had one 5-year-old girl, and the history was very different one, that she will have swelling of the elbow joints, and some antibiotics were given every time with fever, and that will respond, and in between she will remain well for 3-4 weeks. So she landed us with around 8 courses of antibacterials, and we got admitted her and studied a fever pattern. The fever was used not to be beyond 102 degrees, and when we started working up, it turned out to be a case of tuberculosis of thyroid.
Oh, very, very. Okay, what about Ashwath? Some unusual case before you wind up. Ashwath and Jaideep, one each.
So last month we had a child, 4-month-old child, sir, was brought with history of fever, pain, irritability on moving the left lower limb. So when we did the examination, the mother said after all the trouble started after the 3rd dose of the pentavalent vaccine, which was given at the primary health center. So what we saw was diffuse redness thigh region. There was diffuse erythema of the lower limb, and the counts were very high. The ESR was high, the CRP was high. There was a brisk thrombocytosis, and the X-ray showed a good periosteal reaction. So we did an ultrasound to see whether there was any subperiosteal collection, and to our dismay or surprise or pleasant surprise, the ultrasonologist has said that this is a subperiosteal collection. It looks like a osteomyelitis that is bursting through subperiosteal abscess, and please take up the child for a surgical debridement. When the surgeon went inside and saw there was hardly any pus, and the cultures was negative, and the child did not show any response to ceftriaxone cloxacillin even after 72 hours. So we went back to the pathologist and asked them, can you please process a sample further faster so that we have a quicker answer? It turned out to be Caffey's disease. Till that moment, we didn't know that it could affect in the thigh asymmetrically. We've always been looking for it in the clavicle, the scapula, and the mandible. So that was a surprise.
Okay. Jaideep?
Again, it was a 5-year-old girl who was having fever for 2 weeks. Initially, oral amoxiclav was given, then I was admitted in another hospital on day 8. And the report was hemoglobin 10, the total count was high, the CRP was high, platelet was high. And the chest X-ray from outside shows some streaky shadows. Now, the child did not respond after 4 days of antibiotics. Then chest X-ray and blood test was also similar. There was no evidence of TB. USG was done. There was hepatomegaly, and the fever continued. So then the child was referred to our hospital, and many other investigations was done. Along with that, a CT chest was done because the child had some respiratory complaints, which again showed the streaky opacities. Now, at this point of time, which the parents did not reveal previously, that there was history of intermittent painful nodular skin lesions previously. And 2 times the child had blood-streaked sputum also. So then the child was investigated for non-infectious causes of fever. The P-ANCA, C-ANCA were negative, ANA was negative. Bronchoscopy was more or less normal anatomy. In between the nodular lesions in the shin recurred. So skin biopsy was taken and it showed vasculitis. So ultimately the diagnosis was ANCA negative small vessel systemic vasculitis, which are quite rare, and this was published also.
Okay. Now, in fact, I thought I should share one case which was discharged yesterday in my unit. This child had all features fitting in with EB virus infection. Had exudative tonsillitis, generalized lymphadenopathy, splenomegaly, upper airway resistance syndrome, mouth breathing, periorbital edema, lymphocytosis. But then outside, dengue, NS1, and IgM both were positive. He had lymphocytosis, mild thrombocytopenia. We repeated the dengue NS1, that was also positive. We confirmed it is EB virus infection. Simultaneously, child had features of both dengue and EBV, dual infection. That we are trying to look at false positivity of NS1 and IgM. NS1 false positivity doesn't occur in EBV. Well, IgM antibodies positivity can occur in other arboviral infection, malaria. So that child, of course, we did not give any treatment other than symptomatic measures. Child is better. So to summarize, I think my panelists would definitely agree that somebody was joking. Somebody was joking recently. Some student was asked, what is the most common symptom of COVID-19? He said fever. Then the lecturer corrected, it is not fever, it is fear. Fear is the commonest outcome of any fever. I think we should treat fear rather than treat fever aggressive as a symptom. There's no point in trying to read those numbers 103, 104 and give antipyretic after antipyretic. Like the
Dr.
culture of culturing. Yeah.
Dr. Bala, before you take the take-home messages, I have 2 observations which I would like to have your comments. Now, should we stick again the definition of 3 weeks of fever for pyrexia of unknown origin after every investigation? Because now few of the publications say that you stick for 7 days.
It doesn't matter at all, Ashwini, whether it is 3 weeks or 2 weeks. If you have done the basic workup, if you don't have a diagnosis, you call it FU or PU or prolonged fever, it's not going to make any difference. Your approach is not going to change just by labeling it as PU. Your approach is going to be same. I think that's all semantics. It doesn't matter at all if you ask me.
And secondly, as a pediatric practice point of view, we should not talk about those fever. They are all like all different types of fever. They are classically seen only in adults, and I think we should take away that teaching.
Absolutely, absolutely. That's correct. I think like the culture of culturing for typhoid fever and for urinary infection, the culture of temperature charting needs propagation. I think parents should be asked to be taught to record temperature correctly and document it correctly, and we should give them the warning signs. I think we should say a strong no to tepid sponging. In fact, tepid sponging in children with febrile seizures or without febrile seizures, I think has no place. Paracetamol or ibuprofen as a single drug is a good antipyretic. We don't have to treat aggressively. We have to treat the discomfort of the child rather than the temperature chart. Fever without localizing signs, as you could see with the differences among the panelists, is always, the Western protocols are very difficult to follow in practice. You have to individualize, but you should not miss serious infections, SBI. It's a medical emergency in infants, particularly below the age of 3 months. And I would say, I'm sure all of you would agree, UTI is the most commonly missed and messed up cause for short duration fever. An empirical antibiotic therapy, as pointed out by my panelists, in office practice for fever is rarely required as an emergency. And wherever it is required, you should do appropriate investigation, start the therapy correctly. If you follow the correct approach, there is no way you can go wrong. Finally, let us hope that with the discussion for 2 days, fever will lay a strong foundation everywhere for a national approach to fever, thanks to Fever Foundation of India. Thank you very much. Over to the organizers.
Thank you, sir. Thank you very much for the wonderful moderation for the panel discussion. And thank you, Ashwath sir. Thank you, Ashwini sir, and thank you, Jaideep sir, for the comments and clinical pearls. We are getting lots of comments in the chat boxes and everyone appreciating for the clinical pearls which you have been giving in the last 1 hour, sir. Thank you very much, sir. And over to Dr. Jagdish Sinappa, sir, for the comments.
Thank you very much. And today has been a wonderful day. We started off with, some little esoteric topics, but then came down to what is the basic things that every pediatrician should know about fever. And thank you very much, Dr. Balasubramaniam and team, Dr. Ashwini, Dr. Ashwath, and Dr. Jaideep, for clarifying all those simple things that everybody needs to know. Over to you, Krishna.
Yes, sir. Thank you, sir. And it's over to Mr. Praveen Singh for the valedictory remarks.
Krishna, Dr. Yagnesh sir can say before he goes to the one minute.
Fine. It was a wonderful experience, madam, for 2 days. And we learned a lot from the giants of ID chapter, both pediatrician as well as physician. We started with Dr. Suresh Kumar today morning. He was excellent in his presentation and ended with Dr. Balasubramaniam again, another expert from ID chapter. Congratulations to the whole faculties for their wonderful presentations and sparing the valuable time for all of us. Thank you, everyone.
Yes, thank you.
Thank you, sir.
Over to Praveen.
Yeah. Dear sir, ma'am, good afternoon. And before I go for valedictory, I wish to say that, completing a year in any relationship is a milestone. However, traditionally, a 5th anniversary is considered as first of the big milestones. I thank all of you immensely, all the clinicians in the audience, postgraduate students, faculty members, advisory board members of Fever Foundation of India, organizing team members for establishing, nurturing FeFCon for last 5 years. I thank the attendees for believing in FeFCon and investing your precious time in attending the conference. I'm sure the learning will help in better patient management. I thank all the faculty members for delivering lectures in the interesting, easy to understand, and most importantly, something that is useful in day-to-day clinical practice rather than just a textbook lecture. the advisory board members of Fever Foundation. Sir, ma'am, without you, FeFCon wouldn't have seen these glorious 5 years. No amount of thanks would be enough to justify your contribution, not just for FeFCon, but also for healthcare practitioners across the country. Thank you, beloved advisory board members. The GC Surana oration has been one of the highlights of FeFCon. This year, the orator is one of the most knowledgeable, respected, and is a reference guide for most students of medicine. This is what the students told me. I'm not making it. This is what the students. In fact, sir is the Wikipedia for most of the students. And not just the students, but also for practicing pediatricians across India. Jagdish sir, thank you for the oration. I am sure that the oration will be a benchmark in the coming days. And we are blessed to have you around us. Sir, thank you very much. I wish to thank Dr. Manjula, convener of Fever Foundation of India and the backbone of FeFCon 22. Madam, your energy and commitment is unparalleled. Thank you for churning out such wonderful scientific feast year after year, month after month, month after month. Dr. Krishna Kumar Iyer, sir, the silent slogger, what I call the silent slogger behind the scene, has been a great support and the driver for Fever Foundation. Sir, we definitely recognize all the hard work that you have put, not only the hard work, the sacrifices that you have done. For example, the last night's sleep that you have missed to ensure 5 successful years of FeFCon. Thank you, Krishna Kumar, sir.
Thank you.
Dr. Ignesh, sir, then Dr. Balasubramaniam, sir, Ashwin, sir, thank you so much, for enlightening all the audience with such wonderful practical pearls. I would like to call it as practical pearls. Finally, the organizing team, spearheaded by Chief Organizing Secretary, Mr. Jairaj. Sir, thank you for driving the entire team to deliver seamlessly. Without your guidance, FeFCon wouldn't be what it is. And finally, the unsung heroes in the field who ensured a record registration of more than 50,000 clinicians for FeFCon 22. So this is one of the things that it's not about just registering doctors. The efforts of each and every one, the faculty, the advisory board members, the organizing committee, it reaches to 50,000 doctors across the country is not a small thing. So in that, we have created a record of sorts. I'm sure many agencies will now start giving record for us for having created such a big record. Thank you. Thank you to the field force who have ensured 50,000 plus registrations. Then thank you, RX team, for streaming the sessions. And now I look forward to see you all in FeFCon 2023. And please do take care of yourself, sir and madam. You are precious not only for Fever Foundation, not only for your family, but also to the community at large. Sir, thank you very much. We are blessed to have you.
Thank you all. Thank you.
Thank you. Thank you.
Praveen, it's a challenge to you. Next year, you have to have more than 60,000 now.
Yes, sir.
That's the biggest challenge. So you have to work on that.
Yes, sir. Sir, you all have made FeFCon Fever Foundation so it's a benchmark now. So with, having you all delivering lectures. हम जब बोलते हैं कि अश्विन सर ने एक लेक्चर दिया, बाला सर SBS सर ने दिया, हमारे साथ जगदीश सर है, हमारे साथ मुरुगनाथन सर है, डॉक्टर इग्नेश है, चेतन त्रिवेदी साहब है. Moment we say your names, they all kind of they say that ठीक है, अच्छा ऐसा है क्या, and all those things. So we are blessed, sir. We are really blessed.
Yeah,
and
absolutely.
Next year,
right.
50 plus registration, we will definitely work on that, sir.
Thank you.
Thank you. Thank you.
Thank you all, sir. Thank you all. Namaste.
With this, we've come to the end of FeFCon 2022. I'm sure that you enjoyed the 2 days as much as I enjoyed hosting it. Thank you so much, everyone, for joining us in this journey of learning and growing and interacting. We will see you in FeFCon 2023. Please stay healthy, stay safe, take care.
RX team live streaming can be stopped.
Yeah.
No, still live.
Streaming.
Both are there still.